begin the talks at 10 o'clock. Taswala, sir.
Yeah, very good morning. I think this is one of the best CMEs which has been organized by the Bombay Ophthalmological Association under the aegis of MOS. And Dr. Swapnesh, as you know, is a VR surgeon. So his favorite topic is taken it and is structured it so nicely. I was just going through the two sessions. The star faculty, a galaxy of stars in VR surgery we have with us. So I am sure everybody, the common ophthalmologist and the general ophthalmologist is going to have lots of pearls of wisdom and points, go home messages to take. So I declare the session open and hand over the mic to Dr. Swapnesh Sawant for further proceedings. Thank you very much. Wish you all the best for the webinar. You're muted. You're muted.
Dr. Joshi, sir.
Rajesh.
Yeah, good morning, one and all. I thank BOA for giving this opportunity to MOS to hold this webinar under its aegis. Many thanks to Lahani sir, Chief Advisor of BOA, Advisor of MOS, Ragini Madam, Chairman Scientific Committee of BOA and MOS for guiding every time. Dr. Pritam, Dr. Swapnesh for all the help. Experts, Dr. Natarajan, Dr. Atul Ursekar, Dr. Vatsal Parikh, and for all the presenters. I'm sure today's webinar will be helpful to everyone. Thanks to Bayer for the technical support also. Thank you so much. And Swapnesh for further proceedings.
Welcome, Dr. Pritam Saman.
Hello, sir.
Yes, sir.
Hi.
Pritam, sir.
Good morning, Dr.
Yeah.
Pritam.
Yeah, thank you so
Pritam.
much. I think first of all, the gratitude to Swapnesh because he has single-handedly
Yes.
organized this CME, both on the academic front as well as on the logistic front. So I usually we do the thanking at the end, but I'm doing the thanking in the beginning. My thank you to Sai Numerotech because he's always been there to support us. So a big thank you to him and his team. And Dr. Rajesh Joshi was thanking BOA for giving MOS a chance, but that shows his humility. It should be the other way around because MOS is the parent here, and we thank from BOA. I would like to thank MOS for giving us the chance. And the Dr. Jignesh Taswala sir, welcome. So
Yeah.
nice to see you always. Your energy is tremendous. The tremendous energy that you have infused in MOS over the last few months, you and Dr. Rajesh, is just amazing. You're setting new bar and new goals every day. So thank you for that. And
good morning, Pritam.
Good morning, sir. Natarajan sir.
How are
Good
you?
morning. How are you? Very good, sir. Very good. Very good.
Carry on. Yes.
Yeah. So welcome to dear Dr. Natarajan sir, who's been our Pitamaha of the BOA and the BOA retina people specially. So we are so happy to have him here today morning. And with that, I would also like to say that most in all probability, this would be the last CME of me and Swapnesh as the torchbearers of BOA because we hand over the baton to Dr. Ragini ma'am and Sumit on 1st of April. So it's been a wonderful journey past 2 years, a lot of speed breakers, but what doesn't kill you makes you stronger. So we've come out, I think, great in these last 2 years. And of course, we are not going anywhere. We'll be around. You will be seeing our faces even next month onwards. But thanks again to BOA, to everyone. And over to you, Swapnesh. Let's start.
It will be the best CME, don't worry. Pritam and Swapnesh ka.
Hi, Jignesh.
Last will be best.
Good morning,
Yes.
Jignesh.
Good morning, Nutty Boss. How are you?
Yes. Very good. Wonderful.
You're back or you are still in USA?
No, I come back.
I
come back. Yeah.
So we have our experts with me, Dr. Natarajan sir, Dr. Atul Ursekar sir, and Dr. Vatsal Parikh. A warm welcome to them. And it's bang 10 o'clock, and I invite Dr. Aniruddha Mahendrikar to start his talk on clinical trial synopsis in ARMD.
Yeah, good morning, everyone. It's really nice and wonderful to see everyone. And thanks MOS and BOA. MOS, as Pritam sir said, is extremely active. I hope you are able to hear me and you are able to see the screen. Yeah,
very much.
So we will start with this talk, which is clinical trials synopsis in ARMD. Basically, we will just cover in basic what is the clinical trials and what do they suggest to us. So let's go to a short history. Laser photocoagulation was the first effective treatment, and yeah.
I'll just request Numerotech to start the timer. Each talk is of 8 minutes.
Started, doctor.
Sure.
Timer is on.
Yes, doctor.
Yeah.
So macular photocoagulation study, which was in 1970s. After that came the era of photodynamic therapy, which helped in reducing the rate of visual loss. And then the topic of today, that is the dawn of the anti-VEGF era, started. So in anti-VEGF, we all know it first began with Macugen, that is pegaptanib, which was first FDA approved for neovascular AMD, and it is an RNA aptamer which binds VEGF 165. The landmark study was the Vision study, which showed that the patients who underwent this treatment had less chance of losing 15 letters compared to those who did not undergo this treatment, that is sham. However, now Macugen is history. We all know that newer medicines have come, but this study proved that medicines, that is intravitreal anti-VEGFs, are better than the previous treatments, that is photocoagulation and PDT, to stop vision loss. So then came the boss of everything, that is Ranibizumab, and its landmark trials, that is Anchor and Marina. In these trials, what was found was not only visual loss was stopped, in fact, visual acuity improved by more than 15 letters in 35% of patients, where in those who underwent around 0.3 milligram of Ranibizumab. So this was a significant improvement because previously it was just stopping of visual loss. Now the next landmark was improvement in the vision. So these studies, that is the Anchor and Marina, are now considered the gold standard for neovascular AMD treatment trials. So what do we learn from this is that not only are these very effective, but the safety profile, that is the safety of intravitreal injections, is significantly good. They are very favorable. There are very minor local complications, and severe complications such as vitreous hemorrhage, retinal detachment, and endophthalmitis are also very rare. Systemic arteriothrombotic events, which were quite hyped initially, are also not definitely conclusive. So we can see in this photograph that initially the treatments were focused at preventing the vision loss, and towards the Anchor and Marina study, there was a gain in visual letters of 11 letters in Anchor, 7.2 letters in Marina. So what did these studies establish? That the medicines are definitely safe, and they definitely not only reduce the vision loss, but also improve vision in ARMD. And so started the great journey of intravitreal anti-VEGFs in ARMD. Then came Bevacizumab. This was a monoclonal antibody which was actually the parent molecule of Ranibizumab, and however it was developed for chemotherapy in colorectal cancers, lung cancer, cervical cancers. But it was used off-label by most of the retina surgeons as it was very cost-effective compared to Ranibizumab in many of the retinal diseases, not only ARMD. The main study for this is the CAT study, also others like IVAN study, which proved that intravitreal Bevacizumab, either monthly or PRN, had similar efficacy, almost similar efficacy with intravitreal Ranibizumab. Now, this was a significant study, but there was a disadvantage, especially in our country, because of legal issues, because of Bevacizumab not being officially approved for intravitreal injections. This is the CAT trial. We will not go so much into the intricacies, but what we need to understand is that because Bevacizumab was very much cheaper than the previous injection, that is Ranibizumab, what did these studies show? That there is now a cost-effective treatment available for AMD. So till now we can see that previously in the era of 1970s, there was actually no treatment. Then macular photocoagulation, then PDT, which showed that vision loss can be prevented. Then we came on to the anti-VEGF era, where slowly we showed that the vision could be improved. Now the cost also could be curtailed. So how is anti-VEGFs given in this ARMD condition? So there are different regimens. 4 of them are the most important ones. That is, first is fixed regimen, which is monthly injection. Then there is PRN strategy, which is pro-Renata. There is treat and extend regimen and observe and plan regimen. So there are different trials which were conducted, which we can see being named in this slide. We are not going into individual of those studies, but we will try to understand what the studies showed. In monthly, we have to definitely give the injection every month. In loading dose and PRN, we give 3 monthly loading doses, and after that we observe and see how it is. In treat and extend, we give 3 monthly loading doses, and then we definitely extend the interval. So this is how the difference is. What is the difference between PRN and treat and extend? In PRN, on follow-up, the patient undergoes examination and OCT, and if there is no significant recurrence or evidence of fluid, then we wait. Whereas in treat and extend, we do not ask them to follow up every month or so, but we extend the follow-up interval. But on the day of follow-up, he definitely undergoes the injection. So these helped in reducing the number of injections that is required. So generally, initial treatment with anti-VEGF agents is given at a fixed monthly interval, usually till disease stability is achieved. Now, it is not 3 months or anything, but till we feel that the disease is stable. So if we see that the edema has reduced, but at 3rd month, if we see that there is some persistent edema, we call him after a month. This showed that treatment is very long term with repeated and multiple injections. Now came aflibercept. This was an alternative treatment in which instead of monthly, it was proven to be useful, can be given every 2 months, and it showed equal efficacy, that is non-inferior to Ranibizumab. Still newer medicines, that is Bevacizumab, its landmark studies, that is Oct Angiography, showed that every 12 weeks, we can see here every 12 weeks dosing interval, more than 50% of the patients could be maintained on that. And overall safety was similar to aflibercept. This is the Oct Angiography study group. And now there is a newer medicine which has come again, which is Bevacizumab, which is also useful every 16 weeks. And it is shown to be non-inferior. So what are the key points? Given multiple treatment options, selection depends on the lesion type, systemic health. Switching is possible and combination is also possible. Effective treatments can effectively reduce or prevent legal blindness. However, the real world studies were different. They had inferior outcomes because the studies environment was not identical. Intensive monitoring was not possible, and early diagnosis is required, and compliance was quite poor. So what is the difference? That we need to dry the retina. However, the burden in ARMD is significant. And we can see that in ARMD, the treatment keeps on going on and on. In DME, in fact, it can reduce. So the future direction is that we need a lot of studies to improve the cost, to improve the interval between the injections, and a lot of research needs to be going into that. Thanks a lot.
Thank you, Aniruddha. You tried to cover a very huge topic and concise it. I invite Dr. Natarajan sir's opinion on this topic, and followed by Dr. Ursekar sir. Welcome, Vatsal sir.
Thank you.
Natarajan sir, are you there with us? I'll pass on the mic to Dr. Preetham sir.
So let's take Dr. Atul Ursekar's opinion. Dr. Atul, sir, any words?
Yeah, I think it is a nice sort of opening round, or giving a sort of overview. And compared to the earlier presentations, which were a decade ago, now the whole discussion is, we know there's no question that these medicines work. The only thing that we have to effectively get skilled at is what is the spacing interval. Because basically the bottom line really is got to do with patient compliance, because we do know that this treatment stretches out for a long time. And this is particularly in patients who have comorbidities, say like diabetes, or who are very elderly. So the game plan and the strategy is probably the key to effective treatment. And each one of us has to really master this. And fortunately, now, of course, there is a wide choice of anti-VEGFs. But at the same time, fortunately or unfortunately, the treatment is not a one shot. It's not like a cataract surgery or something where, okay, the cataract is done and that's the end of the treatment. So when you start treatment, really you have to also plan at a broad overview. Like, okay, now you may be giving the patient the 6th injection or the 10th injection. So your whole plan should also be short term as well as long term.
All right, thank you. Dr. Vatsal sir, any comments before we move on? So you're muted, sir, you're muted.
I would agree with what Dr. Atul Ursekar said, and what has happened nowadays is that patients' acceptance to treatment is also more because now everyone gives it. So what efforts we had to put in earlier to explain patients have reduced, because when they come to it, they already know that it may be multiple injections. So I think overall it's a good situation, and these newer drugs will help to reduce the interval.
Thanks for the wonderful discussion, sir.
So we move on to our next topic, which is use of ILIA in PCV. Dr. Chintan, can you please upload your presentation and we start? Chintan, I believe you're mute.
Yeah. Is my screen visible? Sorry.
Yes, please start.
Yeah, thank you, Team BOA, for this opportunity. So I'll be presenting a case of use of aflibercept in PCV, a one-eyed patient. So a 62-year-old male came with complaints of decreased vision in the right eye. The left eye vision has been very less since a long time. Both eyes pseudophakic. The patient came to me on December 2020. And this was the picture of the fundus, where we see there are RP changes there. There is some edematous area. This is difficult to make out on 2D picture, but on slit lamp biomicroscopy, I could make out a definite swelling there. Sorry for these artifacts. And the other eye is everything is burnt out, scarred with RP changes, with pigmentary disturbances. So this is the OCT of the right eye, where we see that there is a tall thumb-shaped PED with SHRM shrum material, with a lot of SRF present. This is the right eye, and the left eye has a lot of outer retinal damage with everything is burnt out, a lot of RP changes and scarring there. So on fundus fluorescence angiography, we see there is some leakage here, there is block fluorescence here, and in the later phases there is pooling of the dye as evident in the right eye. And the left eye, the RP changes are showing window defects. There is scarring causing staining, and this block fluorescence because of the pigmentary changes. So one-eyed patients, he counseled the patient for aflibercept injection, which was given on 21st of December. Patient comes back at 4 weeks interval with an improvement in vision from 612 to 69 and from N8 to N6 parts. This is subjective. The PED had decreased in height, more flattened out, and there was the SRF had also reduced. So as a part of the loading dose, gave the second aflibercept injection. There was some technical delay because of getting patient enrolled in the program of ILIA for you. So the interval got extended to 5.5 weeks instead of 4 weeks interval. And the second injection was given on 29th of Jan last year. And the patient comes back again after 4 weeks. The SRF had reduced to a great extent, but there was a paradoxical increase in the height of PED with notching also present there. We see some hyperreflectivity also here. I'm sorry that I don't have the ICG facility, and patient was not ready to travel to a referral center for ICG. So continued with the third aflibercept injection given at an interval of 4.5 weeks from the last injection. The patient again comes back after 3.5 weeks with a stable vision, and almost all the SRF had reduced, and even the PED height had reduced, and gave the fourth injection, tried to extend the interval to make it 6 weeks to reduce the burden on the patient. and the patient comes back after 5 weeks with again slight increase in the height of PED and with some recurrence of SRF there, but the vision is 6/9 N6 stable. So kept the interval same at 6 weeks in contrast to treat and extend where we reduce the interval. And then the patient comes back again after 5 weeks with persisting SRF and PED there, but the vision is stable. So gave the 6th injection, again keeping the interval same at 6 weeks in between the 2 injections of 5th and 6th. And the patient comes back again after around 5 weeks with similar picture on the OCT. Maybe the PED height is slightly lesser, but the SRF is still persisting there, the neurosensory detachment. The vision is stable. So gave the 7th injection at keeping the interval same at 6 weeks because the vision was stable. And now the patient comes back after 4 weeks. The SRF has almost resolved and vision is stable. Tried to make the interval to 7 weeks from 6 weeks. And the patient, this time there was an occasion there. So patient family, close family event for the patient. So the patient comes back after around 10 weeks time. And luckily the vision was stable. And there was slight SRF which was there. The PED was similar in shape and size. So I wanted to give the injection as soon as possible, but because of the close family event for the patient wanted some time. So the interval got extended to 12 weeks interval between the 8th and the 9th injection. And this is the last follow-up of the patient where the vision was stable. There was some SRF persisting in other scan also. There was a lot of SRF there. And again, the interval, I tried to make the interval less, but patient wanted to increase the interval to reduce the burden on him. And so the interval between the 9th and the 10th injection was 11 weeks. So this is just the summary of the scans to start with. When there was a tall PED with a lot of SRF, the PED went on decreasing. There was a paradoxical increase in the height of and notching after the 2nd injection and even after the 4th injection. But the SRF again sometimes gets resolved, sometimes remains the same. The vision was luckily stable after the 2nd injection onwards. And this was a sequence of injections for the patient where with the interval like 5.5 to 4.5 to around 6 weeks, and then it got extended to 7 and 12 and 11 weeks. So I would just want to put these things like why was there the discussion points, the paradoxical increase in the height of the PED after the 2nd and the 4th injection, and if the vision is stable and there is still SRF which keeps coming and going. And this is how I could treat and extend. The last 2 interval got extended because of the patient's personal reasons. And thanks to ILA4U that I could enroll this patient in this program, and patient would get the advantage of 3 free injections after every 2 paid injections. So thank you. And if there are any things, any question or any discussion.
Chintan, you keep your question slide on, and we'll ask our experts to give their opinions on that. Vatsal sir and Ursekar sir.
Atul, shall I start?
Yes, you can start.
Yeah, I think this is quite a common presentation with PD. What I see, maybe 40-50% of patients, do not flatten totally. As he said, probably ICG would be of help, and maybe I don't have much experience, but PDT may be of help if possible in such situation. Little SRA persisting and patient maintaining good vision is also a common thing. I have a patient who has maintained vision over 2 years or more than 2 years with SRF there, and PD persistent. Vice versa, I had a patient who had taken 4-5 injections and there would not be any difference in PD. SRF had disappeared. She went to Kolkata and took Bevacizumab, but whatever data I have, again there was no difference in the PD height. So I think this is a common problem. Probably ICG and PDT may be of value to help. Atul, you can start.
Yeah, so a very nice presentation and good imaging as far as the OCT is concerned. But I think it is here that, as Vatsal said, if you have full imaging right from the beginning, then you know what you're dealing with. So a couple of observations regarding the images. One is that, interestingly, if you see, the choroid was not thickened, whereas in IPCV classically, the choroid is described as being thickened. So that's one observation. Second is a good part is that you saw right in the beginning there was subretinal fluid but no intraretinal fluid. So that's again a very important indicator that this patient is likely to do well if the SRF and the PED reduces. If there's intraretinal fluid, then obviously vision may not improve much. And thirdly, if you see in the later images, though the PED reduces, you can see what is known as the layering sign. Under the PED, you can see those fine layers. So that is in this slide, you can see the layering. So that is an indication that there's some level of chronicity, because every time there's fluid, there's a kind of layer which comes and then it goes down. So what would have really been useful and what may have explained to you why the timing and the PED is going up and down is what is the severity or the extent of the disease that you're dealing with, in the sense that you would have been able to identify the location and the size of the BVN. That's one. Secondly, you would have been able to identify the location, the size, and the number of polyps, because these are important pieces of information which will in the beginning indicate to you what is the nature of the beast that you're dealing with, so to speak. And if there was no change in the size of the BVN or the polyps, or then it would also mean that this is a patient who's going to require much longer duration of treatment. So that would have been the benefit of identifying the BVN. Here, of course, you have done very good imaging with OCT and identified the disease and treated it properly. But additional information would also help you to make a good long-term strategy.
Just to add, Atul, sorry, 1 minute.
Yes,
just to add, since this is a one-eyed patient, probably he reported earlier, so you would not get intraretinal cyst and other things because this disease is caught in the earlier stage.
Yeah, that's correct. And also the patient is generally more conscious if they have, had a very bad outcome in the other eye. So then they are more nervous and they tend to come earlier and more often to the retina surgeon.
The question is to both the experts. In today's era where PDT is not available, what is the role diagnostically as well as prognostically for dye-based imaging, and what is the extra role, if at all, of Octa in this particular case? Bursekar sir.
Yeah, so as I said, if in the beginning, this is a sort of treatment naive case, you know exactly, as I mentioned earlier, what is the extent of the disease. Here you're identifying the extent of the disease by two parameters, that is the subretinal and the sub-RPE fluid. But the other important indicators are the BVN, the size of the BVN. Is there a feeder vessel? How many polyps are there? Are they small? Are they big? Are they multiple? Is there a bunch of grapes configuration? Because each of these has important prognostic indications. So at least in the beginning, you know what you're dealing with. Then subsequently, of course, you can use only the OCT information. That is one. And secondly is OCT angiography is fairly useful in identifying and locating the BVN. So in case ICG is not available for whatever reason, then at least OCT angiography will identify the size of the BVN. And in some cases where there is a little borderline, is this type 1 CNVM or is this IPCV, then once again, Octa will be useful to differentiate the two. In some cases, you can even see the polyp. So those cases where you want a clear-cut differential diagnosis and where you would not want to, for whatever reason, if ICG is not possible, then OCT angiography will give you that much additional information. But OCT angiography is more difficult in these cases, so it has to be done properly, because segmentation, if not done properly, will give you a wrong diagnosis. So that's also important to keep in mind.
I had a question. Can I ask a question?
Yes, sir. Yes, sir.
Yeah, go please.
Yeah, so I had that question, what he's discussed, very important, which I'm missing out, the paradoxical increase in the height. It usually happens after the second injection which you have given. I've seen it with Bevacizumab also. The first injection flattens out very well. The second injection, at the second week of the injection, you get a paradoxical rise in the PED, especially in these occult IPCV cases. So I was wondering, what is the reason? Anybody has any conjecture on that? Because I was trying to find the literature, I couldn't find this paradoxical increase. It happens after the second or the fourth, as he has shown typically. The first injection flattens it beautifully. So any thoughts on that, please?
Could it be something like that, Ajay, what we were talking initially after anti-VEGF, paradoxical increase in macular edema? Could it be something that suddenly VEGF has been depleted, and when the VEGF level suddenly rises? This is, I think, probably we were discussing 10 years back for macular edema, So I'm just putting a guess. Could it be something similar?
Could be, but they respond very well to the next injection after that if you give, So I shorten the interval after that for the third injection, when this paradoxical rise has happened, and it responds beautifully. That's not the worry, But why should it go so high? It goes really very high.
No, 2 weeks after second injection or 4 weeks after second injection, whether you're using Eylea or Bevacizumab, both intravitreal levels should be reasonably high. If it's after
Very true.
4 weeks or something, then probably you can think that has been metabolized.
Yeah. It's usually second week, that's how he's saying. I have seen it in Bevacizumab typically, Yes, yeah.
No, and the one possibility is maybe that the effect of the anti-VEGF on drying the retina is probably acts first, and then the PED starts settling. So maybe that could be the reason why this paradoxical, the PED is increasing, the retina is drying up. There are probably some factors playing a role there.
Possibly. But it's very scary, And the vision also drops, the patient's vision drops and he gets alarmed, like what's happening, so I was just wondering if anybody else has that same experience.
I think it's also a response to, like, the initial injection will cause you can say shrinkage of the neovascular network, and then there could be a reverse response with the body trying to again generate more neovascularization as a healing response, because ultimately that is the theory, that neovascularization is a healing response.
Right.
So now the body is trying to heal, so it's probably putting in double effort to generate a little more neovascularization.
Hitting back, yeah. True. That could be a good conjecture. Yeah, good idea. Thanks. Yeah.
Swapnesh, regarding your question, I had been practicing without ICG for all these years, and now I have the ICG facility. I think it does help in diagnosis, but there are now clear-cut guidelines that ICG is not compulsory in most of the cases.
So one more question on the board was about treat and extend. So when we normally treat and extend, we are essentially looking at OCT, right? I mean, like Sapnesh did put up the question, and Dr. Atul did answer it. But for all practical purposes, it is the OCT which is, and the intraretinal fluid and the subretinal fluid which is guiding our treatment. So why would you do an Octa when your treat and extend is going in a fashion where you are, it's like a desirable fashion, vision maintaining, patient requiring an injection about 2.5-3 months? In such a situation, why would you do Octa? That I thought I'll ask that question.
It's only for academic purpose.
So essentially it won't guide your treatment much. Is that what you're saying?
I think clinical response to me would be more important,
Okay. Right. So Sapnesh, you want to move on?
Next. Yeah. I invite Dr. Nishikant Bodse sir to speak on aflibercept in wet ARMD. Bodse,
Thank you, Swapnesh. Yeah. Yeah, thank you very much for your kind invitation. Thanks to BOA. And I'll try to cover this large topic in as much short time I can. This is my standard disclaimer. Now, we all know that basically when we look to AMD management, we are basically looking at two things. On one side, the patient wants to have a good efficacy, good visual gain and vision to be maintained. But on the other side, we have to also balance with the molecule that can be durable. We'll have to individualize it for the patient, and that entails the patient to have a frequent clinical visit, and there's the injection burden. And when these two come together, you can find that the patient compliance goes down. Now, what is the anti-VEGF basket that we have to choose from? I really don't have to enumerate them. It has been well enumerated by Anirudh before. And basically, it is the effectivity or the binding capacity of the anti-VEGF molecule and its duration of action that finally defines how long it's going to act. Now, as important as having a good anti-VEGF, it is important to know which regimen we are going to follow. And now when you see which regimen to follow, there are basically two, if we classify them. One is a fixed dosing, and the treat and extend, which are the proactive ones, in which we actually treat before the disease has come back or it's got reactivated. And the reactive one is basically the PRN treatment, where we treat as soon as the disease comes back into activity. Now, the fixed dosage regimen has been very well used in most of the trials which have got approval of the FDA for usage of these molecules, whether it is the Marina or the View trials. In each of these, it was monthly injections that were given. It has got the best efficacy, but the problem is the number of injections are very high. There are more visits, and you really cannot keep on sustaining it for a very long time. And therefore, most of us gave up the fixed dosing. And then came the PRN, which we of course love to use, because it was basically go on treating whenever there is a reaction or when it came back. It gave the patient an option of fewer injection, but the problem was in real world studies, we really didn't attain the visual acuity we would have loved to get. And therefore, the balance between both came in, that is the proactive treat and extend. And the aim of this treatment is to minimize the risk of the disease recurrence, and therefore you treat it before the disease has a chance for it to recur. Now, let's see a typical treat and extend. Now, suppose there is a patient with had a 3 monthly loading and you find the lesion is still active. You give at 8 weekly then, and then you still see it is active. So continue giving it 8 weekly. Now, the main thing is you call the patient after 8 weeks, and whether the disease is active or not, you're going to inject. Again, you call the patient after 8 weeks and you find that the lesion is now dry. The lesion is dry. So then you tell him, okay, now you come after 10 weeks. So I'm going to inject you after 10 weeks, whether the lesion is dry or not. And the patient comes back after 10 weeks and the lesion is still dry. So you call the patient after 12 weeks. Now, after 12 weeks, when the patient comes and you find that the lesion is showing a signs of activity, then you reduce it back to 10 weeks and you tell him, come after 10 weeks, I'm going to inject. So the basic aim is you're going to inject, you're not going to inject, but the fixation time for injecting can vary and extend according to the demands of the patient's eye. Now you can see this is a typical case of a PCV where a loading dose was given, and after the loading dose, we call the patient after 8 weeks. The patient maintained well, so call after 10 weeks. The patient maintained well, and then after 12 weeks, it got extended till the time he has reached 16 weeks. And this is how you reduce the number of burden and yet attain the best possible visual acuity for the patient. Now, which is the most suitable molecule for this particular type of treatment? And hands down, it has to be aflibercept, because aflibercept was specifically designed for high affinity banding with VEGF and PGF both. And that's the only molecule that acts on this both. And because of its unique mechanism of action, where there are 2 receptor domains, there is a high binding of VEGF, and therefore this aflibercept molecule was most suited for us to have a treat and extend sort of a profile. Now, if you go to the studies of aflibercept, there are 3 main studies that everyone will look at. And actually, it has been Altair, Oct Angiography, and View 1, View 2. The View 1, View 2, like I said, were the fixed dosing schedules that were used to compare aflibercept 0.5, 2 milligrams monthly, bi-monthly, and Ranibizumab. So it was a study with 4 arms. Oct Angiography was, of course, the head-to-head comparison between Bevacizumab and aflibercept, and it was basically to get knowing whether Bevacizumab is non-inferior to aflibercept. And the Altair study is an interesting study, and this study was basically to how to use aflibercept the best in a treat and extend. Now let's go through each of them very briefly. I'm not going to go through any of the details of it, but just the findings were View 1, the first year showed a great primary endpoint, and it showed that if you have a modified quarterly dosing, that is 12 weekly, you could maintain the visual gains over a long period of time. And that's what was shown by View 1 and View 2 trials both. So these trials showed that if you are extensively treating in the first year, but after the second year are ready to extend it, you can really reduce the treatment burden of the patient, and you can extend it to 12 or even 16 weekly. Now, Altair was a trial basically done to know whether you can do the extension at 2 weekly or a 4 weekly interval, whether you jump with straight 2 weeks or you go on saying that, okay, now come straight after 4 weekly extension. And it showed that in both the arms, you can have a good extension. You can have a reduced burden for the patient. But of course, when you extend at 4 weekly, you have a slightly lesser or inferior visual acuity outcome as compared to 2 week group. So it did show that treat and extension works fantastically well with aflibercept, but you get a better visual acuity gain if you take at a 2-weekly rather than a 4-weekly extension. Now, interestingly, this slide is a totally different side of how you look at a glass, whether you look at the glass half full or full. Now, like when you're talking about brolucizumab, you will say that 51% patient of brolucizumab had only Q12 dosing. Now, if you look at the other side, it says that up to 49% of the patient treated with brolucizumab did not get Q12 dosing. So it is about 50%, you can say whichever way, failed to get Q12 in even brolucizumab molecule. And of this 50%, we know that about 80% could maintain up to a longer week, up to week 96. And this is what is shown by this slide. I'll just go through this very fast. Now, when you take head-to-head comparison of the brolucizumab Oct Angiography trial versus the Altair trial, you will find that we can have a similar amount of outcomes if we use aflibercept carefully as what you can get with brolucizumab. That is reducing the treatment burden along with reducing the number of injection and the visits. Now, whether the same visual gains which were seen in clinical trials were also seen in real world. Now, there are multiple studies which showed that. There is a study by Epstein et al. Which showed that you can have the mean number of injections reduced to about 7 in the 1 year and only 2 to 3 in the second year. There's a study by Hanemeto et al. Which also showed that treat and extend did have a lesser number of injections to PRN, which is very interesting. And it also showed that it really made a much lesser costing for the patient. So just enumerating and ending by saying that even in real world studies, we find that aflibercept gives you a good treat and extend. Aflibercept has a strong binding affinity. It is one molecule which has got a very high potency, and it also inhibits VEGF and PGF both together. And therefore, we can safely conclude that treat and extend is a good way to go forward. And for treat and extend, aflibercept is the molecule of choice. Thank you. Thank you very much.
Thank you, Nishikant sir. So one question, if the patient is going to be very stable and there is no visual acuity drop, then what is the endpoint of treat and extend?
16 weeks.
So at 16-week follow-up, if there is no activity, then we are going to...
And when patient is for root. That's what
comments from Vatsal sir and Ursekar sir.
So I agree with what Nishikant has said, but sometimes some patients may stabilize and may not need injections. So not necessarily I would repeat every 3 or 4 monthly. I may just do PR and then.
Okay.
That percentage may be small, but it is always there,
But the basic premise of you don't let the disease come back. The only way that you do it is to go on injecting. There is no way for you to know that it will come back or not to go on extending it. And
I agree.
That's well.
Ursekar sir, are you there with us?
Yeah, I'm there. Can you hear me?
Yes, yes, yes.
Yeah, so I think that is a excellent description of what are the methodology. That's what I said after the first presentation, that we know these medicines work, but the whole thing is the strategy now. So the strategy has to be fine-tuned to the disease and to the patient. So this is sort of what Nishikant has described is a sort of fundamental or basic game plan which can be used. And then depending upon the individual case, a few modifications may have to be made. Like we have a description earlier of a one-eyed patient. The one-eyed patient, yes, you would want to extend, but maybe you may be a little more conservative or a little more aggressive, where even a small change you may decide to treat. So this is a good fundamental plan, but it needs to be then customized depending upon additional factors like the presentation, whether the patient is one-eyed, ability to come repeatedly. Sometimes these patients are very elderly, so they cannot come as frequently as possible, or they have to have somebody bring them in. So these are other, you can say non-medical, but social factors which you also have to keep in mind. But at the same time, to ensure that these patients maintain good vision for as long as we can deliver it.
Also, I'll pass on the question to Dr. Dudani sir also. Does he propose treat and extend to each and every patient that comes to his OPD?
Yeah, I think frankly, I don't propose to all my patients, but it's a good option in our patients. The problem is the follow-up is very sort of, the patients decide when they follow up. Though you tell them, I mean, the dropout rate and, the comfort, and this COVID has shown us that nothing is, permanent in life, except death and taxes. So I think it's very variable for all patients, how they decide. I think most of my patients decide their own treatment. I've realized that. Unfortunately, our patients think that they're very smarter than us at least. So if the vision is good and you tell them to inject again, now they can read OCT better than you have realized, most of my patients. They are seeing the screen like more, like I said, cued onto my screen than I am seeing. And before I can tell anything, a bit of fluid nahi hai. So if I tell them to inject at that rate, I mean, they think, there is no fluid and you're injecting, means. So it's, both ways, So sometimes I think that I extend and I call them for when the fluid starts coming, then they come, So usually they don't stick on to treat and extend my patients, I can't inject a dry macula because they read the OCT better than me. That's what.
But that's why Ajay, initial counseling is very important, because you have to tell them, okay, look, if you're going to get a recurrence, then I'm going to lose some vision.
Point is very well taken.
Inject if you are not going to. So on for that, I'm going to put you the next. Otherwise, I'm not.
Very true. Very true.
They don't. Because see, if you tell them it's like a suspense, I'm going to keep. And if I tell them, look, I'm going to do an OCT document, then they are really not bothered, because to your desert free, then you're not going to look at the price.
Yeah.
And with that highly for you program, if you plan before,
the
4th and the 5th is free.
That's true. That's true. They're very happy about it.
Right. Natarajan sir, I'll ask Natarajan sir, what does he follow, PRN or treat and extend, or a combination and customize to each patient?
Hey, you have experts here, yeah. Vatsal is my boss here. No, Vatsal, you have to answer on my behalf. Our Jaydeep is here.
Sir, you are like Mr. Modi boss always,
Modi के साथ compare कर दिया.
Good morning, sir.
Modi depends on Amit Shah. So हमारा Amit Shah है Jaydeep.
फिर तुम मोटा भाई हो जाएंगे सर. तुम मोटा तो नहीं है.
No, I'm not joking, because I wanted to tell Swapnesh what it is. After a long time, he called me. I didn't want to argue. I slowly want to become only surgeon. No medical retina. I thought I'll give it to, but patients are not leaving me, and you people are also not leaving me. So today I think I'll put my foot down and tell Jaydeep to do it. even I attended the Yanuzi rounds after a long time. I enjoyed it because of Yanuzi, but the medical retina is okay. I mean, they didn't talk about injection, so that was nice. So here the whole meeting is on injection. Anyhow,
sir, we request you to be only physician so other surgeons can work,
No. I want to do where nobody wants to.
You would agree with me, no?
No, I agree, Vatsal. I really agree with you, because I'm serious. I'm not joking. I'm seriously telling whoever cannot or don't want to touch the patient who is asking too many questions and nothing can be done, then I want to do that. So that they have to know that I'm the ultimate. No, I was in the Whale vitrectomy meeting. That's what we were discussing. And Nishikant, your paper was quoted there by, I forgot the author's name, from Japan. He quoted my friend only, central retinal artery occlusion. Anyhow,
oh wow.
Jaydeep, you answer Swapnesh's question.
Thank you, sir. Thank you for giving me the opportunity to answer on your behalf. Although you have, I think, 37 or more years of experience. So I'll just say that what I personally do is to start off with 3 loading doses for any kind of wet AMD case, whether it's a treatment naive or a fresh or a recurrence or a multiple injections taken patient. After that, I would like to follow for PR and with the PRN dosing for at least next 3 months and try to understand how the lesion is recurring. And then after that, maybe once I have a fair idea that, okay, this is the amount of time after which the recurrence starts in this particular eye, then go on the extension arm and try to extend it every 2 weeks or 4 weeks, and then take it from there. Because starting like after the 3 doses, immediately going for an extension, maybe somewhere we miss the recurrences early on, and we may not be able to do justice to the patient that time after the 3 loading doses. So that is how I try to go ahead with it.
Thank you, everybody. And I think it's a proud moment for us also to hear that Nishi sir's paper was quoted in an international conference, which is now a normal thing. Thank you so much. We move on to Dr. Asnani sir for his talk on Bevacizumab in treatment-naive bilateral occult CNVM. If sir is, because he had a commitment, I think he has joined, but we move on to the next talk by Dr. Ashish Vaidya sir. Sir, are you there? Can you share your slide? His topic is anti-VEGF in submacular hemorrhage.
Yeah, Swapnesh, can you hear me?
Yeah, but you can't see
Swapnesh,
you.
can you hear me?
Ashish, we can hear you, but we can't see you. Hi, Ashish. I think in the meantime, Swapnesh, call Harish and check whether he'll join.
Yes, sir. So he told me that he would be slightly.
Yeah, you can share. Yeah, okay. Yes, Ashish.
Yeah, can you see the slide?
Yeah, yes.
Yeah. I would, at the outset, I would like to thank the BOA and Dr. Swapnesh and Preetham for inviting me here. My talk for today is submacular hemorrhage. Now, hemorrhage in the macular area can be either subretinal, sub-RP hemorrhage, intraretinal, or pre-retinal. It's important to differentiate between pre-retinal hemorrhage, like you see over here. It's a boat-shaped hemorrhage, and it obscures the blood vessels. While over here, the blood vessels are going over the hemorrhage, so it is a subretinal hemorrhage. The causes can be multiple. It can be trauma, CNVM, PCV, lacquer cracks in myopia, or a retinal macro aneurysm. There's a sudden decrease in the central vision, and you have a smooth dome-shaped hemorrhage. It is bright red. You can see over here, it is bright red in subretinal hemorrhage and very dark red, almost greenish in sub-RPE hemorrhage. The other findings can be drusen, CNVM, polyps, hypertensive changes, macroaneurysm, and it's always important to examine the other eye. One can do a FFA and to see the blocked choroidal fluorescence and determine the level of the hemorrhage. ICG can also be done to look for the CNVM, but today what we rely on is OCT and OCT angiography. This is a very nice flow chart of a patient with a submacular hemorrhage. So if the patient has submacular hemorrhage, you check if there's vitreous hemorrhage or no. If there is vitreous hemorrhage, then you would think of doing a vitrectomy. If there's no vitreous hemorrhage, then you can perform a OCT, FA, or ICG. If there's contraindication to intraocular gas, then you only do anti-VEGF with or without TPA. If there's no contraindication to intraocular gas, if there's contraindication to TPA, then again, you can only do intravitreal anti-VEGF therapy with a pneumatic displacement, or you can add TPA to it. You review on post-op day one, week 1 and month 1, and then subsequently if anti-VEGF needs to be added. So it's very important to decide if the patient comes with a submacular hemorrhage as to what we are going to do. Now let's see 2 patients which I have. This is a patient who was a 45-year-old female who came with vision of 660 N36. She had a sudden decrease in vision since 1 day. And you can see this hemorrhage is primarily juxtapapillary, and there's a spillover of this hemorrhage into the fovea. Here you can see on the OCT, there's an elevation over here. And when you do a OCT angiography, you can make out that this may be a CNVM. There's a large subretinal hemorrhage on this side. So the patient underwent pneumatic displacement with C3F8 and intravitreal aflibercept. In this patient, I did not use TPA. We asked the patient to lie in the prone position, and then subsequently 1 month later, when the patient followed up, the hemorrhage had completely cleared off, and the patient's vision was 6.6 N8. Again, you can see that on the OCT, you can see the difference which is there. And on the OCT-A, you can see that this leash of blood vessels, which suggests a choroidal neovascular membrane over here. And we gave the patient a second ILIA. And after 2 months, the patient's vision was 6, N6. The CNVM had completely healed and scarred off. This is a juxtapapillary CNVM with absolute fine fovea, and the patient's vision was completely restored. We have asked the patient to come repeated follow-ups every 2 months, and we shall see subsequently as to what is to be done. So this patient had a very good result. The second patient was a 53-year-old male patient, again with sudden onset of reduced vision. However, this patient came after 1 week, at which time you would expect that this thing would have got clotted a little bit. Patient was 36, N36, and a hypertensive patient. Now, over here you see in the OCT, you can make out that there is a submacular hemorrhage. And now the question was, what was the cause of this submacular hemorrhage? If you see over here on OCT-A, there was just submacular hemorrhage. You couldn't see anything beyond that. And it's always very important to examine the other eye. The other eye, if you see, had a vision of 6/12 N10 and showed parafoveal telangiectasia. This was not visible otherwise. It was visible only on when you do the OCT or the OCT-A. Now, since this patient had parafoveal telangiectasia in the left eye, there was a very high chance of a choroidal neovascular membrane being present in the right eye with the submacular hemorrhage. And hence we decided to go in for pneumatic displacement with C3F8 and intravitreal aflibercept. And this was 1 week later, and you can see that the hemorrhage is already cleared off. It did not get displaced as much as the first patient, but that could be possible because this patient was treated almost 10 to 12 days after the episode happened. Now, if you see, the OCT has flattened down at the end of 1 week, and at the end of 1 week, you can make out this CNVM net which is there. So this patient had bilateral parafoveal telangiectasia, and in the right eye had a choroidal neovascular net which had bled. Subsequently, 1 month later, when the patient came, the patient vision was 6/18 N12, and the CNVM had regressed very well. And here you can see on day 1 submacular hemorrhage. After 1 week, it is regressed. And after about a month, you can see that the normal foveal contour has been restored and the patient's vision has improved. Thank you.
Thank you, sir. Those were wonderful images. And I would like to invite comments from Ursekar, sir.
So excellent presentation and good description of how to manage these cases. Actually, I had myself a question to ask because in both cases, Ashish had not used TPA. So what would be the guidelines to use TPA in the sense that particularly, the window where a person comes late or depending upon the height of the hemorrhage and the amount of the hemorrhage?
See, it is the guidelines which say that if you have a very thin hemorrhage, then you don't even need to do anything. If you have a moderate hemorrhage, then these are the patients who respond the best. If you have a very thick hemorrhage, especially with a CNVM, then these patients do very badly anyway. Now the question arises whether to use TPA or no. TPA is, of course, it is expensive. That's one part of it. The second part is that TPA also has certain complications. There's a higher incidence of hemorrhagic complications which has been reported when you use TPA. And the other point is also that there has been a study in which it is shown that if you use TPA with aflibercept, the TPA can cleave the aflibercept and may result in a lower response to the aflibercept. So based on all this and after discussion with the patient, we decided not to use TPA. And personally, if you ask me, I have not used TPA ever. So I prefer to do just pneumatic displacement with the anti-VEGF.
Yeah, I had another question, which maybe since Dr. Natarajan was mentioning about the surgical aspect. So can you enlighten us about, when you would go in for surgery, even if there is no vitreous hemorrhage, but where there is a large submacular hemorrhage, like would the presence of hemorrhage either under the RP or under the neurosensory retina would be a determining factor?
Natarajan sir.
I thought Ashish is going to answer. Ashish, what will you do? When will you do surgery? So I actually, Ashish is probably, net is not working. Anyhow, so I think I remember a massive submacular hemorrhage and hemorrhage following Ipcv in the entire subretinal space. I remember doing a 25 gauge vitrectomy that was related to Boa Cme On. That was 2004, where I did a vitrectomy and injected a TPA and put the patient on head-up position. I didn't do subretinal anything. And then the patient, everything cleared. And then following that, we did ICG, and there was a IPCV and did a PDT also. And then if you do the submacular hemorrhage, like what Ashish showed, I will again do a intravitreal TPA and put the head-up position,
Okay.
and not a subretinal injection.
Okay.
Can I ask a question, Dr. Chinmay?
Yes, Chinmay.
Yes.
Yeah, so just a question to everybody in the house. Any experience with, so this is a case that I'm describing is typically a vitreous hemorrhage breakthrough with a large subretinal hemorrhage, possibly covering the whole of the posterior pole. So any seniors or colleagues who have experience with subretinal TPA injection? I believe I've discussed a similar case with Dr. Borse a long time back. I would just like to have their experience with subretinal TPA and gas and anti-VEGF. I believe the technique has been described.
Chinmay, sorry to interrupt. I'm going to present exactly that case. So
okay.
I will
okay, yes.
talk about it in my
I think
presentation.
we have a lot of experience. So the main thing is, I think that was originally which I did even when Boa Cme On said just inject and leave it. But I remember Hillel Lewis, when I met him, he used to wait 45 minutes injecting the TPA and then come back, he'll scrub out and come back and then again do the drainage. But I think best will be to do the least so that you inject TPA and leave it. Actually, everything will settle down from the submacular region to inferiorly and then it will get absorbed.
Okay.
We have a question. We have a question in the chat box from Dr. Anand Subramaniam sir. What's the management protocol for submacular hemorrhage due to burst macro aneurysm? Ashish sir, Vaidya sir.
Yeah, see, you have to suspect a burst macroaneurysm when there is hemorrhage in all three layers of the retina. That means there is a pre-retinal hemorrhage, there is an intraretinal hemorrhage, and a subretinal hemorrhage. When you have hemorrhage in all three layers, the most likely cause is supposed to be a burst macroaneurysm. Now, again, if the hemorrhage is thick, then you may decide to do either TPA or just pneumatic displacement of the hemorrhage. And in the end, you have to identify that macroaneurysm by doing a FFA, and you have to laser that microaneurysm. Again, there are studies which say that once a microaneurysm is burst, whether you laser it or you don't laser it, some people say that even if you don't laser it, it will still close on its own.
Utsekar sir, any thoughts on that same clinical condition?
Yeah, I think I would agree with what Dr. Ashish has said. Essentially, the management is to basically remove the hemorrhage. The macroaneurysm can be managed either by laser or, as per some studies, as they say, if it has ruptured, then it's unlikely, it'll basically scar down. So then laser may or may not be necessary.
Thank you everybody for a wonderful discussion. And we move on to our next topic, which is interesting cases in ARMD by Dr. Dudani.
Yeah, thank you. Thank you for your kind invite. Are my slides visible?
Yes, sir. Audible.
So I'll be sharing with you a few cases of mine. So if I start with my first case, this is a case I call a PED which got fatter and fatter and also flatter. So we have a case with about 5 injections of Pagenex with a 12 months follow-up in a 64-year-old lady with an occult CNVM. Her past interventions where she received 24 Ranibizumabs and then we switched her to Eylea also. And she received the first Bevacizumab in October 20. And then the second one the month later, and then the story goes on, as I will show you all. So this is how the story starts in 2018. There's a serious PED, and it responded so well to eccentrics. And I thought, oh, this is the end of the story. Like, actually even PED do respond to anti-VEGF. But that's how it came back with a vengeance in 2019. And then we switched to Eylea and it did respond. It got better. Then again, the PED started broadening horizontally, as you can see, and these were the hyperreflective foci which started to come like a ring of hard exudates around it. This is like appearance of a typical Ipcv lesion. This is how it broadened horizontally very much. As you can see, it's going beyond the range of the OCT scan. And that's when we gave the first Bevacizumab. And this is the excellent flattening which we had at day 1. And then at 1 week, this was my first case. And that's when it came back, which I shared with you all. It comes back with a vengeance at day 15. And she had received multiple anti-VEGFs and still it came back. So PEDs, as we are aware, is the most difficult nut to crack in the compartments of the fluid which we have to treat. And about 70% of the patients don't have a resolution of PED in most of the cases. So we gave the second injection at 1 month and again, it flattened well. Then at 5 weeks, you can see that we extended it further to 3 months, saying that Paginix works for 3 months and it stayed flat, but that's how it came back. It was a mistake I made to extend it that long. Again, it responded very well with the Bevacizumab at 4 weeks. It again flattened out very well with the 4th injection. After the 5th injection, we injected at 2.5 months. That's what I realized is the sweet spot in patients with PED, rather than extending it till 3 months. And this is the excellent fluid resolution she has till today, just with a sliver of PED fluid, and the vision has come back from 660 to 618. So this is a treatment naive CNVM, which I thought was a RAP lesion, which responded beautifully. She was a 55-year-old type A personality lady with 612 vision with a type 3 CNVM. We started with Bevacizumab. And she responded very well, and she received a couple of more injections. Then they had to switch to Eylea. I'll show you all why. As of now, she's doing well, but she's gone into clinical depression, with AMD. So AMD is not that a benign condition. It affects you visually and psychologically. So this is the typical type 3 CNVM. As you can see, there is a hemorrhage here, seen on the red-free photograph with the typical intraretinal fluid and some SRF here. And that's the beautiful response you saw with that small molecule of Bevacizumab. There's not a drop and it flattens in 1 week because most of the VEGF is acting in the intraretinal lesion. So this is the slight HRS which are seen through the lesion. So, she stayed well, and at 8 months, she had 2 recurrences. She received these injections elsewhere. When she came back to me, follow-up, this is the recurrence of a RAP PED with IRF, and SRF. There's a sliver of fluid here. As you can see, that's the PED which is forming. So that typical, the photograph of Januzzi's of how the RAP lesion progresses. In spite of constant anti-VEGF injections, this is a very difficult lesion to treat. So it recurred at 3 months, again at the same site. And now there's a PED which is forming here also with intraretinal fluid. It got flattened again. And then it came back again with a large PED here. So she's a very sensitive lady, and she said, "Hey, doctor, I'm getting a lot of metamorphopsia." So we felt that we'll, switch to Eylea. So in this patient, we did an Eylea switch because she wasn't doing maybe that well and recurring very rapidly with Paginix. And she responded beautifully to an Eylea switch here. Then she came back again, and now she's so fed up, as I told you, patients decide what they need to do. And she said that next injection, doctor, I will take Avastin, And this is how she is. Maybe there's a small rip here, as you can see in this lesion here. And there's a sliver of fluid here with a PED again. This is my prize case, a 80-year-old lady, and I'm treating since 2003. She received PDTs, 40 Ranibizumabs, 2 DEX implants, Y in AMD. She had a vision of 3 meters, and she lost to follow-up during our COVID 2 years. And then she came back and she received 2 Paginix with a magic response. So this is the story in 2010 when you fast forward, when she received, eccentrics. That's the, IRF with PED. You can see the, a sort of a drill lesion. There is no intraretinal architecture seen. And here there's Schrem forming with just, this streaks of retinal tissue here. So this is when I did Ozurdex. I thought that maybe there's some inflammatory element. This is looking more like a DME sort of thing, but it didn't move the cyst a bit, Then we moved back to eccentrics. So that fluid used to constantly stay there. Vision was counting fingers. She was lost to follow up. This is how she came post 2 years of COVID, I mean, there's no retinal architecture. I discussed with her that we'll try this last injection, which has come new. And so this is how she responded on 1 week post-injection of Bevacizumab. And this is at day 30, She's never been flat for last, 5 years or 7 years. And this is the response I got, So she came back again 6 months later, because I think that was the Omicron wave. And she came back again with this fluid. But the vision did improve from counting fingers to 660. And we suggested a next injection of Paginex. And this is how she responded, So I thought, oh, wow, she's actually flattened out and maybe she's flat for good. So now she came back because there's no COVID. So she keeps coming back to me. And she's still wrung dry. As you can see that even the Shrem has disappeared. There's a semblance of a foveal contour and the vision is 636 today. So I think, there is this, whether there are two types of fluid, whether it's a degenerative fluid or whether it's an exudative fluid, which is there, So the degenerative fluid is due to the RPE atrophy. But I think, all fluids in AMD after this case there is an element of exudative element, and RPE does work in most patients. And she has stayed flat till today, after those 2 injections of Paginex. So this is the AMD endgame, which I saw in this patient, which I thought would never come, This is the last case I'll share with you all. Just I'll give me 2 seconds, 2 minutes for this. An 80-year-old lady, again, taking care for me for the last 11 years. An occult CNVM, received 80 Ranibizumabs. And post-lockdown, again, she had that same sort of situation where we moved her to Paginex. I'll show you all this case. So this is the story, how it starts. She had this conical PED in 2010, responds beautifully to eccentrics. Fluid comes back. Then, we inject again. She does well. It recurs, it comes back. So this was a precious eye of her, She used to come back very religiously because the other eye she had, refused treatment. Yeah, last few slides. So this is how the PED used to come back. And this is the pre-Bevacizumab effect of COVID, 2 years, no follow-up. You can see these layering lines with PEDs, with Shrems, with a lot of intraretinal cysts, which was never seen in her case, And this is how she responds very well. So just one stop I want to show you all here, that these patients, some of these mature CNVMs I'm seeing, they are tending to bleed, So she was very good after this injection. Then she came back with 3 months later with this large, massive submacular hemorrhage, which I again treated with gas and Paginex and prone. That's how she bled. You can see that photograph there. Massive bleed, So I think maybe because these injections tend to dry very rapidly and cause a shrinkage of the fibrous CNVM, they lead to bleeding of the mature vessels. So she came back again with a second hemorrhage. This was, you can see, here. And this time she really didn't do well, though we injected her again with gas and air and Paginex this time. And she developed a couple of cells in the anterior chamber, which responded just to topical steroids. So again, thank you so much for your patient hearing. Thanks.
Thank you, sir.
Thanks.
Those were wonderful images and a very long follow-up. Something to learn, how to keep your patients with you. And I'll invite Vatsal sir for his comments.
I think what you told about Ajay, more than cases, I would admire him for his skill to keep patients so long with him and give he would have probably by now 100 patients who have taken 100 injections. Well managed, Ajay. Ajay, what I would love is probably to put fundus photograph also, if possible, because then it makes more sense.
Sure. I'll do that. I just wanted this opinion of the floor on, these patients. The hemorrhage which I'm seeing in these patients of mature CNVMs who have received multiple anti-VEGF injections, are other of my colleagues and you all seeing this sort of happening in these mature CNVMs? Like I think, who have received multiple injections? Because I had 2 such cases, not just 1. 2 such cases have received about 60 injections, and then, when we moved them to Bevacizumab, they had this massive submacular hemorrhages.
maybe the theory what you propose that scarring may be causing bleeding from mature vessel may be true,
True, yeah. And
That
they were
seems
they were non-hypertensive patients, because initially I thought they might be hypertensive or some diabetic patients, but they didn't have any other systemic comorbidity except aging, and atherosclerosis. So I feel that these mature CNVMs, the mature vessels in the CNVM don't respond to anti-VEGFs, and when the fibrous tissue scars, maybe these vessels get sheared and they bleed, because the bleed is quite a big bleed, as you saw in these cases.
So probably here, if you have fundus photograph and autofluorescence, you may be able to monitor scarring process little more, over a period of time.
True. No, Vatsal, I have to tell you that your images which the patients come with, it's like out of the world. Huh? You're that new wide angle camera which you have with the OCT. They're like, I mean, this, it's excellent imaging, the system which you have. Great. Yeah.
Thanks.
Thank you, sir. So probably we can extrapolate this AMD to the teaching of PCV, where we also had formed mature vessels and neo vessels with polyps. And the routine teaching was PDT with anti-VEGF.
True.
The PDT usually will work on mature vessels, but unfortunately we don't have it now.
Yeah.
And so that would be a limiting factor why those mature vessels keep creating problems.
Yeah, absolutely. So this was the theory which was proposed also, that for these mature vessels, you only require the photothrombosis of PDT, which you brought out beautifully. Yeah, great point. Great.
Yes. I think we'll move on to the next topic.
Thank you.
Dr. Sharang Vartikar would be presenting When Nothing Seems to Work is his topic. Sharang, can you share the screen?
Yeah, I'll do that. I think seeing the presentation so far, this would have been the theme of the entire CME itself. And I don't think I'm going to share anything different, but it is something on the lines of what Chintan presented and what Dudani sir has presented. First of all, thank you, Swapnesh and the BOA team for giving me this opportunity. My case is a 54-year-old female who came with distorted vision in the right eye. And this was the presentation. She had a large PED with some notching here in the right eye, and the left eye had multiple drusenoid PEDs. So at this stage, her vision was 6/6, and we decided we'll just observe. Then 3 months later, she came with a drop in the vision in the right eye, and this was her OCT scan. We did an FFA, which showed these two hyperfluorescent spots. One of them maintained its size, and the other one showed, increase in the intensity. I passed an OCT through these two particular points, and this was the first lesion, and this was a break in the RPE layer, which you can see here corresponding to this hyperfluorescent spot. Based on this, we decided to proceed with an anti-VEGF, and aflibercept was preferred at that time. And fortunately, she did really well. The lesion subsided, and there was significant flattening of the PED as well. And both these lesions seem to have responded quite nicely to this. For cost reasons, we did complete the loading dose, but we continued it with Ranibizumab. Then she opted for a PRN protocol. And around 6 months later, she came back with this kind of a picture with a lot of SRF there and increase in the PEDs. Now, she went for a second opinion, which in such cases is always a good thing. And she underwent OCT FFA. I'm sorry, I don't have the ICG images. PCV was confirmed, and ILIA with focal laser and a PDT was done for her. Then subsequently, 6 months later, she came back. Vision was being maintained, although the OCT was showing these lesions. And it was decided that we will just observe this case. And she had decided to follow up with a treat and observe protocol. So no treatment was done as the vision was being maintained. However, she came back with a 6/18 drop in vision and increase in the SRF things. Here, ILIA was given, and again, fortunately, we got a beautiful response here. But now we were a little concerned, and we decided to follow the treat and extend protocol, again with ILIA. Now, this, we did a scan, and it showed diffuse choroidal thickening, attenuated choriocapillaries, dilated outer colloidal vessels, and a double layer sign. Again, this eye continued with ILIA, but meanwhile, the left eye now showed this huge PED. So far, it was only having small PEDs. Now, suddenly, this has increased. Again, vision was 6/9. We decided to observe this eye and continued with the right eye. Now, because of the cost reasons, we switched from ILIA to Zaltrap, and left eye was still under observation, although it had this subfoveal SRF there. And this again continued for some time till the left eye vision now started dropping. Now we got a little concerned. The patient opted for, we gave the option of OCTA, ICG, PDT, but her past experience with PDT was not so good, and availability of PDT was also becoming a challenge. And Eylea was given at that time. However, we found absolutely no difference in the left eye. Right eye, meanwhile, was doing fine as far as OCT was concerned. However, the vision in the right eye was deteriorating slowly. Right eye, again, in between, we shifted to Bevacizumab for, again, cost reasons, but that didn't seem to help much. So we went back to Zaltrap. In the left eye, now she developed this subretinal hemorrhage here. And again, in order to try and do something, we decided to go ahead with Zaltrap for the left eye also, but not much difference. And right eye, we continued on 3-monthly Zaltrap injection for whatever it was worth. And left eye, because it was the only eye now, we kept giving Zaltrap every 6 weeks. Here again, we reconsidered doing an ICGA PDT, but again, she was not keen on that. So right eye, after some time, the vision became counting finger 1 foot, or the fovea was scarred, and then right eye treatment, we decided to stop, and we were focusing on the left eye now. But that again, there was nothing that was really responding. The vision also kept slowly dropping. Brolucizumab was considered, but even she was a little apprehensive, and even I was. Maybe we should learn something from Dudani sir there. But we just held on for that time, and we continued with Zaltrap. And finally, in February, we decided to go for Brolucizumab, and I was really expecting some, very good thing to happen. Unfortunately, there was no significant difference in our last follow-up, and things are as they are right now. So overall, right eye has received Eylea, Accentrix, then PDT, macular laser, Zaltrap, Brolucizumab. Left eye has Zaltrap and Zybev, and here left eye has received Eylea, Zaltrap, and Pagenix. All kinds of protocols have been tried, and unfortunately, the outcome has been quite unsatisfactory. And now what has happened is another patient, 64-year-old female, come with a distortion with a very similar picture. You can hardly make out the difference. The height of coincidence is the name is also same, both patients. And we have again discussed all the options with this lady as well. And she decides that she's going to observe and not do anything. By God's grace, 3 months later, the subfoveal SRF has reduced, but we don't know how long this is going to stay. So as we all know, PCV is basically abnormal branching vascular network with aneurysmal dilatation of vessels, initially thought to arise from abnormal choroidal vessels and was diagnosed mainly by ICGA, but now it's believed to be a type 1 neovascularization in the context of a pachychoroid. And treatment PDT was the mainstay, where improvement and stabilization of visual acuity were only short term. But the questions I'm going to, we want to discuss, and some of these already have been covered in Chintan's talk, is, current role of investigations and whether PDT in any cases anybody would want to consider, and whether it's available, what would be the choice of anti-VEGF, any role of Ozurdex, because that is also being used along with anti-VEGFs, and what would be the approach to symptomatic PEDs, just simple PEDs, like Dr. Dudani sir showed some cases where, anti-VEGFs gave a good response in PEDs. Whether that can be done, is this a standard practice, or we select only few cases for that? Thank you.
So I think, Sharang, you keep this slide on, and we'll put the question to all the seniors on the forum. Dr. Ursekar sir, if he is there.
Hello, can you hear me?
Yes, sir.
Yes, sir.
Yes, sir.
Yeah, so basically just a few random observations. First and foremost, when you have a good vision, and particularly when the PED is very large and very tall, I think it was a good decision to observe, because the larger and the taller the PED, there's also a risk of RPE rip. So, a dramatic from 6'9", the patient can go down to 660. So that's another, that's an important consideration to keep in mind. Secondly, would be, again, as I reiterate, if the previous imaging was available because the patient had undergone FFA, ICGA, then that would definitely have been useful in identifying what the problem was in the right eye, and also why the patient is sort of deteriorating in the left eye and also not responding. Another advantage in the absence of PDT is that if the patient is lucky, sometimes the lesions are such that they are amenable to direct laser treatment. So since we don't have PDT, if ICGA is done at an early stage, not when things have gone downhill, then right in the bud itself, if possible, you can do a direct laser treatment. That's sort of the only alternative which is not listed here, which is available. And I have seen patients in which imaging has identified these lesions, and direct laser has been beneficial to these patients.
But not for subfoveal, right?
As I said, it depends on the location. Obviously, not for subfoveal. But if you are even if there's subfoveal fluid, that doesn't mean the polyp is necessary.
I meant lesions. Okay.
Yeah, the lesion is important to identify, but the key over here is to catch it early, because once you have all sorts of other, when you have large lesions, when you have scarring, then in that case, it becomes a little challenging. Even, when you have a large PD, very often the BVN is on the side. It's not under the PVD. It is usually at one of the edges. That's why it typically describes as PED with a notch.
Yeah.
Ursekar sir, would you give any importance to those intraretinal spots which are seen, like in DME? We know they are a sign of inflammatory markers, and the role of steroids is very well documented in DME. But would you give any importance to those spots which were seen? They were corresponding to the hard exudates, but in the left eye also occasional hyperreflective spot was seen intraretinally in the eye.
It would have the same implication in the sense that the greater the number and the greater the density, the poorer the potential for visual recovery, which also Dr. Dudhani also showed. Basically presence of all the fluids when the discussion goes to is that how much should you inject to make it dry. The bottom line is intraretinal fluid is the worst fluid to have. So then, of course, you have sub-neurosensory and then you have sub-RP. So between the three, intraretinal fluid and other indicators, like if you have those hyperreflective dots, they are an indicator of guarded visual prognosis, because the recovery is going to be that much more compromised, irrespective of your, drying up the fluid subsequent to any therapy you use.
So your take on approach to symptomatic PEDs? Vision maybe 6.6, 6.9, but distortion.
Yeah, as I said, I would definitely do a good imaging, because again, that indicates how long you can keep under observation. As you said, if the patient has got good vision, if there's a small PED, again, you may just keep it under observation. But like in your case, if there's a very large PED, there's a very real risk of, a rip occurring, or sometimes even you can get a bleed. So my first approach would be to do a proper good imaging, because you have a baseline. See, very often this is a very common situation that, subsequently down the line, many months or many years down the line, you say, why did this happen? Why did this happen? Or why was the response not there? But you don't have a starting point where you understand where the disease developed from. So along the evolution of the disease, then it's very difficult to track, because as you give anti-VEGF injections or any other therapy, all that scarring, the recurrence of fluid coming and going, it distorts the picture. It's like when you're doing a primary surgery, and if you're operating or doing a resurgery, like in RD, there's a difference between doing a primary RD surgery and doing a RD surgery with PVR, because the whole anatomy gets distorted. So then identifying the pathophysiology and the evolution of the disease becomes that much more difficult.
Ursekar sir, we have a question on the chat box. The role of TTT in combination with anti-VEGF for these polyps which are extrafoveal, now that we don't have PDT.
I think this
Dr.
is
Bapaye has asked the question.
Yeah, I think these are all the challenges that we are going to have to possibly, use in absence of PDT. So it's like similarly in CSCR, different other modalities have been tried. So there is even that micro pulse which has been described for patients with CSCR as well as with diabetic CME. So in the absence of PDT, if as long as you follow the dictum, first do no harm. If you're confident with your parameters, and as long as you don't produce a deterioration in vision, I guess there's no choice. You can't try it in a desperate situation.
Anyone uses Ozurdex in order to probably reduce the risk of a RIP occurring along with anti-VEGF?
We can have a raised hand if anyone uses or has used Ozurdex.
Give it intravitreal dexamethasone from the vial because Ozurdex patient may not afford just that simultaneous injection of 0.1 ml dexamethasone. That's very cheaper.
Okay.
Sure.
So yes. So nice. We move on to our next topic, which is pharmacoeconomics of anti-VEGF therapy by Dr. Chinmay Nakwa. Chinmay, can you share your slide?
Is my slide seen?
Not yet.
Okay.
Just try and reshare it, unshare it, and then again share it.
I'm sorry, I'm facing some problems. If you don't mind, can you go ahead with the next one? I'll get ready in the meantime. There's some system problems. Sorry.
Okay. So we have a next topic, managing submacular hemorrhage by Dr. Jaideep. Jaideep, are you around?
Yeah. Hi, Swapnish. Thank you for inviting me. Thank you, BOA, for having me to speak today. So I'll just share my screen. Is it visible?
Yes, it is visible.
Okay. So I'll be talking about something which we discussed some time back, managing a case of submacular bleed and how I went about managing this patient. So she was a 60-year-old lady who presented to us first in 2020, somewhere in the second phase of the lockdown. And she didn't have any systemic conditions, had cataract surgery done in both the eyes. And after cataract surgery, she had 6/6 vision. There were some dry AMD changes in both the eyes though, and she was regular for follow-up. Till December 2020, vision was maintained. So she then presented to us in July 2021 with a sudden loss of vision in the left eye for a week. So this was just a week's duration, and the vision had dropped to counting figure close to face, which was quite alarming. And this is how she presented to us with a massive submacular hemorrhage. And you can see there is a component of sub-RP bleed, subretinal bleed, and a large lesion, which is just as temporal to the foveal region. So this is how the OCT looked like, and you could see the sub-RP bleed, subretinal hemorrhage, and SRF surrounding it. And you can see that the retinal structure is still not disturbed, and the retinal layers are still quite well maintained. So just 1 week duration of drop in vision. So we decided to image, as Dr. Ursekar said, that it's very important to start off with the imaging to know where we are starting off. So this is the FFA pictures, and you can see a small lesion coming up superotemporal to the foveal region, a PED, fibrovascular PED, but the ICG was the clincher. So in the ICG, we could get, sorry for the clarity of the images, but we could get a BVN, which was very close to the fovea, temporal to the fovea. And there was a lot of hemorrhage around it. So at this point of time, when the picture was like this with vision counting finger close to face, I thought we should better go for a surgery with a subretinal TPA. And that's what we planned with the gas along with an anti-VEGF. So the choice of anti-VEGF was something which I had to decide. And by this time I had a reasonable experience with Brolucizumab. So I thought this would be something because of its longer duration of action. Why don't we try it in a vitrectomized eye? It would be a little useful. So went ahead with a vitrectomy with subretinal TPA and C3F8 gas. So here I just can this be seen? Is the video visible?
No, video is not playing.
Is it visible now?
No, we can see the fundus picture, but the video is not moving.
Yeah, just a minute, sir.
Jaideep, you can directly share the video later, or if it is not playing with the PPT.
Is it playing now?
No, you're out of the share screen.
Yeah, so I'll just do it later. Is my screen visible?
No, you're out of share screen. You have to share screen again.
Okay, just a minute. Is it visible now?
No.
Right.
It is visible now.
Yeah, now it's visible. You can
Now-
play the video.
Okay. Now is it visible, sir?
Yeah, but it's not play. Video is not playing.
I'll just play it at the end.
Okay.
I'll just finish the case quickly. So this
Yeah,
is how the patient looked on day 1 post-op, and this was the OCT we did, and you could already see that there is a reduction in the PED height, as well as the subretinal hemorrhage has cleared off to some extent to the side. And this is about a week later, and you can see there is significant clearing of the subretinal hemorrhage. And subsequently, say around 4 weeks down the line, the vision was counting fingers 3 meters. And this is a time when we decided that, okay, let us go in for the second injection of Brolucizumab. There was significant reduction in the height of the PED as well as the subretinal fluid. So post the second injection, this is how the fundus looked like. And this is the OCT. And you can see the PED has dramatically dropped and reduced in size, and there is hardly any fluid subretinally. And the foveal contour has come back. And the visual acuity has improved to, at this point of time, it was 6/60. And then subsequently, a month later, it came to 6/12. So this is after 2 injections of Brolucizumab, one intraoperatively and second one a month later, that is around 4 weeks later. So at this point of time, vision was 6, 12, and 8. And we thought, okay, let us complete the 3 injections, and we gave the third injection. So the last OCT here is after a month after the third injection. And vision had come back to 6/9 and 6. So there was a dramatic improvement from how the patient was when she started off with. So at this point of time, we thought, okay, let us wait and watch and extend. So this is the pre-treatment and post 3 injections of Brolucizumab, of course, with vitrectomy, subretinal TPA and gas. Patient coming back to 6, 9, and 6. So the story didn't end there, of course. After 2 months of the last injection, I could see when the patient came for a follow-up, a little bit of subretinal fluid coming there and the height of PED increasing, vision dropping by 1 line. So we thought, okay, let us give the 4th injection. That is 2 months after 3 loading doses. The patient came back to 6, 9, and 8 a month later and was doing well. But a couple of months down the line, vision dropped again to 6, 12, and 10. And you could see again some rise of the PED and some subretinal hyperreflective material collecting there, along with some intraretinal thickening. So this is time when we gave the 5th injection, and so we have to follow up the patient yet. So the take-home message from this case was that submacular bleed, we need to needs very prompt treatment and needs a surgical management based on, as we had discussed earlier, depending on the amount of subretinal fluid, the height of the subretinal hemorrhage, sorry. And if it is significant, go ahead with a TPA. And there is a dramatic improvement if you treat at the right time and aggressively. And anti-VEGFs definitely help in these cases. And you need to consider brolucizumab because in such kind of a case, you can, although we know that anti-VEGFs are not working well in vitrectomized eyes, not more than 2 or 3 weeks. But here we can see at least 8 weeks of fluid-free duration in this vitrectomized eye and good visual outcome. So something which we can consider in such cases. So that was my case. I would be happy to take any questions.
Jaideep, you're sharing your video.
Yeah, just a moment.
First, unshare your PPT and then open the video and yeah. Yes.
Okay. I'll just go directly to because I did a vitrectomy with IVT assisted PVD induction and then going for a subretinal TPA with the 41 gauge needle. So what I used here is a little different technique where I used a VFC, that is an oil injection syringe, to inject the TPA, not with the handheld syringe. So this was much more controlled way where I connected a tubing to the end of the oil injection syringe. We drew the piston and injected the TPA, reconstituted TPA 50 micrograms through the cannula. Then attached this 41 gauge needle to the end of that cannula, and I set the injection pressure around say 5 millimeters, very low. And then with that, I could control the subretinal TPA injection very well without it inadvertently going very fast, causing, sometimes it can go in and cause a macular hole or something in such cases if you cannot control it. So I was trying here outside the arcade, it was not working out. So then I decided to change the site and went where there is significant subretinal hemorrhage and fluid. So I could find the right plane there, and there you can see I injected it in the right plane and I could get the bleb where subretinal TPA was going in the right plane. So I just wanted to highlight that this kind of injection can help to inject the subretinal TPA in a more controlled way if you connect it to a VFC syringe, that is oil injection, through the vitrectomy machine. So I ended up with the injection of C3F8 gas. So that is what I wanted to highlight with this video.
Nice
so
video.
I'd be happy for questions.
Yeah.
Jaideep, that was an excellent surgery. What I wanted to know is, in your technique, did you also inject your anti-VEGF subretinally, or did you inject it into the vitreous cavity? And the second question is, see, there have been concerns with brolucizumab with regards to inflammation. So yours is a retina surgery patient, you do expect some inflammation. So did you have any thoughts prior to deciding brolucizumab, or was there some justification for the choice of brolucizumab?
Right. So firstly, no, I didn't inject the anti-VEGF subretinally. It was very much in the vitreous cavity at the end of the surgery, which we normally do. Subretinal would be little, I don't think there is, I've not heard of reports of subretinal anti-VEGF injection, but that would be little more dramatic. I injected in the vitreous cavity at the end of surgery. Secondly, this patient has no previous history of any inflammation, and inflammation per se post vitrectomy, we are taking care of removing the vitreous, and the chances of inflammation happening in a minimally invasive surgery like this 25 gauge surgery is very less. And my indication for using brolucizumab was because I wanted something to last longer than normally it would. So I thought that let me give it a try. And considering a little bit of experience with such lesions previously, I thought brolucizumab was working well in my hand. So I thought, let me try it out and see how it goes.
Okay. It's a great surgery.
Any comments from Ursekar sir?
Yeah,
I think very nicely imaged and highlighted what I was saying earlier, and very nicely operated also. The only thing I would probably liked is when you achieve that highest level of success of 612 vision, if you had done the angiography at that point, because the OCT at that point when the retina was fairly dry, at least to me it appeared that the lesion was extrafoveal. So if you had done angiography at that stage, possibly you could have done also a little bit of direct focal laser, and that may have prevented that subsequent deterioration which you had in one of the last images. I think that would have been sort of perfectly completed the picture. But otherwise, very well
That's
managed.
a great point to take home. So I think the next time the patient comes, I would like to do that. That's something which I can do, a focal laser to extrafoveal lesion.
Yeah, because you could have killed it at its weakest stage of the evolution of the disease.
Swapnish, can I add something?
Yeah, sure.
Samyak here.
Yes.
Yes. So Chinmay was asking a question about whether the different methods. So there's one more method which has been popularized by Tamer Mahmood et al. And it's published in American Academy of Ophthalmology in 2017. So what they do is they prepare an injection, subretinal injection, with about 0.4 ml of a TPA and about 0.2 ml of filtered air. And they inject it subretinally, similar to what Dr. Jaideep showed us. And there is a partial fluid air exchange which is done. There is no need for gas, or you can put SF6 gas and do a partial fluid air exchange. So you mix an injection of TPA along with filtered air and give it subretinally. That also works really well. So, I mean, there are multiple ways of doing it.
Yeah, I agree with you. I think we have done that, Jaideep, subretinal air and TPA, correct? But we didn't mix and send it Samyak. We injected air. At least I have done that. Subretinal air, and then I've given the TPA. The idea is to have space in the subretinal.
A bleb can be created with the air. That's a very good idea.
So the hemorrhage gets pushed inferiorly and the air kind of floats. So
there's like you create a potential space for the hemorrhage to go inferiorly, and there are quite dramatic results. But what Jaideep has shown was equally good. So, and it seems to be lesser invasive as compared to subretinal A and subretinal anti-VEGF, I think. So there's good learning from me over here.
Yes.
Jaideep, what is your advice to the patient on the post-op positioning day 1 and then day 2?
Yeah.
In such a case, I generally ask for a post-op prone position, and subsequently that is on the day 1, and subsequently when I see the patient, when there is a little bit of I could see breakthrough hemorrhage happening, propped up position to make the blood settle down. But the first thing I would do is try to displace the hemorrhage from around the macula, and once it's displaced, then let it go down towards the with gravity.
Okay, because in diabetic vitrectomy usually it's the opposite way around. That day 1 we would prefer the patient to be sitting, and then we would like the patient to be head down position, because you don't want the hemorrhage to come and track and be behind the retrolenticular or the retrolens space. You want your view to be good. So it's a catch-22 situation where you would like to see the patient.
In this kind of case, we don't expect too much of hemorrhage coming out, and there's no active bleeding happening here, so we can probably get away with it. And displacing the blood from the macular region when you still have the TPA acting there is a good idea, and then maybe it can trickle downwards and settle there. So that's my thought on it.
Yes. I just wanted to bring about this point because this is slightly different than what usually we advise our routine diabetic patients. So great video and great learning. I think Dr. Haresh Asnani sir has locked in, and Chinmay, I would request you to go in after him because he has some commitments.
I understand. Yeah, I'll stop sharing now.
Yeah. Sure.
Yeah.
Good morning, everybody. And thanks, Swapnish, and thanks, BOA, for the opportunity, and thanks for accommodating my change in the schedule. Are my slides visible?
Yes, sir. Yes, sir.
Yeah.
Yes, sir.
So my talk today is about my experiences with brolucizumab, and I'll be showing my experiences with one case of brolucizumab. This is a female who was 86 years old, and she came to me in the lockdown phase, and she's a diabetic hypertensive with ischemic heart disease and operated for cataract. Her complaints were very vague, and she had a bilateral subretinal hemorrhage, and on OCT we could see an occult CNVM. So this is her fundus picture with some subretinal hemorrhage in the right eye, a little more hemorrhage seen in the left eye.
Your slides are not visible.
Yes, sir. Slides are not
Slides
moving.
are not moving?
No.
So make
Okay,
it full
one
screen.
second. Hold on. Let me stop sharing and reshare again. Let me just share the desktop directly and see. Can you see my desktop?
Yes, sir.
Now?
Better, sir.
Yeah, you can see the patients. This is my second slide. The patient
Yeah,
was
now it's seen.
hypertensive with diabetes, ischemic heart disease, etc. I just
Yes.
mentioned that. And this is the fundus picture with a subretinal hemorrhage in the right eye, a bigger subretinal hemorrhage in the left eye. This is her OCT of the right eye, which showed occult CNVM with intraretinal fluid, some subretinal fluid, and this is the left eye. Similar picture, looked pretty bad. And since we had just come to know about the launch of brolucizumab, I thought that let me give this a try, because she is a lady. She traveled to my clinic all the way from Andheri West and couldn't travel too often with the lockdown, etc. Let's give it a shot with brolucizumab. So I counseled her for brolucizumab in both the eyes, and we started injection in the left eye, which looked worse to start with. So I gave her an injection of brolucizumab, but to my surprise, on day 7 when I saw her, there was absolutely no change, and in fact the thickening of the intraretinal fluid, etc., had gone worse. And I was wondering whether I really made the right choice or not. On day 17, I could see slight amount of improvement, slight reduction in the intraretinal fluid, but still I wasn't really too convinced, though I still decided to continue with brolucizumab for her, and this was her next visit, and that was exactly a month after the first injection. And I could see, to my pleasant surprise, the subretinal hemorrhage resolving right here. This is her OCT on the 31st day, and this is the day I gave her the injection also, the second injection of brolucizumab. Could see the CNVM resolving, the subretinal fluid resolving, intraretinal fluid having gone completely. So I gave her the second injection. After that, there was a much better improvement, symptomatically slight improvement, good resolution of the occult CNVM, and then now we come to the right eye. Now 1 week after the left eye injection, I gave her the right eye injection. This was the injection day with a lot of intraretinal fluid. Day 10 after the first injection right eye, a small amount of hemorrhage again seen, but started showing resolution on day 10 itself. No intraretinal fluid. So the remarkable part was the intraretinal fluid absorbed really fast. And this is the second injection of the right eye, which is showing a further resolution of the subretinal and sub-RPE fluid. Second injection of brolucizumab give us more relief, a better resolution, more flattening of the sub-RPE elevation. The third injection of brolucizumab was taken on the 6th of January 2021, and right eye was on 11th of January 2021. After the third injection, that's roughly 15 weeks of initiation of treatment, the best corrected visual acuity also improved, and the patient felt symptomatically better. This is her right eye, and this is her left eye, which was looking really very, very good. I decided to wait a little bit and follow her up. Following her up subsequently showed very good maintenance of the foveal thickness and absolutely no lesions. But a few months later, sometime in April, that is 3 months after her first injection, she started showing some amount of intraretinal fluid in the right eye with a little elevation of the sub-RPE. The left eye continued to do well, so I gave her a fourth injection of brolucizumab in the right eye. The left eye, of course, doing well, I decided to observe. After this fourth injection, 1 month later, she did very well. Again, symptomatically also feeling much better. I've continued to follow her. This is 3 months after the fourth injection, and one follow-up in December, which is again end of almost about 8 or 9 months after the fourth injection. Very good. But she came to me just a few days ago on 25th March, nearly 1 year after her fourth injection, and now she's again beginning to show some amount of intraretinal fluid and elevation of the subfoveal RPE. So I've decided to give her this in the right eye, one more injection of brolucizumab, which I haven't yet given her, probably for the coming week. So this is her timeline of the foveal thickness, which showed slight, this is the right eye, which it did quite well, and it showed a consistent drop in the subfoveal thickness, and in the left eye, initial rise in the first 2 or 3 weeks post injection, followed by a very good drop and an excellent maintenance of the subfoveal of the central retinal thickness. So my initial impressions and learnings from this first case of bilateral brolucizumab injection in a case of occult CNVM with subretinal bleed was that it really did well with 3 loading doses. One eye had an initially delayed response due to the severity and presence of subretinal blood. The other eye, right eye, did very well, but that eye which did extremely well had to be given a 4th and a 5th dose first at a 12-week interval and then after 1 year. Both the cases never had any evidence of intraocular inflammation or vasculitis, and there was a little delay in the visual recoveries. At around 3 months she had some kind of visual recovery, but overall this was a very good outcome in an advanced case of bilateral occult CNVM. Thank you so much for a patient hearing.
Thank you, sir. Dr. Manish Bapai, sir, has a question. I'll request him to unmute and ask a question.
Am I audible?
Yes,
yeah,
sir.
Manish.
Yes. I experienced a patient who developed severe inflammation at the time of 3rd dose of brolucizumab, and first 2 doses were given for both eyes. So, and then after talking to certain people, I realized that it's not very uncommon to get inflammation. So my question was, has anybody experienced this, and would you consider putting patient on steroids prophylactically if you are giving bilateral loading doses?
Well, I haven't so far experienced any inflammation in any of my patients since I've used brolucizumab, and it's been about 1 year and 1.5 years, I think, since we've been using it. My initial follow-ups were very close, and weekly follow-up in the first 2-3 patients, and then I have not found any inflammation. So now I have been very liberal with my follow-ups and following them as usual with like I do with other anti-VEGF injections.
Because I have become after that experience, I have become very conservative about the treatment. I mean, giving
yes, case selection, I've been a little bit careful. Couple of cases where I thought of giving brolucizumab, but they had some pigment on the lens and possibly some old uveitis or something, so I decided not to give them brolucizumab for this particular reason. So but still not too many cases that I have really found any kind of inflammation. I think case selection would be a big thing here.
Okay.
Manish sir, what was the presentation of inflammation in your case? It was like vasculitis or just a vitreous haze?
It was more of acute iridocyclitis kind of picture with some amount of vitreous haze. But I know of a patient who had endophthalmitis, sterile endophthalmitis like picture, and needed vitrectomy and ended up having very poor visual outcome. So that's my concern when giving loading doses in these patients. So if the patient is doing well after first 2 injections, I become little, a little apprehensive in giving third dose and try to do it more on PRN basis. So.
Yeah, I think you're right. With this concern of inflammation, we will have to, space out our doses as much as possible when it comes to brolucizumab. And this is always there at the back of our mind, even now after so many cases. Whenever I'm checking a patient, I have to look for vasculitis or any signs of any flare in all these patients. I don't know if anybody here in this group has seen any inflammation. I think Ashish had some case of inflammation. Ashish, are you there? Yeah, he's logged in.
Dr. Vaidya, sir. Okay, can we get comment from our expert, Dr. Ursekar, sir?
Yeah, with regard to inflammation, I think if at all BOA MOS should try and collect some data and present it, because however, even if you ask individuals, it still becomes anecdotal, and nobody gets the bigger picture. What we are really interested in is in the bigger, the broader picture. So whether it is BOA, MOS, VRSI, AIOC, somebody should kind of collect the data. Just like in the CAT trial, ultimately it was the National Institutes of Health in the US which did the trial to compare. So it has to be kind of a independent third party. But maybe I think there are a lot of vitreoretinal surgeons who are using it, who are quite comfortable with it. And then there are others I've heard who are very conservative or even not even used it at all. So there's a very broad spectrum of users and non-users, and both sides will benefit if we collect some data.
I think I recollect some email from VRSI about a registry for adverse events for anti-VEGF injections. They're starting something like that.
Yeah, that's just a broad. Thing for any anti-VEGF. It's
okay.
not. I mean, even if
not just
because now they have all these biosimilars. So
yes.
what we wanted to do is that they wanted to warn all the members in case a particular batch of biosimilar is getting a but I think brolucizumab has generated a lot of interest because it's a sort of the latest molecule. It shows very good results in many cases, but at the same time, as you said, there's a concern always at the back of your mind. And sometimes suppose it's a one-eyed patient, or suppose, as is in your case, a patient is not able to come immediately. All these things, they do worry you before you prescribe it. But I think it is good that this patient benefited. The only thing I would have probably liked to know is, because from the nature of the initial imaging, actually with a lot of intraretinal cystoid spaces, kind of, I thought it maybe, was it like a RAP type of lesion? Or
yeah, it was almost like a RAP lesion. It was a occurred with a lot of intraretinal fluid, and some places the RPE couldn't be seen. So possibly it could have gone. There was a blood also. So yeah.
I think that that response timeline was probably affected by the fact that it was a RAP lesion. So even though we call all of them neovascularization, I think maybe the RAP lesions have a different timeline of response. And fortunately, I think you may have caught it in the early phase of the endothelial cells being sort of being promoted by the VEGF, and because you injected in time, you achieved a very good long-term response.
Yeah, maybe the timing was right. Yeah.
Sure. So thank you, Asnani sir. And we go on to our next topic from Dr. Chinmay on pharmacoeconomics of anti-VEGF therapy.
Thank you, Dr. Swapnesh. Is my screen visible right now?
Yes, yes.
So thanks BOA for giving me this opportunity. And mine is quite a different topic in this clinical heavy session that we're having. So thanks for the opportunity. Sorry, this is not playing. My screen is not moving right now.
Chinmay, try the watermark like arrow on the left lower side of the screen, not on the keyboard.
Yeah, I got that. I think there's some issue with the. I don't think I'm able to navigate my cursor.
Can you come out of the slideshow and just show slides individually?
I was going to say that. Come out and show the individual slides.
Okay. I think that screen is hung somehow. Okay. Something happened. I think it moved. Yeah, it's finally decided to respond. Can you see the slides moving?
Yes.
Yeah, so this is my second slide. This is quite an antithesis because this whole topic is about financial interests only. But let's move on. So we are talking about AMD and it being a chronic disease. So as we have learned through this discussion, it is something which you have to keep on treating. And since the history of AMD, the treatment of AMD, now we have come with agents which can actually improve and optimize vision. So the decision to make is whether we undertreat or whether we overtreat, because both have certain pros and cons. If you undertreat, the patient keeps on losing vision. If you overtreat, there's a chance of systemic and ocular adverse events happening. So what is the treatment strategy that we follow? Well, among the talks that we've heard so far, I think more or less the treat and extend strategy seems to be the most acceptable, though many people eventually go towards a PRN strategy. But if we had an option, I think we would agree that the treat and extend strategy is the best to follow for all our patients. So what do we need to know about the economics of AMD? So if you look at the history of AMD, at one point of time, the Novartis, which introduced Lucentis, they were charging the procedure cost was almost $1 lakh for one injection. So coming from there, now there has been an entry of a lot of biosimilars into the market, and the pricing has become pretty much aggressive. So as clinicians, we need to know two things. We need to know which pricing suits best for our patients. And once we know the economics of the pricing, we are able to make much better informed decisions regarding the choice of molecule that we make for our patients. The issue over here is compliance. If the drugs are becoming more and more cheaper and they are more and more accessible, I think that should lead to a better compliance among patients. We should be very effectively able to convince patients for a treat and extend protocol. And knowing the economics and presenting the data to them very objectively, I think will enable us to get there. So there are certain assumptions which I've made in my presentation. These are for non-charitable private practices in Mumbai and suburbs. And the average procedure fee, now the fee that you charge might be either more or either less, but this is the average fee that I've taken. And it's assumed that the doctor's following the treat and extend protocol, and he has taken an average of 6 injections in a year. And the injections are procured with the best available commercial offer. And this is only considering the direct cost of treatment. So there are indirect costs like traveling costs and loss of wages for the attendant and all, which are a little difficult to calculate. So this presentation is just with regards to the direct cost of treatment per patient per eye. So there are certain terms which I'd like to mention. What are the procedure costs? So this is the amount which the patient pays for the injection, which you give a bill for. It includes the cost of the injection, the OT charges, surgeon fees, follow-up fees, etc. And investigation costs are the OCT, fundus photo, Octa, or FFA, which are considered separate from the procedure costs. So if you come to the drug and the costs, generally Avastin is charged from 8,000 to 12,000, an average of 10. Eccentrics, let's say 30. Razumab around 20. Razumab and other approved biosimilars. I've not considered the non-approved drugs over here except Avastin. Eylea, well, around 60, and Paganax, let's consider around 35. What are the general charges for OCT? Well, I would say an average of around 1500. Fundus photo, let's say 500, sometimes more, sometimes less. Octa around 3000. And consultation fees, well, there's a wide variation. Let's go for the lowest. Let's consider at least $800. So if you consider these numerical values and you put all the possible drugs over there, those are the procedure costs which are there. And that's the unit cost to the doctor. So if you get this from a vendor, those are the costs that you would generally be bearing. And obviously the companies, they give us certain offers. So if Eccentrics, if you buy 5 injections, they exclude the dealer margins and it comes to around 18,000. With Razumab, the Intas molecule, if you buy 5, they give you 2 free. So the effective cost comes to 7,700. Eylea, they have a unique program, Eylea for you. So the cost over there would be around 18,000, and Paganax is there's no offer on that, so the cost is what it is. Investigation cost, well, let us consider per year the patient spends around $10,000 per injection, and pre and post-op medications, if you give antibiotics, another $1,000 in that. Around 6 injections per year. And a consultant fee of, let's say, 800 per visit. So multiply that by 6 and then that gives you 4,800. So what would be the cost of therapy? So this includes the procedure costs along with the investigation costs, consultant fees, and pre and post-op medications. So if you put all of these together, sorry, I'll just continue to the next sections. So the injection cost, that is the cost of the drug per year, would come to around this much. And eventually the amount that the doctor would make, if you look at it, is more or less similar. So if you look at the numbers, the cost between Eylea and Paganax, I know there have been certain preferences among different doctors, but the cost between Eylea and Paganax, considering the offers that Eylea is giving, is almost similar. There's hardly anything to choose. And if at all you have to choose between Eccentrics and a biosimilar of Eccentrics, also it's quite competitive. So I think if you present these numbers to your patients, the fear that the patients have is there's a lot of uncertainty. How many injections will you require? Well, I don't know. How much cost it is? Well, I cannot really tell you. But if you give them these numbers that this is the amount of yearly cost that you would have, then there's a lot of clarity. I think there would be a lot of patients will be more likely to follow up and have a treat and extend protocol if you present these numbers to the patient. Thank you.
Thank you, Chinmay, for that presentation. Would like to invite a few comments from the audience. Jaideep, do you present a bouquet of options to all the patients, or
Well,
you put your foot down?
Right. So very nice presentation, Chinmay. Very interesting to see the numbers. So I generally do give an idea to the patient at the beginning itself nowadays, because I know that what my protocol is going to be, and it's going to definitely require at least, as Chinmay said, at least 6 injections in a year to be on the conservative side. So I do give a brief idea about the molecule and why I'm choosing and what would be a approximate cost, not for the 1 injection. So I am not counseling the patient here to take the first injection. I'm talking about the entire cost for 5 or 6 injections and how it can be broken down. Recently, I've started doing that because I think, as Chinmay said, it would be the patients are more, they get a better idea to and are more motivated to take the whole therapy. Otherwise, it's like you're going to have a lot of dropouts after 1 or 2 injections. So I do give the options to the patients. But as far as the anti-VEGF is concerned, I give my preference. When I know that there is no preference required, then I tell the patient that you can choose any one of them. But otherwise, I tell about my molecule, my choice, and give a fair idea about how much it's going to cost for about 5 or 6 injections in our center.
So comment from Dr. Ursekar sir, if he is there. and then we move on to our next talk because we are just running short of time.
I think it was a nice tabulation because cost is certainly one of the most important things. And as I mentioned after the first presentation, is that this is no longer a situation like you're telling the patient about a cataract surgery, which is a one-time thing. So you have to look at the short-term perspective where you want the medicine to work, but at the same time, you as well as a patient have to understand that it's not just one injection which is going to be the end of the story. And it is, for whatever reason, a little prolonged process. You're preparing the patient in many ways to hopefully participate and ensure that both short-term and as well as long-term success is achieved. I think good effort.
So do you bring up the topic of Mediclaim, especially in the single-wise drugs? Now that we have the IRDA letter with us, do you use that to help your patient or to influence the decision?
No, I provide the information in the sense that I guide them that the IRDA decision is there and so on and so forth. You put it on the table with the other information available. And as mentioned, is that when you give the whole bouquet of choices, there is always, and very often the patient themselves also ask that, okay, fine, that you've given me all these choices, but sometimes multiple choices can confuse the patient. So it's not uncommon that the patient will themselves say, but then what do you recommend? Which one do you recommend? So in certain cases, we do make a mention that this would be the preferred medicine. And then depending upon the response, I do also put a caveat that after the loading dose, there is a possibility that we may have to change track. So you do mention that multiple injections may be required, but at the same time, you also mention to the patient that after the loading dose, there's a possibility of change of both frequency as well as in certain situations, change of the injection, depending upon what response is obtained.
Thank you so much, sir. And thank you, Chinmay. We move on to our last topic. It is by Dr. Sarvesh Tiwari, and his topic is twist in the tail. Let's hear what is the twist.
Thank you, Swapnesh, and thank you, BOA, for this opportunity. So with all this controversy involving the use of Bevacizumab, let me share this interesting case with you all quickly in the interest of time. And I'll leave it to the audience to decide about whether it's a boon or a bane. Okay. So starting with the case, I hope my screen is visible.
Yes.
Yeah. Okay. So this is a case of a 65-year-old lady who came with the complaints of defective vision and metamorphosia since 2 months in the right eye. This is in August 2019, before the pandemic started. The visual acuity in that eye was 6/18, while the other eye it was 6/9. Okay, so she was pseudophakic in both the eyes. As you can see here, you can see a large subfoveal PED is there with some amount of SRF, and there is a notching of the PED also. This is the other eye where you can see some myelinated nerve fibers and some RP irregularities, but and some soft brucines if you observe carefully. Otherwise, the left eye fundus was otherwise unremarkable. There was no fluid or anything. So with such a tall PD sitting there, I was a bit not very sure whether we should go for treatment because the patient vision was not that bad also. But since the patient was very persistent regarding the metamorphosia, I decided that the best thing to go in such a case would be to inject Eylea. So that Eylea was injected with the aim of flattening the PD and to resolve the SRF. However, post-injection 4 weeks, what I landed up was this. The patient complained of a scotoma in her field of vision, and what I could see was this kidney-shaped area of hemorrhage. I said that let's go ahead with the loading dose of Eylea. So I re-injected Eylea. So this was the presentation after 4 weeks. As you can see, the PED had flattened out, obviously also because of the rip, and the localized heme seems to have slightly spread out. So it was now involving the larger area, and it had come closer to the fovea. So at this point, the patient was saying that her scotoma had increased naturally. though surprisingly, the vision was still maintained at 6/18 in spite of the small hemorrhage covering the macula. So at this point, the patient, I told her to go for the third injection, but she was very apprehensive because of the 2 injections. So she requested me to change the injection. So in the interest of that, I decided to go ahead with Eccentrix at this point. Eccentrix was injected. This was the picture after 4 weeks. You can see that there is still SRH is there. The SRF is reduced. However, since I was not very happy with the response, I somehow convinced the patient to go ahead with the further injection. But that time she refused. And now when she came after 1 month, this was the picture. Again, you can see there is intraretinal cystic spaces have appeared. The hemorrhage seems to have migrated now supratemporal to the fovea, and it is spreading in a much larger area. Now at this point, you can see that I could see some sort of a type 1 like CNVM like picture with a subretinal Schremm like material. So at this point, the patient got convinced and took another dose of Eylea. This was the picture post 4 weeks of that Eylea. You can see that the intraretinal cystic spaces have resolved. The subretinal heme still persists along with the Schremm. So at this point, I was slightly doubtful about the diagnosis. Is it an IPCV I'm dealing with? So I advised the patient to undergo an angiography and an ICG. As you can see, the FFA was showing an area of blocked fluorescence naturally because of the subretinal heme. There was this area of increased fluorescence because of the RP window defect, and there was some leakage noted supratemporal to the macula. The ICG corroborated the findings. As you can see, the prominent choroidal vessels are evident in the early pictures because of the overlying RP rip. However, there is staining of the subretinal fluid, and however, leakage persists as a hotspot in the late stages. So for this, we got confirmed that what we are dealing is an occult CNVM and not an IPCV. So when the patient came to me, this was almost when we were somewhere in October 2020, and that's the time when Brolucizumab had been just launched. So this was the picture at that time. So I gave the patient the option of Brolucizumab since it was a new molecule around, and the patient got convinced and we injected Brolucizumab. So this is the picture post-resolution. Now, as you can see, after 4 weeks of injecting, there was a complete resolution of the subretinal heme as well as the complete resolution of the intraretinal and the subretinal fluid. This was the picture after 4 weeks, and this was the picture after 8 weeks. So you can see the effect of that first Pagenax, which I gave, almost lasted till 8 weeks. So I was very happy at that time. But suddenly, after 10 weeks, something unexpected happened. The patient suddenly landed up with an increase in the scotoma. There was a massive subretinal heme when I saw a fundus, and the vision acuity had dropped from 6/9 to 6/36. At this point, I could see there was a resurgence in the PED, and there was massive subretinal heme everywhere, which was slightly encroaching into the macular area. At this point, I discussed this case with various other senior retinal specialists, and everybody was of the opinion that the best thing to do was to inject aflibercept along with intravitreal C3F8 followed by strict head down position. This was done, and 4 weeks post injection, this was the picture. You can see there was a resolution of the subretinal heme. However, some intraretinal cystic spaces still persisted. At this point, I somehow managed to convince the patient the vision had improved to 6/24. This point, we again gave a second dose of injection Brolucizumab. And after 4 weeks, this was the picture. Again, you can see that there's a complete resolution of the subretinal fluid, and the heme had also nearly resolved. The PD height had also come down. So far, so good. However, after 10 weeks, as you could see, now there is a resurgence in the subretinal fluid here. So since we had seen good response with Brolucizumab in the past, I told him to repeat the injection. This was in June 2021. After 4 weeks in July, again, we noted a complete resolution of fluid. There was no hemorrhage, and the visual acuity was maintained at 6/12. So by this time, I had come to this conclusion that the effect of Brolucizumab was exactly lasting for up to 8 to 9 weeks, and probably in the 9 to 10 weeks, I was getting a resurgence. So the patient is still following up, and the treatment journey continues. So what I came across through this interesting case was that the best resolution of the fluid as well as the subretinal heme and the visual acuity was observed in my case after injection of Brolucizumab. The improvement was sustained even after 8 weeks of the first injection. The paradoxical worsening after 9 weeks, however, needs to be investigated further though. The resolution of the subretinal heme 4 weeks post-injection was not that appreciable in my case. Thank you. Case is open to discussion.
Very interesting case, Sarvesh. I am sure there are going to be multiple thoughts on this. Ursekar sir, first your comment.
Yeah, so after the fluid resolved,
Yes.
again, one can see in the sub-RP space a very clearly defined multiple layers. So that itself is indication that this disease is a very chronic disease, and it's not going to sort of settle and remain quiet. In fact, it was almost an indication that it is guaranteed that it is going to come back. So the only thing is, I didn't exactly follow your treatment interval. I was not able to. I would have probably looked at treat and extend, but with a very conservative extension period.
Okay.
In fact, I would probably not have waited for the fluid to come back, because the layering is almost guaranteed that the disease is going to come back. You see here, you can see the layering in spite the fluid has gone.
Yes, sir.
So this is a sign where you have achieved success in the short term, but this is not long-term success. Long-term success would require treat and extend, but with very conservative extension steps. Okay. As Dr. Borse said, or should, that the 2 weekly is better than the 4 weekly.
Okay, sir. Point well taken, sir.
Ursekar sir, would you agree that when there is a PED rip, the height of the PED as well as the overall average retina thickness goes down, whereas in his case, when the presumptive diagnosis of rip was made, there was no appreciable reduction in the height of PED. Can you just show that image, Sarvesh?
Yeah, I'll do that.
So could it be the hemorrhagic component of PCV, or just a membrane which was missed at the edge of the PED which had bled, either of the two?
Actually, one thing is that
it's not showing the it's not showing the RP choroid interface very well. So
yes,
because of the height of the PED.
Actually, the section through which the drip was appreciable, I could not capture that. I could not take that photo, but in that one of those sections, the drip was clearly visible.
Okay. Yeah, I guess because of the height of the lesion.
Yeah.
Spectral domain OCT, the problem is got to do with the band of clearly visible, whereas with the swept source, you would have seen the whole thing from top to bottom.
Yes.
Any other comments from the group? Anybody else has any other thoughts how to manage this case, or any pointers? Then we move on to our diabetic session after this.
Thank you. Thank you, Sapnesh. Thank you.
Thank you.
Thank you. Thank you so much, everybody, for sparing your Sunday mornings with us. And thank you, Ursekar sir, in spite of your busy schedule. You have been kind enough to answer and attend each of the PPTs, and it was very valuable inputs from your side, which really improved our experience in this session. Thank you so much.
You're welcome. Thanks to all the participants for excellent, spending the time collecting all the information and presenting it in a very concise manner, because I think practically everybody, was within the time limit, and these are difficult things to present in a short time, but they all did very well.
Thank you, sir.
Thank you, sir. Thank you, Sapnesh.
Thank you so much.
Thank you, everyone. Thank you.
So we move on to our next session. The experts for this session are Dr. Paritosh Kamdar sir, Dr. Hemang Kopikar sir, and Dr. Karobi madam. And let's begin the session with none other than Sabyasachi Sengupta. He would be presenting application of clinical trials to case-based approach. Sabya, you can share your screen.
Yes, thank you so much, Swapnish. I hope my slides are visible to all of you.
Yes.
Very good afternoon to everyone, and thank you so much to BOA for giving me this opportunity. So I'll quickly talk about 3 cases that I have managed, sort of the take-home message will be how do we really apply clinical trials to practice. And we know that Swapnesh has already introduced me, and I practice in Borivali. So we know that it's not really easy because there are a lot of information in clinical trials, and when patient is actually sitting in front of us face to face, it's not always easy to sort of recollect all that material from trials. So how we do that is so this is a quick template based way where you can do it, where initially you need to remember the inclusion exclusion of the trial and see whether your patient actually would fit into that trial. And then look at the baseline profile of patients who are included in the trial and see how close or how much variability your patient has with a protocol patient or a trial patient. And then based on the results, you choose the best intervention for your patient from that trial. And then of course you keep assessing outcomes on a regular basis and compare your outcomes with trial results. And if they're really different, try and collate all of that and publish your data. But how do you really sort of interpret a paper? Large clinical trials are okay, but how do you really judge whether a trial is good enough and whether recommendations should be taken to practice? And so I have a blog as well as a lecture on YouTube on how to read a scientific paper. You can all take a look at that. So, we'll look at a sample trial and then look at 3 cases that I've managed based on that. So this is the protocol T from the drcr.network, which compared aflibercept, bevacizumab, and ranibizumab for diabetic macular edema. So this is a very, sort of concise way in which you can take a look at the recommendations, where, sort of the overall sort of recommendation is go for a loading dose for 3 months and then do a PRN and a monthly follow-up, and then inject whenever there is recurrence in fluid or drop in vision. So I'll show you 3 patients that were managed. The patient 1 was treated as per with ranibizumab as per protocol. Patient 2 was not treated as per protocol, and patient 3 he dropped out midway from what the protocol suggested. So this is a patient. So these images are not from real patients, but are just representatives. She was a 64-year-old lady. So the average age of patients in that trial was 60 years. She was a diabetic for 15 years, whereas patients in the trial were about 17 years with diabetes. HbA1c for this patient was 7.5, her vision was 624, and the macular thickness was 497 microns at baseline, and she had moderate NPDR. So she was very close to our, the clinical trial patient that was there. So has a variability of less than 25%. So she is really an ideal fit. And if you would treat her as per trial protocols, you should get the results that the trial showed. So this is the baseline. So this was moderate NPDR. So this is in February 22nd February 2019. This was the picture at baseline. As you can see, the thickness is 497 microns. So she got the first injection of Eccentrics. This is the, so we are doing a loading dose. So the second month she got a second dose, vision had improved to 612. The third injection she got on 24th April, that is the third month, and vision had improved to 6.9. Now, in May, she didn't get an injection. In June, again, no injection, vision was maintained at 6.9. She kept following on a monthly basis. In September, she, as you can see, the vision has dropped as well as the thickness has increased. So she got a 4th dose. In November, she got a 5th dose. In January, she got a 6th dose. So at 1 year, after 6 injections, that is what most people would require. She was treated per protocol, that is loading dose followed by PRN. She had a monthly visit, so she was very adherent. And so she had a final vision of 6.9. This is the second patient, who's a 61-year-old gentleman, has diabetes for 15 years, HbA1c slightly poorly controlled at 9.7, vision is 624, and macular thickness is 409, which is slightly less than what clinical trial patients had, and he also had moderate NPDR. So he's also, pretty much a good fit for clinical trials if you want to actually, recruit him. So this is the baseline picture. As you can see, this is 27 July 2019. This was the first dose he got. Then, he was supposed to come in August. He did not come back for that. So the loading dose was missed. So that initial bus is missed. He came back on 30th September. That is 2 months after the initial dose. He had edema again and vision had dropped. So he got a second injection here. Then he came back in November. This was looking good. So he didn't get an injection. Then straight away he jumped to 4th March, so after 4 months. And again, there is edema. He got a next injection. Then in April and May he didn't come back. He came back in June again. So he had recurrent edema again. So this is something like a patient that we would see more often in our clinics. He got another injection in, in 15th September, again, no injection in October, again, recurrent edema, so injections again. So, he got 6 injections over 1 year again, but his BCVA remained at 636. That is almost 1 line worse than what it was at baseline. So he has also gotten 6 injections, while the previous patient has also gotten 6 injections, but that was per protocol, and she had good vision. But this gentleman did not take those initial injections, and he landed up with relatively poor vision. So this is a comparison of the first patients. So you can see the edema is actually worse at baseline, but she ended up with 6.9 vision with 6 injections, and this patient ended up with 6.24 with 6 injections at 1 year. But this was as and when needed. So this really doesn't work in most cases. This is the third patient and the last one. So he's a 54-year-old gentleman with diabetes since 15 years, HbA1c of 11.7, vision of 3/60. So it's relatively poor. And there's a very large edema of 886 microns, and he had severe NPDR. So this was at baseline. He got the first injection. This is the second injection. So the loading dose we are trying to do. So despite no fluid here, he still got a second injection. Then he did not come back in December, but he came back in March. He got the third injection. Then in April he was doing well. In May he came back. There was a little bit of fluid here. He got a fourth injection. Then in July he got a 5th injection. So he sort of dropped out after getting 2 doses, not 3 loading doses, but still at least he's got 2 doses. And based on that, he's actually retained 6, 12, and 10. So, what we would see after 1 injection of anti-VEGF is something like this, where, there is very little fluid, and patients actually have good vision. And most of us don't, or at least a lot of us think of not injecting at this time. But then, that's where that initial loading dose does not happen. And then vision does not, always end up the way we want it to be. So, what about PRN from baseline for DME? People say it works very well in my practice, so patients are not willing for a second injection immediately. So, overall, if you look at literature, about 20% do well with this regimen. The rest don't. So even if we are looking at PRN right from baseline, we should really have a very low threshold for re-injecting if you are doing PRN from baseline. So overall, sort of the take-home message is, monthly for 3 months, and then PRN is definitely works well. And despite whatever the OCT looks like at 1 month after the first injection, we need to inject. So, thank you so much. And if there are questions, we can take them now.
Thank you, Sabyasachi, for that wonderful presentation and a great insight on how to use these trials and bring it into real-world practice. Kopikar sir, your comments on that?
That first patient which you showed, you have shown up till the lockdown. So what happened to that patient after the lockdown? Because you have shown up to February or so of 2020. So what happened afterwards?
So she has actually gotten another 3 injections in the second year. She's taken another 3 injections. But then she didn't come back for almost 4 months. That was the first lockdown. But after it, she's continued to come.
So now all these patients whom you have shown, what was their renal status and what is it now at the time of presentation, and now what is it? Because most of them were uncontrolled when you have shown their HbA1cs. Subsequently, after all this, did they control themselves? And what was their renal status?
So none of them had any renal parameter problems that, so I have not repeated them, but at baseline, I have asked them to get all these parameters done. So at baseline, there were no renal problems. The second patient actually was put on insulin by his diabetologist, given that he is not responding very well. But the others continued their diabetes. I did not ask them to get repeated sugars done, but then they are in with follow-up with the diabetologists. None of them had any renal disease as such.
Karobi madam, your inputs
Sabyasachi, thank you, Swapnesh. Sabyasachi, very well correlated with the studies, but I needed to ask you this, that don't you think that even in the control, say when there are patients coming who have been given the loading dose and like they are getting it as per protocol, it would depend on what their status of glycemia, as Hemang said, renal status also, which guides the probability of a good response in these patients rather than only a protocol based thing. So what are your comments on that?
So, these are some things which are not really always under our control. So we, recommend them to get their parameters done. And a lot of the times there is a lot of disconnect between what the parameters are looking like and how the retina is behaving. So probably there is an interplay over a long period of time. So I would still think that the chances of better success are per protocol. And so of course, even if we treat per protocol, some patients still continue to worsen. But then the chances of improvement are better if we try and stick to that. So overall, I think that second loading dose is, I think, most important. Even if we don't do 3, at least 2 loading doses are a must, irrespective of how the OCT looks like at 1 month.
But Sabyasachi, these protocols, they extend almost to 24 months, that is 2 years. Now you said your patient number 1 received only 3 injections in the next year, but that is not as per protocol, no?
Yes, so we are doing PRN, ma'am, after that initial loading dose. We are just doing PRN, and that's what this protocol T also did for, so they had this protocol, and those re-injection criteria are all given where, there is any worsening of fluid more than 10% from previous, or there is 3 letters or 5 letters or 1 Snellen line loss, then we re-inject.
Okay. And the last question is that what did you mean by very low threshold for injection?
So any, so if you're not doing a protocol-based treatment, then any little bit of few cystic spaces, or if we feel that, there is a little bit of fluid which is re-arising, then we should re-inject instead of, waiting for it to worsen.
Okay. Thank you, Sabyasachi. Over to you, Paritosh.
Well, to me, as a small-time vitreoretinal practitioner, I think common sense overrides all sorts of protocols. You must forgive me for this statement, but this is what I have followed over all these years. Second is that I use these fundus pictures and OCT pictures basically to emphasize to the patient that the retina is the only place where we can see actually the status of the blood vessels. And this is what would be happening to rest of all the major organs in your body. So I use this as a tool to convince the patient to achieve better control. Third thing is that to me, the injections would be applicable only to center involving DMEs, but it would be, just as a stopgap to give time to the patient to achieve a good metabolic control. And secondly, I usually combine it with laser. I don't just rely upon the injections, because in my experience, for some reason, our Asian Indian eyes, they become sort of dependent, and they keep requiring injections over and over again, where their entire economics goes haywire. Because you must remember that this patient is not only seeing you as an ophthalmologist or a vitreoretinal specialist, he has to see his diabetologist, he has to see his nephrologist, the cardiologist, and so on and so forth. The other most important thing that we must remember is that these patients per se have a higher than normal risk of developing arterial as well as venous thromboembolic events. Anti-VEGFs invariably push up the risk, notwithstanding that some of the studies they've tried to show that, okay, there's no increased risk over a period of 1 year or 2 years and so on. But nobody is really focusing upon all these aspects and morbidity and death risks of the anti-VEGFs over a long-term period, say over a decade or something like that. So one needs to put all these things in perspective. And as Dr. Kopikar very rightly pointed out, we need to decipher whether it is cystoid macular edema or a spongy edema. Spongy edema eyes are the ones where renal function is usually compromised or on its way to getting compromised. So getting all the things controlled, I think, is the best way to managing DMEs. Anti-VEGFs, they will be just sort of a bridge between achieving all these controls. Thank you.
Thank you, everybody, for your valuable inputs, and it was a great presentation, Sabyasachi, and continue to educate us how to read the papers. Yes. It really helps.
Just one suggestion, Sabyasachi is so very good at research methodology and so many things. We have so many vitreoretinal specialists across the city of Mumbai. And fortunately, touch wood, it's a good cohesive group that we have. So if he could take the lead and give us protocols about at least the common illnesses, and we fill in the data, give it to him, then we can have a Mumbai study itself, a real life study of all the various illnesses. So Sabyasachi, please take the lead.
Sabya, we want a Google form in the evening immediately.
Ha. Thank you. Thank you for the wonderful talk. Thank you.
Thank you. Thank you so much. Our next talk is pre-operative anti-VEGF in PDR. And the speaker is Dr. Anand Subramaniam, sir. So after a lot of injections, I think it's time to dive into some surgeries. The screen is visible, but the voice is not audible.
You're on mute, Anand.
Am I audible now?
Yes, sir.
Yeah, thank you, BOA. Thank you, Swapnesh, for inviting me to present my talk. So it all started with Swapnesh telling me that there's a huge session on anti-VEGFs. So by the time they come to this session, that is diabetic retinopathy, people would have been bored with anti-VEGFs, injection after injection. So he told me, tell something about perioperative anti-VEGFs. So it started off with perioperative anti-VEGFs. So then I told him that perioperative, we don't inject after the surgery. So after a little bit of bargaining, it became preoperative anti-VEGFs. So finally, we are starting with preoperative anti-VEGFs. And I have told him that there's very little to talk about in this. So Swapnesh has agreed that he said, sir, aapka sab videos dikha do and we'll all feel happy so that we get some comic relief from this. So my talk here is just to provide you a little bit of anti-VEGF relief so that we can look at some surgical cases and have a little bit of breather between other anti-VEGF talks. So why do we give preoperative anti-VEGFs? That's a no-brainer. I think everybody agrees that it reduces the post-operative vitreous hemorrhage. Chances of NVI and NVG becomes less. It improves our surgical outcomes and facilitates our surgical manipulations. When should be injected? According to the lot of studies which I went through to prepare for the talk, there is a vast variation. People have injected 1 day prior to the injection to up to 20 days prior to the injection. But the most important thing I would say is that when you're injecting the patient should always be having their preoperative fitness and your OR booking should be made so that when you're injecting, you know for sure that after X amount of days, the patient is going to go into the OR. So what are the concerns? Now, suppose we inject the injection a little bit more than a week or 10 days before the operation. What it can happen is that the contraction of fibrovascular proliferation, it will lead to a rapid progression like we call the crunch disease, and TRD will become CRD and CRD will become best left alone very soon. But suppose we inject it too soon, then there is inadequate time for regression of the vasculature and you're as good as not injecting it. So the timing of the surgery is very critical during this. So these are a few of the cases which I did. So just let's go through that. This is what I do. There's no right or wrong. So this is a case of a combined retinal detachment with avascular, fibrovascular proliferations. So we have injected the patient about 5 days before. The modus operandi will be that we truncate the cone, we release all the traction, and then go on to attack the fibrovascular proliferation. What I would like to do is that I would like to get the edges of the fibrovascular proliferation where I'm sure that I have taken out the second membrane. So I would be thinking of an area somewhere near the disc. So I would go around with the forceps. This is an max grip forceps which I'm using. So I would like to separate out the fibrovascular proliferation slowly along the disc. And my main aim would be to relieve the traction around the fovea. So once this is relieved, I'll be happy. So, but for that, I will need to tackle these fibrovascular proliferations as well as the one superiorly. So once I've got the edge and I know that I've removed the second membranes, these are the second membranes over here. I would go and use the cutter and then cut off the rest of the fibrovascular proliferations. This we identified the positive break in this CRD. So these are obviously 4x pictures and forwarded for the lack of time. So all these steps would require a lot of patience, where I would suggest that we take as much time as we want. So in spite of injections, you can see there is some amount of bleeding coming through the base of the proliferations. The most important step in a CRD would be to relieve all the traction around the break. So you have to be meticulous around that. You remove the traction, you free that area, then remove the rest of the traction. So we still have this fold, so I have to remove this traction also to relieve this one. So this is another case of tractional retinal detachment. Again, the principles that we follow are the same. So this, instead of an max grip forceps, I'm using an ILM forceps when I'm not sure that the retina is healthy enough, and when you can see a lot of these sclerosed vessels. So it's a better idea to be very gentle along the retina when you're pulling the fibrovascular proliferation. So I usually try to find an edge between the prolifs and try to go in with my cutter and reach the disc. So if the fibrovascular proliferation is very densely adherent, I also sometimes use a bent 26 or 24 number needle, which can help us act like a pick. So it's just a mix and match of the cutter, of the forceps, and of the needle, where we can go through and remove these membranes. So there is no fixed delamination or segmentation. You try to incorporate all of those into the procedure as and when you can. So again, this proliferation looked innocuous and it looked more fibrous than vascular. But once you're inside, you can see that there's a lot of vasculature. So my take would be that you should be injecting a anti-VEGF in all your dissections of fibrovascular proliferations. Perioperative, I don't think we should need to know why it happens. If it is persistent from the first day, then it is because of the bleed from the residual fibrovascular prolif or the vitreous skirt. If it occurs after about 4 to 5 weeks, it might be related to a sclerotomy fibrovascular proliferation. So our recommendation is that you inject about 5 to 7 days prior to surgery after getting the fitness and booking the operation theatre. I found that DRCR net is having a protocol AB, where they are going to study whether a prompt vitrectomy helps or just anti-VEGF therapy helps for vitreous hemorrhage in PDRs. Thank you.
Thank you, sir. In cases of ERM with diabetic vitrectomy, if it is also required in a particular case, do you leave behind or inject a Ozurdex or inject anti-VEGF or do the vitrectomy with IVTA? So in those cases, at the end of surgery, what are your choices, if at all required, to be injecting an agent at the closure of the surgery?
I do not use tricot for staining the vitreous in maybe 99% of my cases. So if I feel that the cystoid edema and the macula is very boggy, then I would prefer to leave an Ozurdex injection at the end of the surgery. That works very well. And also in ERMs, where you have these generalized spongy thicknesses. So these thicknesses do not resolve very early. So you have to wait for 6 months to a year for it to resolve. So in such cases, also it's a good idea to leave Ozurdex inside.
Great. Would like to invite Paritosh sir his comments on his use of pre and peri-operative anti-VEGFs.
Thank you, Swapnesh. Beautiful videos, Anand. Very nice. And thank you for humoring up the sessions. Otherwise, I agree entirely with you. I cannot re-emphasize what you said at the beginning and at the end, that before injecting the anti-VEGF in such cases, first get a pre-operative fitness and have your OT ready. Because the crunch disease is something which can progress without any predictability, and we should not end up losing the eye. Though, I mean, anti-VEGFs have been a very, very useful tool for reducing intra and post-operative hemorrhage, but there is a slight concern that they might perhaps be worsening the macular ischemia. But then I think when we just balance the overalls, that okay, if we lose less number of eyes post-surgery, you having used anti-VEGFs, I think the balance is in favor of using an anti-VEGF pre-operatively for eyes which have got florid vascularization particularly. The other thing I would just, I'm just going a little off track for some of our younger friends. These closed systems, the MIVS, which all of us use nowadays, they are very useful to limit hemorrhage and to be able to control intraoperative bleeding very beautifully. As you saw in Anand's videos also, that bleeding did occur, but it was not like a spurt which just clouded your view totally. So these MIVS systems are beautiful, and particularly some of us would be using pressurized infusion. We have to be very careful that these diabetic eyes, which end up reaching such bad proliferative disease and TRDs or CRDs, they are extremely ischemic. Their choroid is also extremely ischemic. Optic nerves are also ischemic. So we need to be careful about the pressurized infusion, or the ones who are using raising of the bottle height during dissection. Keep a watch on the clock and intermittently please lower the bottle height to allow perfusion to occur. And this I can say because my first diabetic vitrectomy I will never forget in my life. Beautiful dissection, everything went off well. Next day, the eye looking retina attached, ekdam taka-tak, beautiful this thing, but had gone into no PL. And this had occurred because we probably kept the infusion, but those days there was no pressurized infusion. It was 20 gauge systems. And we probably forgot to lower the bottle height after 3-4 minutes. So please beware of these things. But beautiful videos, Anand, and thank you very much for such a beautiful exposition. Post-operative, I would use very rarely. Those are the late hemorrhages where sometimes you suspect bleeding is from the anterior hyaloid, or where one can see anterior hyaloidal fibrovascular proliferation along with hypotony. So in those cases, before going in again, I would re-inject, but those are very rare in present day circumstances. Thank you.
Quick comments from Kopikar sir and Karobi madam.
Yeah, my only small comment is that I still believe that the maximum possible PRP should be done in PDR patients before vitrectomy, and you should never forget to complete the PRP after the vitrectomy or during endo laser and even after that, post-surgically, because it's a retinopathy. Don't forget that. And most of the problems which occur afterwards, after removing oil, etc., can be prevented by having completed a good PRP. And I think that is one of the take-home messages. Thank you.
A quick comment from me would be that what Paritosh mentioned about ischemia, if you inject maybe 2 or 3 days before the surgery, it's not sufficient time for a macula to get ischemic in that short duration of time. One small question I had to Anand, what would you do in a patient who had neovascular glaucoma with intractable pressures? Would you give a preoperative injection, and what would be your protocol during the intra-op procedure and the post-op procedure in these patients?
And there's no right answer for this. But we would, I would give a preoperative anti-VEGF and wait.
Because the pressure was high?
Even though the pressure is high, because that relieves the angle and helps in the decrease in the IOP.
Would you do a paracentesis along with it?
It can bleed, ma'am. I've done and it has bled also.
I know.
I would try to avoid it at that time. Maybe give Diamox at the same time, but would not venture into the eye when the NVIs are very florid.
Very true. And what would be your procedure be during the intra-op procedure?
Intra-op, we'll try to tackle it how it is, but then I would think these eyes are the ones which might go into sudden hypotony. So I would think of a long-term tamponade in such cases. Maybe fill it with oil and not complete fill, maybe slightly underfill, so that you don't raise the pressure during your surgery. And you need to have a very close follow-up.
What about ablation of the ciliary processes at the time of surgery? Do you normally do it, or
Not normally do it.
depending on whatever the case implies?
If after the surgery, if the pressures are still high, then I will think about it.
And what about the tenacity of the membranes pre and post injection?
Ma'am, I think all of us agree that once you inject, it's easier to remove these membranes. So they even their point adhesions are very pinpoint. Otherwise, you get very broad adhesions. And during the surgery, we find that this acts as your third hand once you give the injections. But we have had certain cases where they have their fitness was lost and we had to operate, say, after 20-30 days. Then the fibrosis is too much. At that time, you can't operate. So ideally, it's 5 to 7 days. I don't think we should wait for more than that.
Thank you, Anand. Wonderful videos you had shown.
Thank you, ma'am.
So we move on to our next topic, and we invite our only overseas player, Dr. Manish Bapaye sir, for his talk on cataract and DME. Sir, you are muted.
Swapnesh, that was quite a quite an introduction for me. And though I realize I am the only speaker from out of Mumbai, I didn't realize it. You guys consider everybody else as overseas. So, right, so I'll just share my presentation. Okay, so I'll be talking about cataract surgery in DME. So take slightly broader topic of cataract surgery in diabetic retinopathy. Is my slide? Are my slides visible?
Yes, sir. Yes, sir.
They are not moving. Just give me a second. I'll just share it again. Okay. So this was a 70-year-old female patient who had long-standing diabetes and BCV of 3/60. We can see that there was fluid in subretinal space as well as in intraretinal fluid was there involving the papillomacular bundle. The patient received 1 dose of Avastin, and the visual acuity improved to 6/36. There was a reduction in SRF. The patient had the intraretinal fluid was still present. She received second dose. At that point of time, the visual acuity was 6/36, and the intraretinal fluid as well as subretinal fluid reduced. The CMT also decreased. The patient was lost to follow-up at this point of time and came back again after 6 months with the again increase in the macular edema and worsening of macular edema with subretinal reappearance of subretinal and intraretinal fluid. Visual acuity had dropped to 6/36, and we can see that all this while the patient had cataract, but I chose not to operate this patient at that particular point of time because we wanted to get the macular edema under control. So the patient was given Avastin again. And at this point, after 1 month of injection Avastin, we took her up for cataract surgery since it was hampering her vision significantly. And the patient's vision improved to 6/18, and there was the subretinal fluid had regressed, and there was cystic changes were seen in outer nuclear and inner nuclear layers. The patient again, since she was doing better, again she was lost to follow-up. This was mainly because her other eye wasn't doing so badly. That vision was maintained around 6/9. So she wasn't probably very particular about realizing that the vision in this eye was dropping. But again, she was lost to follow-up, came back with worsening of CME, and now she was followed up last week after 2 doses of Avastin at this particular in this particular visit, and she is having 6/36 part vision with this kind of OCT picture. The second patient is that of a 57-year-old male patient with long-standing diabetic, having poorly controlled diabetes, has advanced cortical cataract, as we can see in the anterior segment photograph here. Though his visual acuity is pretty good, but the fundus picture is quite advanced. Here we can see that there is some amount of vitreoretinal adhesion. The picture on the left side is pre-injection. There is significant amount of pre-retinal heme, and vitreoretinal adhesion is there, which is after injection there appears to be vitreoretinal separation there, and the pre-retinal hemorrhage can be seen more liquefied, and here on fundus picture we can see that hemorrhage is regressive. So coming to management of patients, I mean, having combined cataract and significant diabetic macular edema with proliferative diabetic retinopathy or without proliferative diabetic retinopathy, I think we have to look at these patients very carefully. Preoperative evaluation wise, we have to see obviously best corrected visual acuity and pinhole. But in these patients with DME, we have to consider doing PAM preoperatively to see the visual potential. There we have to look for correlation between grade of cataract and visual acuity. If there is any presence of neovascularization of the iris or at the angles, thorough fundus examination goes without saying, but one should consider doing retinal imaging and functional OCT scan preoperatively. If the visual acuity does not really correlate with the fundus and fundus picture as well as the cataract, then OCTA is a non-invasive tool to see if there is any distortion of foveal avascular zone. So when do we time the cataract surgery? When we are sure that the cataract is hampering the patient's vision, or the cataract there is a cataract progression like that we could document in first patient, where the vision loss is attributed to it. If it precludes retinal laser treatment like in second patient, or we have to do a combined surgery. We can plan for combined surgery when cataract is significant and there is a additional vitreoretinal procedure to be undertaken. Intraoperatively, these patients often have poor pupillary dilatation weakness. So losing losing the capsular support there is a high chance of that happening. So we have to be careful. It's better to have monofocal acrylic IOL with in the back placement. Keep the phaco energy to minimum possible and avoid iris contact. If there is a the tractional DME or PDR with vitreous hemorrhage, we can do combined procedure. Post-operatively, prolong the use of topical steroids and NSAIDs than non-diabetic patients, your usual protocol that you would follow. Do a serial OCT in post-op period if the patient did not have DME pre-op. We have to, as there is higher chances of pseudophakic CME also, or development of de novo DME, and prompt treatment for these for in case of the same. If you are giving injections, anti-VEGF injections for DME, resume the injections as per protocol in post-operative period. And it's better to postpone the cataract surgery in other eye for a few months to see how first eye is responding. The pitfalls that are the mistakes that are often done are not managing patient expectation, over promising, not telling them about possibility of development of DME, worsening of DME or diabetic retinopathy post-operatively, not correlating with the cataract and visual acuity, not performing OCT, stopping topical medications too early, inadequate anterior vitrectomy in case of PCR, and implanting single piece IOL in the sulcus. The schedule for anti-VEGF therapy to be for how do we schedule the anti-VEGF therapy in perioperative period? Aim to reach the steady treatment intervals for anti-VEGF before planning cataract surgery. Plan injection 4 to 10 days prior to cataract surgery. Continue treatment in post-op period as per schedule. There is no, according to this study in Journal of Ophthalmology, there is no statistically significant difference in CMT and visual acuity whether you inject pre-intra-op or post-operatively. And consider one can consider using intra-op Ozurdex in case of refractory DME with visually damaging cataract. Thank you for your attention.
Thank you, sir. And sir, quick comments from all three experts.
Yeah, one thing which one has to emphasize to the patient is that they may get a CME later on, after 3 months, 6 months. And studies have shown that sometimes the CME peaks at 6 months post-surgery, at which time the doctor or the patient might feel that the surgery is something remote because 6 months have elapsed, but then it starts afterwards. So this is also linked to further deterioration in the diabetic status sometimes. So one should warn the patients to, if they are in that group who are likely to get it, if you feel, then you must continue some topical NSAIDs for a long time. And you should also warn them to report at the first onset of any visual symptoms.
Sometimes we get, like in the second case, you observed that the patient started throwing up hard exudates. Now, whenever hard exudates are there, and plus it was mainly intra-retinal, it was like a combination of cystoid and spongy edema on OCT. So these are cases where an addition of initially, say, steroid eye drops like difluprednate, and eventually, if required, a steroid implant, if the patient is not a glaucoma patient, then that would help. So wherever you start seeing hard exudates, it's an indicator of superadded inflammation. Steroids should be added.
A small comment that if you have a diabetic in whom you're going to do a cataract surgery, it would be advisable to do, especially if the visual acuity does not match what is the kind of cataract that you're getting with not much of reaction inside. It would be advisable to get an FFA done, because a lot of cases of macular ischemia present with low vision and one might think it is because of the cataract and go ahead. Also, a very guarded consent has to be taken from these patients before you go in for surgery, and they also have to be told about the need for further laser or injections post-operatively, because many times after the procedure, as Dr. Hemang also said, you get a rise in the CME status. And I just want to have the view of everyone, like in a patient who's having a diabetic macular edema, what would be your stand? Would you like the patient to be near dry before you venture into a cataract, or you would do it as in one of the cases which Manish showed, where they were still intracystic edema and they went ahead with a cataract surgery?
I'd prefer as much drying as possible. And same holds good for PDR cases also, that I'd like the eye to be quiet, well lasered before any surgery is done on that eye. Yeah, because that reduces your risk of recurrence. And even if recurrence, which is not very uncommon in these cases, at least the amount of edema that will recur, it will be relatively limited, both in time as well as in quantity.
Madam, in this case, the first case that I showed, it was actually avoiding proper examination. I could not do proper examination, and it was worsening significantly. The patient was visually getting more symptomatic. So I waited still for 6 months with the hope that the macula dries, but she's so irregular with her follow-ups. So at some point of time, we have to bite the bullet, and then with explaining that we are to continue with the treatment post-operatively, I had to do it at some point of time.
Did you couple it with any intravitreal injections, either Ozurdex or anti-VEGF at the time of surgery, or what did you do after the surgery? Because there was some treatment which would be warranted.
So as I said, I had informed her that we have to do, I gave her Avastin pre-operatively, and I had told her that we need to do it post-operatively, maybe after 2 weeks. But again, the patient is irregular with follow-ups. These patients who are not very good with their systemic status and poor with follow-ups at all the doctors for whatever reasons, maybe financial or logistical reasons. We have been going through pandemic, so people did not have time. And another problem that we face in overseas, as Swapnesh said, is that people come from rural areas, so there is a bus strike going on. So there are so many factors which are there. The patient has been little irregular with her follow-up, so she did not come for follow-up in post-operative period for injection, even though it was explained to her.
See, Manish, the only reason why I ask this question is because in this day and age where doctors get beaten up unnecessarily, it is very important for your own safety, that the patient knows very well what the condition is and what to expect. Because many times the minute you touch a patient, they expect that, the modicum of vision should be absolutely perfect, which is not the case. And however much you tell them, it sometimes, they listen to only things which matter to them, not what they would not like to hear. So that's the reason why a little bit of restraint and a little bit of caution and a very, very proper guided detailed kind of consent form needs to be taken in all these patients.
Absolutely agree.
Yeah, I second Karubi. I agree entirely. Not only in these pre-operative patients, but in general amongst diabetics, the role of counseling is the most important, because that is what is going to get them on track in the long run. And in fact, there was a study, the SPEEDS group of studies in India. It showed that counseling at the local village level by the ASHA workers, that in fact proved to be the pivotal point in turning things around for patients who come in from the villages. So those of us who have those kind of patients coming in from rural areas, please consider roping in those ASHA workers also into the counseling thing. Second thing, in a lighter vein, sometimes I have even gone to the extreme step or extremist step of asking the patient and relatives to write down what is it that they have understood from the long bhashan that I have given them. And if I find that they've missed out most of the points, they've heard only what they wanted to hear, I repeat it and I ask them to write it down again. And that then becomes a more stronger document as compared to our standard consent forms.
Yes, you can preserve what they have written, and what rewritten.
Madam, in such patients, we have to assess these patients if they are very demanding, then probably they're best sent elsewhere for higher centers, because then they don't have too much expectation or बहुत बड़े डॉक्टर है 10 मिनट भी नहीं बात की टाइप से
send it to your enemy.
Arobi, there are no enemies. There are no enemies in our vitreoretinal fraternity.
No, certainly.
All are friends.
Dr. Anand Subramaniam has snatched my question, and he is asking role of EDOF versus MFIOLs in diabetic cataract. So, Bapai sir, how do you choose if suppose it's
very
a 10-year-old?
simple. You don't choose either of them.
No, I'm asking a situation where a 10-year diabetic, and you have done a OCT, fovea is absolutely okay, very mild non-proliferative diabetic retinopathy. Would you hesitate to put a MFIOL?
Yes, I would. Any clinically seen or clinically visible diabetic retinopathy, I would very strongly discourage the patient from having multifocal or EDOF lenses, because these patients are at higher risk of developing CME, which can come back to you at in 2 points. One, they can't see well, and usually these are patients who have very high expectations out of surgery. So if there is any clinically visible diabetic retinopathy, I don't put any of these lenses. But if the patient is extremely well controlled diabetes, have for few years, not very long standing diabetes, no diabetic retinopathy, macula is absolutely clear on OCT, and if the patient is asking for it, I might consider. But I wouldn't really volunteer and tell the patients to put a multifocal IOL in diabetics. And certainly, I would definitely discourage them in scenarios that you told.
Okay.
Very well said, Manish. Good.
Thank you so much. And in true IPL flavor, that was the most valuable player, which was the overseas player. So our next talk is Ziv Aflibercept or Aflibercept in DME by Dr. Hasnain Shikari, sir. Sir, can you please share your screen?
Okay, so is that visible to everyone?
Yes.
Yes, sir.
Hi, good afternoon, everyone. So I think it's been quite an enlightening morning and afternoon, and everyone has already, talked a lot about the benefits of Aflibercept or Aflibercept. I'm just going to quickly go through the details of Aflibercept, Aflibercept. Essentially, Aflibercept is a recombinant fusion protein of two extracellular domains of VEGF. So basically, it binds VEGF-A, VEGF-B. Also, it binds to placental growth factor. Since it has the highest VEGF-A binding affinity and also binds placental growth factor, it's supposed to have a better benefit as compared to Bevacizumab and Ranibizumab. And also, the inert complex is degraded slower compared to the conventional anti-VEGF, so therefore it's more efficacious. Now, Aflibercept is a cheaper recombinant fusion, which is identical to Aflibercept. It's in a lower concentration, so when we're injecting 0.05 ml, we're actually injecting 1.25 milligrams of the drug, as compared to Eylea, which turns out about 2 milligrams in 0.05 ml. It's interesting to note that Eylea has been formulated for the eye, and therefore it comes at the isosmotic concentration of 300 milliosmoles per kilogram. Zaltrap has been used in oncology, and therefore its concentration is 1000 milliosmoles per kilogram, but the effective concentration when we inject it into the human eye comes down to approximately 312 to 330 milliosmoles, so it's pretty isosmotic. The US FDA has now approved Aflibercept for DME also, and the use of Aflibercept is off-label. So the in vivo and in vitro evidence shows that the levels of placental growth factor is responsible in the pathogenesis of diabetic retinopathy and diabetic macular edema. And that's one of the reasons why Aflibercept may prove to be a little more efficacious in treating patients with DME. There have been studies, the Vivid Vista DME studies, which have basically looked at the role of Aflibercept versus the others in diabetic macular edema. The DRCR-NET protocol T results prompting the use of aflibercept in DME are with especially with poor vision have shown to be have shown good results. They show that no difference was seen in average visual improvement. I'm sorry, they showed that patients who presented with worse vision, aflibercept produced a greater average visual acuity gain at 1 year than bevacizumab or ranibizumab, and this was not seen in patients who presented with relatively good vision at baseline. In terms of real life effects, Apollon study, the prospective observational cohort study, there were two groups, basically the treatment naive patients and patients who were treated with anti-VEGF. It's a 2-year study. The 1-year results are out, which show the overall improvement in visual acuity in treatment naive versus previously treated patients, but both cohorts had comparable improvement in vision as well as in anatomic outcomes, which basically showed that there was a decrease in the subretinal and intraretinal fluid. The Aqua trial was basically done to show improvements in vision-related quality of life outcomes in patients with DME. So patients who received aflibercept showed clinically meaningful and patient-relative improvements in the NEI visual quality of life, 25 total scores. There was an improvement in subscale scores for near and distant vision and improvement in visual and functional outcomes over 1 year. We all know that aflibercept has been shown to be safe in human eyes as well. So now coming to cases, these are cases that I've had over the last maybe 3 to 4 years. And the first case is a 65-year-old male patient who had been a diabetic since 15 years with fluctuating control. When he presented to me in November of 2018, he came with very poor vision in his right eye. Vision was about 6/60 and 6/18 in the left. You can see that he has quite a macular edema with subretinal, intraretinal fluid, and quite a lot of disorganization of the retinal inner layers as well. This patient started off receiving intravitreal Avastin. He got 3 injections and also received PRP 4 sittings for very severe NPDR. His vision at the end of the 3 injections remained 6/60 in the right eye, but had improved to 6/12 in the left eye. At this stage, he received, he had now received 4 Avastin injections in May 2019. He had no change in the best corrected visual acuity. He had good glycemic control. His systemic profile was unremarkable. So at this stage, I offered to switch him to aflibercept. So in July, post 2 injections of Zaltrap, the patient's visual acuity had improved to 6/36 in the right eye, partly also because he had a little bit of a PSC cataract. And in the left eye, the vision had improved to 6/9 part and N8. But there was still that little bit of fluid that, continued to remain intraretinal. So, a thorough evaluation of his diabetic medications, we recommended that he switch from glitazones to other classes of oral hypoglycemic agents in concert with his treating physician. This patient, unfortunately, was lost to follow-up post July 2019, and so I don't have any further follow-up from him. The second patient, also a 69-year-old male, long-standing diabetic. He presented with cataracts. He had already had laser done prior to cataract extraction with Ozurdex implant. So now in October 2016, 1 month post-cataract surgery elsewhere, he developed a center involving diabetic macular edema with a decrease in the best corrected visual acuity, 6/18 in the right and 6/36 in the left. Post-cataract surgery, his vision had been 6/9 and 6/12 right and left respectively. So this is the clinical picture of this patient in October. And post-intravitreal Avastin 3 at monthly intervals, his OCD picture improved, vision improved to 6/9, 6/18, no intervention done at this stage. After a waxing and waning course, patient lost to follow-up. He received Ranibizumab in October 2017 for recurrent DME with drop in visual acuity. His vision came back a little bit, went back down again. So he's basically had a waxing and waning course. He underwent Bevacizumab with Tricot in the both eyes in August 2018. Again, lost to follow-up for some time. He comes back with vision 636 and less than 660 OD/OS. Again, subretinal fluid, intraretinal fluid. He underwent Ranibizumab into 3. No improvement. We switched him to Eylea, and after Eylea, his vision improved to 612 N10, 636 N24. Just the last few slides. And in July 2019, his vision was 6.9 part, 636 part, also because he had a little bit of macular scarring now in the left eye. And the last case, long-standing diabetic, diminished vision post hypertensive syncopal episode, moderate NPDR OU. He had only diabetic macular edema in the left eye. So these were his pictures. He underwent Avastin, showed improvement. The visual acuity improved to 618. Patient was lost to follow-up. He presented in March again, 21, with low vision in the left eye. He was switched from glitazones, strict glycemic control, given Zaltrap, vision improved, again lost to follow-up, presents in September 21 with similar vision, but the OCD showing increase in the fluid. No intervention was done at this time. He then was lost to follow-up again, comes in January 22, vision maintained at 618 despite OCD showing an increase in the macular edema. This patient again has been lost to follow-up, so he's technically been dictating his own treatment. In summary, aflibercept and zivaflibercept definitely as good as existing anti-VEGFs, but is it better? I think it is, because it relaxes the dosing to 2 monthly. In my opinion, I call that pandemic friendly. It decreases the need for laser, better outcome in worse visual acuity at baseline. Switching has shown improved outcomes. Zivaflibercept in comparison to Eylea is cost effective, though now with Eylea for you, the patient assist plans, the injection prices have come down, and safety is not a question. Thank you for your attention.
Thank you, Dr. Shikari sir. I think even in my practice, the use of Avastin has gone down, and predominantly Zaltrap is the shared injection which is offered to my patients. I would like to invite the senior's opinion on the same. Paritosh sir, what do you at all use Bevacizumab nowadays, or you have totally shifted on to Zaltrap?
No, I don't use Zaltrap at all. After all the imbroglio which occurred with Avastin, I have just taken a policy decision not to get into that janjat, and I don't use any of these molecules. So I stick to Ranibizumab or biosimilars if the patient wants, and I stick to aflibercept. So this is what I have no experience whatsoever with Zaltrap in my own hands. So I have seen some, patients treated with Zaltrap by others.
I have been using Zaltrap quite often, and I find it a good molecule. And even cost-wise, with whatever assisted plans these people have, it doesn't measure to the kind of cost that you would give with a Zaltrap, because it's a 45,000 vial and you can make almost 20 injections out of it. So it really doesn't match up, and it's a good molecule. It works quite well. And the currently Brolucizumab is also a very good molecule, because where you want a drying effect to occur, it generally sort of does it very well. And I have given it to quite a few diabetic patients also with really good results. Means what we were not achieving with the other anti-VEGFs, we managed to get it with this thing. Hasnain, just one question. See, you showed 2 patients where somewhere midway you had stopped the glitazones. In the first case, was it glitazone related CME? Because in the second, definitely it was glitazone plus the anti-VEGF which was given. But in the first one, do you think that the anti-VEGF played any role in the switchover? Played any role, because he was on glitazones, and that could have been the causative reason for the macular edema?
So, ma'am, his macular edema did go down after switching from glitazones, but unfortunately that patient was lost to follow-up because we came across the pandemic at that point in time. So I don't have any concrete evidence that switching over from glitazones helped him get rid of the edema, at least the OCT edema, or improvement in visual acuity. The second patient, definitely from switching over from glitazones, his visual acuity remained the same, even though the macular edema continued to show an increase. Now, again, this patient was dictating his own treatment. I mean, his vision was preserved. So there was absolutely no way that we could convince him to, go ahead with another injection. I'm guessing, if his vision goes down is when he's going to probably come back and want an intravit.
Okay.
Madhu has also posted that he prefers using Zaltrap, especially pre-operatively. It works better than Avastin. Madhu, if you can unmute and just quickly share your comment. Okay, we'll move on. Our next topic is by Dr. Madhu. Yeah, you're online. Please. We're waiting for your comment. You are muted, Madhusadan. You are muted. Just remove the headphones and speak without it.
Hello, can you hear me?
Yes.
Yeah, no, I happen to have a few patients who were bleeding quite profusely despite giving Bevacizumab for PDR. That's what prompted me to try Zaltrap in these patients, and I thought it worked quite well. I had a pretty good experience, nearly bloodless surgery. So though it's anecdotal, I've not used it for more than 3 or 4 surgeries, and this is also in the last 2 months.
Great. So moving on to our next topic, it is by Dr. Yogesh Patil, and he would be speaking on Aflibercept in DME management. Yogesh, are you there?
Yeah. Is my slide visible?
No.
Yes.
Yeah.
It started
So
screen
at the
sharing.
onset, thank you, Swapnesh and BOA, for providing this opportunity. I'll be speaking on Aflibercept in DME, evidences versus what are the real world evidences say. So I will be telling to inject more when we have already injected so much in all the previous talks kind of. So the treatment is usually initiated, the posology of Aflibercept treatment in DME is inject every month for first 5 months, and then every 2 monthly for first year, followed by the PNR schedule depending upon the anatomic outcome or depending upon the visual BCVA. So the landmark studies were Vivid and Vista. They studied the efficacy of Aflibercept in patients who had visual impairment because of the DME, and the subgroups were divided as visual acuity 612 and better, whereas the visual acuity worse than 612. Patients were randomly divided into 3 groups where laser photocoagulation was offered in 1 group, Aflibercept at every monthly interval for first year, and Aflibercept loading dose of 1 injection a month for 5 months, followed by the 2 monthly injection. And all the analysis showed the rapid visual gains were achieved, which were very early with intensive Aflibercept treatment in year 1, and they were subsequently maintained over a period of 2 years as well as over a period of 3 years, and the number of injections gradually reduced in year 2 and year 3. Second landmark study was Protocol T, a part of drcr.net. Randomized head-to-head trial were done between all the 3 molecules available currently, that is the Aflibercept, Bevacizumab, and the Ranibizumab. And what did we got evidences from it? Whenever the visual acuity is worse, that is 612 or worse, Aflibercept molecule was quite superior in maintaining the visual gain at the end of 1 year, and simultaneously the superiority were extended over a period of 2 years with requirement of fewer number of injections between 3 to 6. Same kind of an outcome were also observed in regards to the anatomic change, where the robust reduction in the central macular thickness were observed with Aflibercept at the end of a year, and same got extended with fewer number of injections at the end of 2 years. Subgroup analysis, when the visual acuity, as I already told, was less than 612, aflibercept molecule was far superior in management of the diabetic macular edema at the end of year 1 as well as at the end of year 2. Whereas in a subgroup where the presenting visual acuity was 612 or better, Ranibizumab was almost equally effective or little far superior at the end of year as well as at the end of 2 years, but the difference was not clinically significant. Sorry, the statistically significant. In protocol T, the patients treated with aflibercept experienced considerable anatomic resolution of the macular edema also, and that was significant when the macular, the presenting visual acuity was worse than 612. So another comparison was done in number of patients who require the additional lasers besides our anti-VEGF treatment. So the fewer percentage of the patient require the additional laser treatment along with the anti-VEGF in aflibercept arm compared to the Bevacizumab and Ranibizumab. Bevacizumab group required the highest percentage of the patient where the additional laser was required. A significant proportion of patients, as I said, require the laser treatment at the end of year 1 as well as in year 2, and the number of patients requiring the laser was significantly lesser in aflibercept group. There were also criteria where they studied the disease severity score. So in eyes where the DME was treated and they had a PDR at the baseline, the improvement in the diabetic retinopathy severity score was quite superior with aflibercept group compared to the rest of the 2 molecules. The number of injections gradually reduced with subsequent passage of the weeks in the year 2 as well as in the year 3 in all the groups, but the reduction in the number of groups was, the number of injections were far superior in aflibercept and Ranibizumab compared to the Bevacizumab. Now these were all the evidences what we had, but what the real world is showing kind of, and so several studies have been done till now. And the biggest was the Apollon, and it pretty much conquered with the Vivid as well as the Vista studies, where the aflibercept started early and treated kind of an aggressively, showed a quite a good amount of an visual improvement compared to the rest 2 molecules. And another finding what we got in Apollon study was if the treatment naive patients compared with the patients who were treated with other molecules earlier, so treatment naive patients have showed a significant improvement in the visual gains compared to the mix and match kind of an or with the switch therapies. Luki et al. Has also showed us the same thing. Aflibercept was associated with meaningful increase in the visual gain, and the chances of decrease or a loss of letters were significantly lesser in their clinical practice. I'll skip this one. And finally, the compost polo, they were the first one who showed the aflibercept effectiveness in posology of the DME in the real world, where every month first 5 injections were given, followed by the 2 monthly injections, and the clinical outcome as well as the meaningful change in the best corrected visual acuity was pretty much concurring with the Vivid as well as the Vista studies. Cochrane meta-analysis is the landmark analysis done, which has compared all the data from the real world evidences, compiled it, and showed almost the concurring evidences with all the other studies done till now. So I will quickly go on to the take home from all these studies as well as from the real world experiences is key. The worse visual acuity, that is 612 and worse than that, responds best to the aflibercept treatment. It is mainly because of its higher affinity to bind VEGF-A and PGF, and leads to the disease modification. So the pretty much good molecule in treatment of the diabetic macular edemas. Thank you.
Yeah, thank you, Yogesh, for that detailed presentation. And we have been hearing all day how effective aflibercept is, and especially in very, very difficult cases also, it has proven its worth. Would like to invite quick comments from Dr. Paritosh sir, Kopikar sir, and Parvi madam.
Basically, because it's a molecule which lasts for a longer time, and because diabetics in general, because not they have higher levels of VEGF which need to be suppressed. So aflibercept understandably works better as compared to ranibizumab in non-tractional, moderately severe or severe DME cases. However, the risks of side effects also would be of vascular events would also be greater. Theoretically speaking, though none of the studies has been able to bring that out because they were not enough powered for that. I think that's about it. Please let the others make their comments.
A quick question to Yogesh. Yogesh, in the number of cases that you treat for DME, what would be the percentage of patients that you would like to inject with aflibercept?
In DME, we are talking about.
Yes.
So it's basically, as some of the real world evidences have shown, the treatment naive cases has responded very well, but still my first molecule of choice is always a ranibizumab or bevacizumab, and when it goes to the something called as resistant or non-responder, those are the cases where I switch on to the aflibercept which comes out to be something like 25 to 30%.
Thank you.
Okay. So we move on to the next
That's a
topic.
high number, I feel. I don't think there are so many, at least in my small practice. It's too high a number to say that so many are resistant to other treatments.
So with the permission from our experts, we had a missed lecture in the previous session, which fitted into either sessions. So we would like to hear about the safety of this drug. And we have Dr. Nishant Kumar sir to present this, choosing the right anti-VEGF.
Thank you so much, and thank you, Swapnesh, and everyone organizing at the BOA, and lovely to see everyone's faces again. Lovely to be here. Sorry for having rescheduled. So choosing the right anti-VEGF, we've had lots of talks on efficacy. I'm going to focus on safety. This is actually a 1-hour talk, so I'm going to go really quickly. So just remember, safe. What is it safe for? For safety for the patient, what are the adverse reactions? What are the drug-related issues? What are the procedure-related issues if they're different procedures we're comparing? Is it safe for the doctor? So is the doctor indemnified? Do you have support from your peers? Are the professional bodies supporting the practice that you're doing? What is the support from the manufacturer? Is there any legal precedent to get either sway you one way or the other? That's the safety for the doctor. And what about the safety for the manufacturer of the drug? So some drug companies don't want to stand by the drug if you're using it for ocular. So a good example of that is Roche. What is the manufacturer's legal standpoint? Have they kind of said that, listen, these are known side effects. So if you're using them, you knew about the side effects, and it's between you and the patient. So everyone has a safety role. It's not only the patient, the doctor, but even the company. And safety kind of, envisages all of them. I'm going to start with Avastin. I'm trying to give you an overview or meta-analysis of safety data. We all know that there have been outbreaks of infection of Avastin all over the world. Even when there are compounding pharmacies readily available, we have that, right? In India, we know that there are no compounding pharmacies at all. Roche does not want to sell the drug, and we've had issues with spurious drugs. Just to summarize everything with this drug, Avastin is off-label, but that's absolutely okay because a lot of things we use are. The problem is that Roche actually puts on the drug on the box that not for ocular use. It doesn't sell Avastin directly to ophthalmologists, giving space for a lot of spurious drug, which we've had before. If you've seen the AIO's VRSI guidelines, they're almost impossible to adhere to if you're in private practice or if you're in a small institution. Their kind of guidelines are very difficult to follow. We know that there's no compounding pharmacy in India. There's no indemnity from insurance or hospital if you're using off-label or drugs which have got problems. There is some legal precedence with Avastin use where people have got into trouble. And I worked in the NHS where the Queen was responsible for everything I did. Out here, unfortunately, neither the President nor Mr. Narendra Modi take crown indemnity. So we know that we've had clusters of lots of cases of endophthalmitis. Normally, it's because one drug kind of one vial is split. We know that the government banned Avastin. VRSI guidelines are very difficult to follow. There's intense media scrutiny and the headlines are very sensational. Oncology drug given in the eye causes blindness. It takes years to recover from that kind of reputational loss. Also remember that most of the leading eye hospitals in the country, especially PGI, etc., are now no longer using Avastin. So you're not going to get their support if you are using it. And good intentions are not a defense in court, and there's lots of previous litigation with Avastin. Regarding Zaltrap, this is again a huge talk in itself. There are very few publications on safety which have looked at ERG, etc., but these are all very small studies. The issues with Zaltrap, and one day we can do this talk in detail, is that there is a problem with osmolarity. There's a problem with drug concentration. There's a problem with particulate matter, and there's a huge problem with endotoxin levels. So if you put all of this together, Zivafirabricab may not be as safe as we think it is, but that's a talk for another day. When we come to the licensed products, we got Ranibizumab, which we all know has kind of had lots of problems initially. When it was first launched, it was a lyophilized version. So you had to actually reconstitute the drug and then give it. Then they changed the whole drug, and it's available in its current form for a number of years now. This is kind of, most probably the most scrutinized drug in ophthalmology, at least intravitreally. Multiple large trials, there are more than 10,000 people enlisted in phase 3 trials with Lucentis. And what we know is that even today in India is yet the highest selling licensed anti-VEGF. If you look at the real world data through Luminous, the ocular significant or serious adverse events is less than 0.9%. The rate of inflammation is less than 5 per 100,000 injections. And so far, there have been no reports of vasculitis or occlusive vasculitis. When it comes to Eylea, this again, a drug has been available for more than 9 years, more than 5.2 million years of exposure, more than 37 million vials sold. It's the gold standard treatment for PCV, DME, and exudative AMD for most leading centers and most kind of gold standard centers in the world. If we just look at the VIEW studies, if you look at the endophthalmitis rate between ranibizumab and aflibercept, it's 0.8% and 0.3%. So that gives you some confidence. This is not per injection, it's per patient, where patients get multiple injections. So less than kind of 8 per 1,000 patients or 3 per 1,000 patients of aflibercept, which gives you some confidence. If you look at the intraocular inflammation rates with ranibizumab, it's about 0.41% or 40 cases in about 9,800 odd injections. And with aflibercept, it's 0.28%, so even lower, 74 cases in 26,366 injections, which again gives you a lot of confidence that the kind of rate of inflammation is very, very low, and there was no case of occlusive vasculitis. Again, when we look at this, all the clinical data put together in all the clinical trials with aflibercept, that N is 3,236, so very good N number. The rate of vasculitis in the clinical trials was 0.06%, and none of them were deemed to be occlusive vasculitis. If you look at kind of post-marketing surveillance, the risk of vasculitis is actually 0.0003%. So far, 10 cases have been reported in the 37 million vials sold. Obviously, there's some underreporting, but even if you multiply that by 100, yet the rate is very, very small. And the rate of endophthalmitis and non-infectious endophthalmitis in routine clinical practice is yet very small. It's 0.7 cases per 10,000 vials sold, telling you that the rate of inflammation, both infectious and non-infectious, is very, very small. And in routine clinical practice, the rate of intraocular inflammation is again very, very small. And even if you think that there's some underreporting, if you multiply that by even 10, the cases yet remain very, very small. There was this episode of inflammation with aflibercept, which was noticed in America. These are the timelines. In 2018, there was a kind of study group put on because there was a huge cluster of kind of inflammation noted. And what they realized is actually it was the syringe and not the drug. So some manufacturer had changed the syringe which was given with the drug. That syringe was kind of giving kind of silicon droplets, which is causing the inflammation. So what you got to understand that when you give an intravitreal injection, there are multiple factors that could cause inflammation. It could be drug related, it could be procedure related, because if you just change one consumable like the needle or the syringe, that could have an impact on kind of, inflammation. And obviously we know that the intraoperative, post-operative, and patient-related factors. Now, when we look at brolucizumab, which is a new kid on the block, Hawk and Harry are the two big studies. When you look at the initial data, the serious adverse events were much higher in brolucizumab than aflibercept. So 3.3% versus 1.4% and 3.5% versus 1.6%. When you looked at this in slightly more detail, you notice that the inflammation rate was 5.8% versus 0.6% and 3% versus 1.1%. And when you looked at the rate of retinal artery occlusion or an occlusive vasculitis, it was again much, much higher in this group. But the get out card was that if you looked at the people who were losing vision, so if you looked at people who lost more than 15 letters, it was similar across all groups, and therefore this wasn't looked at any further. But if you just look at that kind of data that they'd reported, the serious adverse events, if you combine the two trials together, was about 2 times higher with brolucizumab than with kind of aflibercept. Intraocular inflammation 5 times higher, endophthalmitis 7 times higher, and retinal artery occlusion 8 times higher. The problem was that they didn't comment further on the kind of rate of vasculitis and didn't look at it further. And in the real world, then we saw that there was lots of trouble with this drug. So when they reviewed the data again, what they found, ASRS did this independently, they found that actually the rate of inflammation with brolucizumab is 4.6%, the rate of vasculitis is 3.3%, and the rate of occlusive vasculitis is actually 2.1%, much higher than initially reported. So if you read this data and you saw all the risk of visual loss was very small, but if you looked at the subgroup that actually had the problems, the rate of visual loss was about 16%, 23%, and 30% if you had inflammation, vasculitis, or occlusive vasculitis. So just remember the 4.6% get inflammation, but out of that 72% develop a vasculitis. And out of that 72%, 64% actually have an occlusive vasculitis, which is huge. And I think I'm out of time, but actually Phil Rosenfeld said this drug should have been withdrawn from the market before more people go blind. So just remember, mean inflammation loss actually happens 35 days post-injection. It doesn't happen in week 1, week 2. The mean range was up to 2 months, 14 to 56 days later. And visual loss is a very real thing if you have vasculitis or inflammation. And just remember, there are consequences. If you have these problems, you are responsible for the drug you choose, so choose wisely. Sorry, this was very, very rushed because there's so much of data to talk about, but I'm done with my presentation. Very happy to take questions and very sorry for overrunning by 30 seconds.
Thank you so much, sir. And I think it was a very interesting talk, and we would definitely need a longer session to give justice to that topic. Kopikar, sir, your comments?
Yeah, it was an excellent talk. And I think that apart from being a gourmet and an epicure, I think you will make an excellent news reader also. You have condensed everything so nicely. Congratulations.
Nice. Thank you, Kopikar. But actually, the data is so much, it's very difficult.
You covered everything. I was listening very intently to it. And I think you have covered everything excellently.
Thank you so much.
I must congratulate you for that.
You're very kind. You're very, very kind.
Nishant, nicely given talk, very specific and condensed very well in a short time. Only thing is that, you know, the rates of IOIs with brolucizumab is much lesser in the Indian scenario as compared to what it is in the West, because where you show this of 3.3 and 4.6%, it's almost about 0.54% here in the total number of Indian patients, which ranges to about 6,500 or 7,000 patients which are injected so far. So I think probably the highly pigmented eyes have a little different status of response to a particular anti-VEGF. So our scenarios are a little different, you know. But apart from that, very nicely given talk.
So, Karobi, can I just bring back a point there? I know that this has been said a lot. We've done a study of the first 150 brolucizumab injections given in the country, and the rate of inflammation is actually 7%. Right. So actually, you know, this is a documented double blind. No one was kind of, you know, and I don't know whether you were part of the study, but a lot of the people who are on this panel have actually responded to my survey. The surprising thing was there are 2-3 people out here who I shouldn't name because they requested anonymity, correctly so. They kind of reported that, Nishant, I given the injection 1 week ago and there's no inflammation. And about 4 weeks later, they called me back. Can I change my response? Because that patient has now come back and there's definitely vitreous cells and there's vasculitis. So I think this thought that we are the protected race, you know, I heard this about COVID also. Okay, India mein COVID itna nahi hoga because, you know, we're somehow protected. It doesn't work. The whole world burns. We also burn. The inflammation rates are at least 5%, if not higher. We can kind of, you know, live in a la-la land and we can listen to whatever data. But if you look at the pure data, if you look at any survey that's been done, why would we be protected, Karobi? Why would it happen in kind of Hispanics and Black people, but not happen in Indians? Why would it happen in Caucasians? I think there's a problem with the drug. Now, the drug has an issue, and that's fine. Some drugs have an issue. I don't use brolucizumab. That's my kind of hands-up kind of approach. I've got about 10 samples lying, and I've been convinced a lot to use it, but I don't use it because I don't think it's worth the inflammation risk. And if you develop occlusive vasculitis, that's the end of the story for you and for that patient. So when you develop, just remember, inflammation doesn't happen at week 1, doesn't happen at week 2. It can happen up to 2 months after your initial injection. How many of us follow up our patients regularly? If you're giving brolucizumab, most people are following their patients up on day 1, week 1, week 2, 1 month, 6 weeks. If I give another anti-VEGF, whether that's ranibizumab or aflibercept, I give them an injection, I see them on their next treat and extend appointment. I don't do all these things. So we're all worried about inflammation, and it really does happen. I know I've heard a lot of people, and I think this has been spun around that, listen, no, the inflammation is not there. I've done a study, it's definitely there. If you speak to some doctors down south, they will tell you that in their first 19 injections, 9 of them had inflammation requiring topical steroids. So if you ask people very honestly, they will tell you, actually, because I'm worried of inflammation, what I do is I give them a bit of Pred Forte with the steroid. I don't use any steroids in my intravitreal injections, but you're giving the steroid to mask an inflammation. So I think the rates are 5% minimum, maybe higher, but in our study, at least that's what we found. And
see, granted, we agree with you that the inflammation doesn't come on immediately, but it comes on about 30 days to 6 weeks interval. That is a general course of time that the inflammation surfaces. But what we have found is that these inflammations are these are not like kind of very severe kind of things which require any kind of vitrectomies, because either institution of topical steroid antibiotic drops, or if it is a little more severe, then some steroid course generally helps to alleviate these kind of things. The kind of severe vasculitis is a very, very, very small number, which
2%,
is probably
2%, correct.
But it's not something which is not manageable. And see, the thing is, at the end of it, there are other anti-VEGFs also which we have used where we have got inflammations. So it is not as if there is one anti-VEGF which has inflammation and the other which does not. So it is true for.
Why would you take the risk? My question is that it was a non-inferiority study, so there's no ways it can be better. That there's no data to suggest that it's better in any form. Visual point of view, anatomically point of view, you can look at the subretinal, intraretinal, but when you look at it all, what's important, there's no difference. So why would somebody want to take a?
Molecule is a very small molecule. I've used it in quite a few patients, and the results are really good. In fact, the thing is that because it is just a 26 Daltons size of the molecule, it penetrates and it helps in quicker drying of this with much longer intervals of re-injections, which is a major thing for that, which goes as a plus point for that molecule.
Because it's a smaller size, actually it gets out of the eye much quicker. So actually, if you look at the pharmacokinetic and dynamic studies, the duration of effect will be much smaller because it's a smaller molecule. But but I agree. I think it's important that I love the fact that we have it in India and we have a choice to give it or not. I think it's important to kind of know that there are risks with a particular drug which are much less with others. And if we yet feel as an individual treating physician that there is a value in using it, but just remember that if a drug is 8 times more likely to cause retinal artery occlusion, 7 times more likely to cause inflammation, I don't know, I kind of feel a bit hesitant using it because it doesn't have any much more safety efficacy issues. Yeah, if it did something dramatic and improved vision by 10 letters more, I think we'd accept it. But vision results are very similar. But that's my personal opinion. And I think that's the global opinion today.
No, I will not agree with you where the vision results are much better.
But on which study? Hawk and Harris showed that in 4 points.
This is my personal thing.
That's okay. That I agree.
I'm talking from a personal user point of view. And the thing is that is what matters to me.
Fair point. No.
The studies may say anything, but it is what my individual thing is which matters to me when I prescribe an anti-VEGF of any of my choice to a patient.
No, of course. And the good thing is that but the thing is you're a KOL, so so we listen to you, and we obviously are very sweet. Now, if you tell me, Nishant, I've used a lot, then I will change my opinion, and I might say, let me give it a go, because we build on our collective experiences. So if you tell me, if Atul tells me, if Vatsal tells me, Preetam tells me, these are people who we value, whose opinion is very kind of sanctum sanctorum to us. So that helps, but obviously evidence-based is much better than evidence-based, hopefully. But I leave that on that.
Okay, great. Thank you. We should leave this discussion to the prime time. And and let's move on. Thank you so much, sir. It was a nice talk, and thank you, Karobi madam, for your inputs. And our next topic is lasers in PDR by Dr. Saili. Saili, are you there? Sorry, Madhu. Madhu, are you going in next?
Yes, Dr. Swapnesh, I'm there.
Yes,
Am I audible?
Yes, yes, yes. Please share your topic.
Yeah. Is the presentation visible?
Yes.
Just 1 second. Huh? Yeah, so I'm going to be speaking about this interesting case of retinal astrocytic hamartoma, and also kind of stress upon the point that something as humble as cystoid macular edema can sometimes, make you bend on your knee. So this is, I'm sorry, the slide is not moving.
Stop share and screen share again.
Unable to do that. Oh yeah, it started to move again. Fair enough. So financially, well, I don't have any disclosures to make. Giving a background of this patient, he's a 27-year-old healthy young male who had presented actually to one of our retina colleagues in May 2021 with the chief complaints of floaters in his left eye. He was diagnosed to have retinal astrocytic hamartoma with an inferior branch retinal vein occlusion and neovascularization elsewhere. These are the fundus pictures which were available with the patient. A montage of the right eye, which looks essentially normal. The left eye shows an irregular mulberry-shaped tumor along the inferior major blood vessels. This is the angiogram that was available. It shows diffuse leakage from the tumor area and also petalloid pooling at the macula, suggestive of cystoid macular edema. So initially when he presented, he had vitreous hemorrhage and underwent scatter laser photocoagulation to the retinal periphery beyond the area of the tumor. The tumor was not lasered at that point of time, according to whatever the reports were available with the patient. However, the floaters kept increasing, and the patient also complained of progressive blurring of vision. His record suggested that he had cystoid macular edema at that time and underwent Razumab injection on 20th June 2021. After his first Razumab, he did get better, and he received one more injection in August for the recurrent CME and underwent one more session of laser on 3rd September 2021. Now, between September and December, no follow-ups were available because he had fever, probably COVID, and he was telephonically advised topical Nepafenac during that period of time. At his first visit to his primary doctor, he was again diagnosed to have recurrent vitreous hemorrhage and cystoid macular edema, and he was advised either an Ozurdex intravitreal or anti-VEGF plus steroid combination. At this point of time, he probably was not very comfortable and he decided to take a second opinion with us. So the first thing we did was systemic evaluation, because astrocytic hamartomas are very commonly associated with tuberous sclerosis complex, though he did not have any systemic features or systemic complaints. At presentation, his best corrected visual acuity was 6/6 in his right eye and 6/12 in his left eye. Fundus examination did not reveal anything significant in the right eye. The left eye continued to show the astrocytic hamartoma. This is a montage picture of his left eye showing a very characteristic, mulberry-shaped tumor with typical sago grain-like appearance of the intratumor calcification. We can also see the laser marks in the periphery of the tumor. This is an OCT passing through the lesion. It's actually a raster line passing from inferonasal towards the fovea, wherein the left of the image shows the classic hamartoma lesion. and the upper part or the right side of the scan shows typical cystoid macular edema. The systemic evaluation, including MRI of the brain, ultrasound of the pelvis, did not reveal any other lesions, and a physician evaluation was also sought, but it did not show any systemic features. We diagnosed him to have sporadic congenital or acquired retinal astrocytic hamartoma. And because he had previously responded to Razumab, we decided to continue with the same treatment. After injection, his visual acuity improved. There was a very good response to the injection with complete resolution of the cystoid macular edema, and the visual acuity did improve to 6/6. However, as time went by, the macular edema kind of reappeared, and because he's a young chap, I thought, let me just try out if he responds well to topical difluprednate and steroid. Now, this was his OCT. The left of the OCT is post Razumab. The right side shows the recurrent macular edema. This is after 2 weeks of difluprednate and topical Nepafenac, which shows reduction in CME. And this is at 4 weeks post difluprednate plus topical Nepafenac. So he does respond very well to topical difluprednate as well. But again, I have some concerns regarding long-term use of difluprednate because he has a clear lens and he might, have steroid-induced glaucoma. So we decided to perform an angiogram this time and see if any alternative treatments could be offered to our patient. This is the angiogram. This is a very early phase before the dye has actually come into the fundus, showing autofluorescence from the tumor. This is the early phase showing diffuse filling of the tumor and window defects as seen in the laser areas. And this is a late phase showing a diffuse leakage from the tumor and the typical petaloid pooling suggestive of cystoid macular edema. So my concerns were, now he's a young 27-year-old chap. Should we continue anti-VEGF therapy? If yes, then do we follow some regimen or treat him as required? Do I treat him with steroids? Do I plan some other form of therapy like direct thermal laser or photodynamic therapy? Again, cryotherapy is not an option for him because the tumor is very close to the optic nerve. For the same reason, plug brachytherapy is going to be out of question because that would have much more complications as compared to anti-VEGF. And oral antimetabolites were again, they have serious adverse effects, and therefore they are not really applicable for him. So these were the basic concerns. I just quickly go through what RAH is all about. So it's a hamartoma. Basically, it's a normal tissue which is outgrowing in its place. The most common association is a tuberous sclerosis complex. These are the ocular features. So apart from an RAH, they can have poliosis, chorioretinal colomas. Systemic features include skin lesions, neurological and other organ disease like cardiac and renal. Major criteria would be, the skin lesions predominantly, and definite TSC diagnosis needs 2 major and one major with 2 minor criteria. So you could have 2 types. One is a relatively smooth tumor without calcification, and type 2 is a raised mulberry-like tumor with calcific lesions. Again, there is an OCT classification based on the cell density packaging, calcification, and the amount of void spaces. And it seems that the OCT classification does correlate very well with what systemic features can be present. So again, this is open to the house now as to what are the possible management options for our patient.
Thank you, Madhu. Excellent documentation of the case, I would say. Yes, I would invite everybody to give their comments. Karobi madam, Paritosh sir, Kopikar sir.
This is a lovely case that you presented. I mean, very unusual and very thought-provoking case. Only as a kind of offshoot from whatever like you're saying, is that how long has this patient been on difluprednate?
Difluprednate, ma'am, we gave him for 1 month. And he was doing well with difluprednate. He did not have any IOP spike or anything. But now my concern is what is safe. Now he's a patient who's getting reimbursement for his anti-VEGF injections, and he's been taking it for the last, say, from May, June 2021 till now. He's quite comfortable taking it, and one anti-VEGF injection for him works for about 8 weeks, 8 to 10 weeks. Now I need to weigh as to what is better, keeping him on difluprednate plus topical NSAIDs, which could theoretically be indefinite and expose him to a risk of cataract and probably steroid-induced glaucoma, vis-a-vis giving him an anti-VEGF, which kind of works for 12 weeks. He just takes an injection, goes back to his, routine job. In fact, I also shared these images with the group at Shankara, Bangalore, and they have a case report of TTD done for a similar lesion for an acquired RAH, and they've documented that the exudation and everything reduced with time. This patient is due to travel to Bangalore in April, actually. So he requested me to just give him a Razumab before he was traveling, and we already actually sought a consultation with MPS sir for this patient.
The reason why I asked you this question is that because when you had shown one picture where you showed both the right eye and left eye of the patient, there already is a CD ratio difference between the two eyes. So I was wondering whether I think you should investigate it from that point of view, either from the point of view of steroid, or maybe, it's like you have to investigate that angle. The second thing is that where treatment is concerned, your treatment was very good. But the thing is that if you want to couple an anti-VEGF with a laser, then the best form would be you couple your Razumab with either a TTT, or you couple your Razumab along with multiple sessions of laser where you're giving argon laser. First you surround the whole thing first, and then you give guided laser onto the surface of the tumor, but in divided sessions, not in one session. So I think that would be the kind of treatment which I might follow for this patient if the patient were to come to me.
I'm considering that the tumor has a lot of calcification, and it looks like a really friable tumor when I look at it. So my only concern is whether direct thermal laser, though it's even given in the as a modality of treatment, how likely is it to cause the tumor to kind of separate out and the calcification to kind of have seedings in the vitreous? Though it's benign, it's not going to cause any harm, but I'm just wondering whether I can create a retinal break at the edge of the tumor.
I don't think so. You surround it first so that there is no percolation from the sides, and then you attack it. But as I said, in limited doses, not as a very kind of a prolific kind of treatment that you give at one go. Just a few shots, maybe 350, 400 shots at one go, and divide it over multiple sessions. I would like Paritosh or Hemang to also, or anybody else who has treated this kind of patient, to also give their opinions. Ajay is also here.
I've had occasion to treat one, but that was sitting right over the optic nerve head. I was fortunate to get an opinion also from doctors Jerry and Carol Shields for that case. So basically, we were just managing it with injection of Ranibizumab and Ozurdex to prolong the interval of the anti-VEGFs. But of course, she was pseudophakic, so there was no risk of cataract progression, and we were monitoring the IOP. There was no glaucoma till she was lost to follow-up after about 3 years or so. So in this particular case, I would consider doing low dose multiple sittings of TTT. And I would continue giving the anti-VEGF for the CME, because as you all rightly pointed out, the risk of glaucoma and cataract progression, though with whatever has already been done, intraocular anti-VEGFs being injected plus the difluprednate for these few months already, he is going to develop a cataract at an early stage, but let's try to postpone it for as long as possible. So continue with anti-VEGFs at 8 or 10 weekly intervals as required, as he's getting recurrence only at that interval, and multiple low dose TTT is what would help in this patient, or rather one can give it a trial.
Yeah, I had treated a similar patient many years ago with a diode laser, red diode. Yeah. That time we had it at Ramakrishna, and there was no TTT. But he had even initially he had a exudative RD also. Then
Yes.
I was thinking it's an amelanotic melanoma, but I sent him to Tata, got him investigated. It was not a melanoma. Then I treated him with the diode laser, which Paritosh has now. And he still comes for follow-up. He's a security guard. And up till the lockdown, he was coming every time for follow-up. He is perfectly okay now. All the thing has settled down. So I think since you have already proved that he is settling down with the NSAIDs and steroids, and you have shown so much leakage on the FFA, you must give him, if you can give him a red diode, or Paritosh can give it. And I don't know, I have never done TTT, but I think I've treated it with the red diode. It has been good. And otherwise, if you are scared of using the green laser, you can do it with the red diode. You'll get a good result, and all that leakage will reduce. So, and it doesn't fragment. The tumor doesn't fragment.
Great. Very, very interesting case and very interesting thoughts. Madhu, keep us updated on what happens on that case.
Sure.
Ajay, any kind of feelers on this case?
Not really. Actually, I was thinking, sometimes these patients who have got, like your CMEs in patients with RP, I have used low dose Diamox and means drops which are there, like dorzolamide drops also you can work. You can add that.
Benzaldehyde also.
Yeah. See, the problem is that he's a young guy. How long will you give him all the systemic things, steroids and all? Go ahead with laser and do it. I think that would be the best option.
True.
Great. Our next topic is also uncommon uses of anti-VEGF. So we are going from uncommon to more uncommon things. Dr. Samya will be presenting that. Please share.
Can you hear me?
Yes.
Yes. And can you see my screen?
Yes.
Okay. Thank you so much, Swapnish. Thank you, Swapnish, BOA and MOS for giving the opportunity. I think this is by and large going to be a summary of most of the things that we have spoken. I'm just going to give a impartial glimpse of the literature that we have. These are the approved indications of anti-VEGFs, the neovascular or wet AMD, macular edema for retinal vein occlusion, diabetic macular edema, diabetic retinopathy, and myopic CMV. Now, let's go to some of the uncommon uses, but they are commonly known to us. For example, PCV. We know that anti-VEGF can be given at aflibercept, ranibizumab, with and without PDT, or it can be given as a monotherapy. Way back in 2007, the neovascular membranes other than AMD and the myopic CMVs were, they were discovered to be responding well to the Bevacizumab. And now it is very recently published from a multi-centric study in the BJO 2020 that peripapillary choroidal neovascular membranes, they had about 77 eyes and followed up through 12 months. And they found out that all the anti-VEGFs, they lead to a good improvement anatomically and functionally, irrespective of the etiology of the AMD. For example, inflammatory CNVMs. If you see that they also respond well to the anti-VEGFs, but they are used as an adjunct local treatment. The primary treatment of the inflammation should not stop, and additional immunosuppression, if warranted, is also required. The other uses in uveitic cases would be inflammatory branch retinal vein occlusion, of course, as an adjunct with the laser photocoagulation. Exudative choroidal granulomas these cases also have found to respond well to the anti-VEGF treatments. And very recently, optic nerve head granulomas also have been, responding well. But the caveats are simultaneous treatment to the primary pathology is very much required, and anti-VEGFs can be used as adjunct wherein required. Retinopathy of prematurity, yes, they've been using for quite some time now, and there are a lot of publications regarding these as well. We discussed about neovascular glaucoma at the start of this session. Yes, they respond well. In fact, the intraocular pressure also reduces in a quite significant percentage of cases. But we don't have, we don't know about the long-term effectiveness of these anti-VEGF medicines. There is no known protocol for giving, but yes, they're used in neovascular glaucomas. Like we've seen what Dr. Anand Subramaniam said, that pre-treatment prior to vitrectomy for diabetic retinopathy, yes, excellent clinical outcomes and reduces the intra and post-operative complications. So these are the commonly known changes. We also have seen Dr. Jaideep, who presented subretinal hemorrhages, and we can use them as an adjunct with the gas tamponade or intravitreal TPAs. And let's go to some uncommon uses that are not very commonly known to us: retinal arterial macroaneurysms. And it was reported way back in 2010 that it responded well to Bevacizumab. We have a current meta-analysis in 2022 that they have a good closure rate and a better prognosis with anti-VEGF treatments. And some of them are reported about close to 98% closure with anti-VEGFs. Of course, these are not the treatment of choice. Laser also is a treatment of choice, and they have to be titrated or combined when they give treatment. IRWAN or idiopathic retinal vasculitis, aneurysms, and neuroretinitis. There are reports where the exudation has also responded due to a lot of VEGF being eluted in the eye. So they are used in advanced cases where there is a lot of edema or hemorrhage. Vasoproliferative tumors. Because vasoproliferative tumors can have a lot of exudation and retinal neovascularization. They have reported good results with anti-VEGFs. For example, there was a report where the VEGF was actually evaluated. The quantum of VEGF was really high. If you look at the quantum of VEGF was about 12,099 pg per ml with respect to the other RD patients, which was 2. So these will respond well to the anti-VEGF therapy. Peripheral exudative hemorrhagic chorioretinopathy or PEHCR, they also have reported that due to the anti-VEGF therapies, in addition to the photocoagulation, cryotherapy, and the other surgical interventions, they also respond well. Again, for radiation retinopathy, they has a good response to the radiation retinopathy, looks similar to diabetic retinopathy, and it is effective for stabilizing vision in about 80% of the patients. This is what the recent review of literature says way back in 2020. Again, it is now being also reported to have used to reduce the incidence of radiation optic neuropathy in cases of uveal melanoma. And this is a very recent publication. Again, it is an adjunct treatment to reduce the incidence of radiation-induced optic neuropathy as a prophylactic patient. It is now reported to be used in choroidal metastasis as well. And how they have thought so is that these tumor cells, when they migrate subretinally, they have these, they secrete these neovascular factors, which allow the supply of nutrients and oxygen. So they think that anti-VEGFs may be a good therapeutic option for patients. And in this article, they did report a few cases where it was helpful in reducing the exudation, but there are no clear guidelines as such. So these are a few summarizing the uncommon uses: the retinal arterial macroaneurysms, IRWAN, retinal vascular tumors. We've seen Madhu just spoke to us about the concomitant macular edema with the retinal astrocytic hematoma, PEHCR, radiation optic neuropathy, and choroidal metastasis. A few of these are controversial: CSR or the central serous chorioretinopathy, because it's a self-limiting, but a secondary CNV which develops in an old CSR may respond well to anti-VEGFs. MACTEL, yes, with a secondary CNVM, but like we know that not every hyporeflective space, intraretinal space is a fluid, so it doesn't require an injection. It is basically helpful where neovascularization is there in the eyes and exudation, and we should all promote rational and scientific use of anti-VEGF agents. Thank you so much.
Thank you, Samyak. That was a very nice presentation covering very, very rare situations also. Karobi, madam.
A very nice presentation, Samyak. You detailed all the places where we could use anti-VEGFs, where you're at a dead end, you really don't know what to do. And the thing is that, have you used it in any of these uncommon cases in your scenario?
Yes, so I have used it in cases of
Can you
radiation retina.
stop the share, please?
All right, stop shares.
Yeah, that's it.
Okay. So I have used it in a case of radiation retinopathy. Myself, I have given 3 anti-VEGF injections. It looks very similar to diabetic retinopathy, and I was wondering if this is a patient of diabetic retinopathy. But we found out that he had received radiation to the brain for an intracranial tumor, and he turned out to be radiation retinopathy. Fortunately, it was a very milder version of the radiation retinopathy, not the one which is aggressive. And he did develop neovascularization, but he continued to maintain 6/6 visual acuity. So that's one of the cases where I have used. I have used it in a case of retinal capillary hemangioma, where as an adjunct, of course, as an adjunct to reduce the amount of macular edema, and a case of choroidal osteoma because he also had some exudation in the macula, but a single injection, and that helped reduce the amount of
You mentioned Mactel as being a controversial thing. Have you ever used it in a Mactel?
Not primarily.
Not
primarily, no. But if it's a secondary CNV arising from a Mactel over years together,
then
yes.
of course you would this.
Yes.
I have used this in a patient of a vitelliform degeneration, where the patient had bilateral vitelliform degeneration, but associated with cystoid macular edema. I mean, otherwise I wouldn't have used it, but it worked well on that also. Paritosh, any feelers from your side?
No, actually, I want to know about the use of. I'm probably letting the cat amongst the pigeons, but use of this amongst the ROP babies.
Yeah. What do you want to know about the ROP babies?
Oh, you have comments.
Yeah, of course. The thing is that anti-VEGFs are a used thing for these ROP children, and the thing is that some people use it as a monotherapy, and many of us like to use it with a laser as the primary standard goal of therapy. And if the regressions do not occur, then we generally resort to this as a kind of therapy to alleviate this problem. But a lot of people like to give it as a monotherapy also, and it works well, because the thing is that in patients who have this cases of APROP, basically where the neovascularization is just at half zone, or at the end of posterior zone 1, you have a lot of VEGF being poured in, because it's a 360 degrees involvement of the entire peripheral retina which is pouring in the VEGF. So there you give the injection as the first mode and let the eye stabilize a little, let the vessels grow a little, and then you can do your laser after that to compound it. Ajay is also here, so he also can give his opinion.
Actually, I totally agree with Karobi. Rather than keeping these babies on monotherapy in these AP-ROP, I am more erring on the side of using eccentrics now with the rainbow results coming. And after the injection, within 2 to 3 weeks, I laser them because they're still small enough and the media clears beautifully, pupil dilates, and that's the end of the story, rather than just keeping on seeing these big babies and see whether it's vascularizing or not.
Exactly, yes.
So I think the twin therapy or a combination therapy is the way to go, is what I feel.
Yes, it's like a dangling sword over your head.
Very true, very true.
If you leave them just like that, because
Totally.
many a times they don't vascularize to the periphery, and much later they can develop problems,
Very true, very true.
I mean, I've had 2 patients who had regressed ROP, means this was not in the area of era of anti-VEGFs, but 2 children who were just followed up. They had regressed ROP, but the vessels had not reached to the periphery. One of them developed neovascularization at the age of 12 years, and one of them developed neovascularization at the age of 16 years.
Wow.
So, if you don't keep a follow-up, then they can just bleed, and, the eye can be lost, that way. So it's better to finish it off at this and get your good night's rest.
Yeah. Samyak, and I think I liked your presentation a lot. One thing I've really used anti-VEGFs, which we see a lot of its patients, is Eales disease. I mean, it's really like, for Eales, it's the drug when you have a little mild hemorrhage and, it's not very easy to laser through that hemorrhage. You give them one injection, the media clears beautifully with steroids, and you can just go and blast off the rest of the laser. You can prevent the vitrectomy in such eyes. I've seen. So in eels, even central eels, it's like life-saving and vision-saving. So I feel that's one very important use in India of anti-aging.
It does work well.
Beautiful, it works. Yeah.
Yeah, I agree with you, sir.
Yeah.
Just one word for that. I was reminded of what Rajvardhan Azad had said about maybe 12 years ago. The anti-VEGFs are the Ganga Jal now.
No, but
everywhere.
But laser is still the Brahmastra, I would say.
That is the Brahmastra, no doubt.
True.
Great. So we move on to our next presenter. It is the innovator of the Mumbai retina scene, Dr. Ashish Ahuja, and he would be presenting on clinical pearls in management of diabetic macular edema.
A very good afternoon to everyone, and I thank BOA for providing me with this opportunity. Are my slides visible?
Yes, Ashish.
So we'll be discussing some of the aspects regarding diabetic macular edema. We have had some amazing sessions throughout the day discussing the application of anti-VEGFs in various indications. The persistent DME remains a challenge due to the extremely complex pathogenesis and the involvement of several different biochemical pathways in diabetic retinopathy. There is upregulation of several factors like angiopoietin-2, interleukin-6, 8, PGF, ICAM, derived factors, and other cytokines. And recently, retinal neurodegeneration role also is playing an effect. Pathways and several molecules, lots of more new anti-VEGFs coming up in the future, which will target various pathways. We have to identify these characteristics on the OCT and decide treatment accordingly. So in the early days, we used to rely on FFA to differentiate the type of DME into focal, diffuse, and ischemic. In focal diabetic maculopathy, we used to observe focal leak from microaneurysms, which could be lasered, anti-VEGF, and diffuse leakages. A grid laser with or without anti-VEGF used to be advised. And in ischemic maculopathies, usually the prognosis is very guarded. Patients would present with a vision of less than 6/60, and maybe after a trial of anti-VEGF, no further treatment should be advised. So it's important to identify, and we are now in the era of OCT angiography. So the use of FFA is reducing with time. So on OCT angiography, we can examine the superficial and the deep capillary plexus and identify markers of the increase in size of the FSZ zone along with irregularity to pick up cases of ischemic maculopathy. So we have to identify the type of DME in the patients which are presenting to us, whether it is more of inflammatory with more of hard exudates, which is causing the edema, where steroids will have a better role to play, or it's more of hypoxic and VEGF driven, where we see a lot of hemorrhages and cotton wool spots along with macular edema, where anti-VEGFs would be a better choice. So in such cases where we see a lot of hard exudates across the macular area, steroids will have a better role to play compared to anti-VEGFs, along with doing a focal laser as well in cases where we have succinate retinopathies, where we have hypoxic or VEGF-driven edemas. Anti-VEGFs usually give a good effect. So also there is an important role of starting statins in cases of DME with hard exudates. So there are several studies which have been published which have shown that oral statins help to reduce the amount of lipid exudation in the retina. It will help to reduce the treatment load in our patients. We have to remember it's a chronic disease, and our aim is to maintain a good quality of vision for our patients over the next several decades, and also minimize the retreatment and increase the treatment interval in between anti-VEGFs or laser, which we are advising. So even in patients with a normal lipid profile, if we are seeing hard exudates at macula, it is advisable and no harm in starting statins for these patients for 6 to 12 months, and it helps in reducing the exudate at the macular area. Also, we had discussed the role of glitter zones in the previous talks. So there have been studies which have been done which show that these glitter zones are a known factor to induce diabetic macular edema. They act on PPAR gamma receptors in the endothelial cells, and they are known to cause peripheral tissue edema in these patients, including macular edema. So if a patient is on glitter zones with macular edema, we can discuss with the physician and try providing an alternate treatment for our patients. So this will all help to reduce the amount of anti-VEGFs which we are giving and reduce the treatment burden. So it's always better to have a holistic approach. There is another interesting study where they noted that in cases where there is a cilioretinal artery, there was a higher prevalence of hemorrhages, hard exudates, and CSME in such eyes. If we compare bilateral, so the author speculated that the difference in the perfusion pressure between the retina and the choroid, perhaps in combination with substances brought from the choroid, could be causing such findings. So an asymmetrical DME, maybe the cilioretinal artery, if it's present unilaterally, could be a cause. So we have discussed about the indications of using anti-VEGFs in most cases, but there are certain cases where we have to be cautious in using anti-VEGFs, especially in cases where there are fibrovascular proliferations which have a focal or a multifocal point of attachment on the retina. It is quite detrimental. It can cause contraction of the fibrovascular proliferations and induce usually slit-like breaks along the blood vessels. So even in cases where there is a dense vitreous hemorrhage, better to do a B scan and then plan an anti-VEGF for such patients. If we notice presence of fibrovascular proliferations, it can induce a retinal detachment and usually is counterproductive. Also, the challenges in patients with a recent history of a thromboembolic episode like myocardial infarction or a stroke, I have discussed with neurologists also, and they would say that you can go ahead with due risk even at 3 or 4 months, but usually difficult to get a fitness from them. So such cases are always challenging to manage, and maybe we can explore the role of steroids or laser in some of these cases. And then in cases of macular ischemia, again, the anti-VEGFs would not help. So what to do when the anti-VEGF injection? We can do an FFA, look for CNP areas and do a peripheral PRP laser, or even there is a role of vitrectomy with ILM peeling in certain cases which are not responding to anti-VEGF. So we have to have a holistic approach, divide the management into ocular and systemic, good diabetes control, treating other risk factors like sleep apnea syndrome, controlling the lipid profile, doing carotid Dopplers, and the management for the ocular part, as we have discussed throughout the day, could be from eye drops to lasers, anti-VEGF, doing a vitrectomy, and last option would be doing a cyclocryo. So thank you for the patient listening.
Thank you, Ashish. Paritosh sir, your comments?
Excellent presentation. I just want to add one more thing, that the Accord study, it showed that addition of fenofibrate, it helps to clear up some of these deposits of hard exudates faster. So I have been, I don't prescribe it myself, but I request the physician to do it, and it does help. There are some conditions where they can't prescribe it. So it's best I leave it to the physician to take a call about it. I, in fact, have a few patients where I just brought about a good metabolic control. Statins and fenofibrate was given, and with just good metabolic control and control of the dyslipidemia, and of course local drops, the DME cleared up. So such things are also possible. Now I have a question open to the house, particularly. I would like to start with Dr. Kopikar and Dr. Karobi. Okay, all of us have heard about the glitazones. It's well published, etc. Now that was a very, very rare publication which the industry allowed to get out. Normally, with due respects, the pharma industry does its own policing, and it doesn't allow reports of side effects to come out into the open in our literature so easily. Now, I have been seeing a lot of these patients who are on some of the newer anti-diabetic tablets, and I have a feeling that some of them, although published literature over the short run says that they are good for in fact, they help to slow down diabetic retinopathy. But I'm not very sure. And only one basic science paper on some animal studies showed that, yes, one of these gliptins, that gliptin group could be, in fact, promoting macular edema. So have, others observed similar things? And what is their view?
Can I just interrupt 1 second? I know you don't want my opinion, but I'm going to take full credit for this. Because that first report...
Everyone's opinion is welcome.
No. Yes. The first report, I'm just going to take, this is some self-publicity. The first report on pioglitazone and diabetic macular edema was actually published by us. I'm the first author, last author on that paper in Diabetes UK. And it was the first time that ophthalmic image of an OCT became a cover page for a peer-reviewed journal, which is Diabetes UK, which has got peer, I think, index factor and, So I think you're absolutely right. Sometimes, you can't wait for a study. A single good case report can start this. And once we published that case report, then, other people got interested. Of course, ILO, etc., that did a lot of work on this. And now you have 10-year data. But ours was a very simple report where we suddenly found this patient who was very well controlled, suddenly getting diabetic macular edema, vision going down to 612, putting on a lot of weight and a lot of pedal edema. And when we spoke to diabetologists, they said, oh, this new drug causes a bit of edema on the feet, but it's so good for diabetes that we're okay to tolerate it. We just have to buy new shoes with a bigger size. And I said, listen, this could be causing edema. And we stopped it. And the proof of the pudding is in the eating. When we stopped it, she lost all that weight, lost all that fluid, macular edema came down. At that time, there was no antivirus just come in. So she didn't need laser. And at that time, I would have most probably given a steroid. And this is back in the UK. So you're absolutely right. I think, sometimes you notice something and you can kind of prove a temporal association and get that out. I think other people join you in, because when we published it, we got so many letters to that one saying, I have 5 patients, I have 20 patients, etc. So I completely agree with you. Sometimes if you wait for industry, it won't happen. But if you see something like this gliptin story, we can all work on it together and say, listen, if you see it, let me know. I'll put together a paper and we'll write it up. But the glitazone one is my claim to fame. After that, I did nothing important.
Congratulations.
There is one aspect which I would like to sort of emphasize on. See, many a times when we see the diabetic patient for the first time, we take a detailed history of what medications are going on, what kind of treatments are going on different kind of sectors. But the thing is that over a period of time, when we are constantly seeing the patient, we don't get into the nitty-gritties of their current treatment at that point of time. The important thing is to do that at every visit, because you don't know when the medications have been changed. Because if the diabetologist feels that the control is not good, he might change it. But if you don't document it, you don't know that a glitazone has been put. He could be getting macular edema for which you are treating the patient without knowing that he's on a glitazone. So this is a small kind of a caution which everyone should exercise when they are seeing their diabetic patients.
I agree with what Karobi says, but I generally check what medications they're taking every time they come. And the second thing is that I have had many patients who were injected with Ranibizumab, etc. And after 3-4, they came to me. Then I found that they were using glitazone. That was long back, but I have experienced this. And I think I try to convince them to go on insulin if their eyes are not very good, because usually these people are reticent to start insulin. And that is why they give them all these other drugs, which we don't know what side effects they may have. So I generally persuade them, at least for your eyes, go on to insulin. And they are better controlled and they can be titrated well. And we try to reduce that block, which people have of taking the jab, that is.
Dudani, sir?
I don't have much experience actually, in seeing this, but I have not seen those many cases of macular edema due to this newer group of drugs, frankly. Maybe I need to look more closely.
Can we extrapolate this to even the blood thinners? Because these kind of group of patients with APLA or PCOD syndromes with obesity, associated blood thinners and uncontrolled diabetes, many a times they are just taking blood thinners and nobody has checked their INR levels. And once their INR levels are controlled, and if we reduce the dose of blood thinners, automatically the macular exudation also kind of responds better to the anti-VEGF drug.
True. There was, the ETDRS study had an arm which had the aspirin, whether they had tried out whether aspirin stopping reduces vitreous hemorrhage, but they found that it was safe enough. But these newer advanced drugs, which are like, which we're using, these heparin analogs, which especially I've seen patients who are on dialysis are using this, to prevent the clotting. So they have a higher incidence of vitreous hemorrhage I've seen. These patients will suddenly come with a vitreous hemorrhage, these patients who are undergoing dialysis. So I think what point you're laying is very true. The Eliquis and the newer drugs may be leading to a higher incidence of vitreous hemorrhage in PDR patients.
This becomes important in patients with, I feel, with CNVMs, particularly the PCV and the ARMD group, where I do request the physician to step down on the antiplatelets in disease.
Great.
Good point.
Super. So I think we'll move on to the last presentation, if I'm not wrong, which is by Dr. Kamal Dedia, and she would be bringing a fresh air of relief and changing the gears to RVO patients, so tachyphylaxis and switch in RVO patients. Dr. Kamal, can you please share your screen? Yeah, we can see your screen but can't hear you. There's a there's a small button icon below. Yes. Kamal, we can't hear you.
Now am I audible?
Yes.
Oh, so very good afternoon to everyone. I know this is the last session of the webinar. Thank you to BOA, Dr. Swapnesh, Dr. Preetam for giving me this opportunity. So we have already gone through anti-VEGF since morning in various scenarios, ARMDs, DMEs, then other rare scenarios where we use anti-VEGF. So this is the last presentation where I will be just highlighting the importance of tachyphylaxis and switching of anti-VEGFs in case of vein occlusion patient. So this is a case in which a 54-year-old female, known case of hypertension, diabetes since 15 years on medications. She actually had come for second opinion with history of diminution of vision in right eye since 1.5 years and left eye since 3 years. Known case of primary open angle glaucoma in both eyes since 10 years and on anti-glaucomatous management on travoprost, dorzolamide and timolol eye drops. Already diagnosed elsewhere as right eye inferotemporal BRVO with CME. So in 2020, she had already undertaken intravitreal Bevacizumab injections, 5 injections at monthly interval. Then in 2021, she again had diminution of vision when OCT was performed at other place and she was advised to switch over to Ranibizumab. So she had come over here for second opinion because already she had taken 5 injections, and left eye, the vision was very less because she had old CRVO with advanced cupping and she had not taken any treatment for left eye. Both eyes, laser had been done when she came to us. On ophthalmic evaluation, The best corrected visual acuity in right eye was 636, left eye was finger counting close to face. Pressures were pretty under control with all the anti-glaucomatous management. She had nuclear sclerosis in both the eyes. Posterior segment, both eyes had glaucomatous disc with some laser marks. Both eyes, left eye PRP 2 to 3 sittings were done, and right eye sectoral laser had been done. And her pressures were under control since past 8 to 10 years with topical medications. So this is when she presented to us. Right eye, as you see, there was a significant macular edema with a neurosensory detachment. Left eye also showed intraretinal macular edema. So we convinced her and to take a Ranibizumab injection at monthly interval for at least 3 months, and then depending on PRN basis. So this is a picture in October after August, September, after 3 consecutive injection. Although the macular edema had gone and her vision had improved from 636 to 618, there was still slight retinal thickening. So we said that we repeat the OCT in November. If the macular edema comes up, she might require 1 or more injections of Ranibizumab. So this is in November when she presented. As we see, the macular edema had come up again. But the patient wanted to wait for 1 more month as she was not convinced and she did not want to take more injections. So in December, again the edema had increased. Finally, we decided to give 1 more Ranibizumab injection. Post Ranibizumab injection, the edema had increased all the more. This time the Ranibizumab did not work after the 4th injection, and left eye also edema was in, and big cyst had formed. So we tried to convince her that she'll have to change the molecule. She might be developing tachyphylaxis because after the 4th injection, the edema had in fact increased and her vision had dropped to 660, and that was the only seeing eye. Or because left eye already the vision was finger counting close to face because of optic atrophy. So patient was convinced, and in February we gave her Ipcv. We gave her options of both Idea and Zeltrap, but because of the financial aspects and need for further multiple injections, she opted for Zeltrap. So we injected Zeltrap in February, and this is after 1 month of Zeltrap injection. Right eye edema had totally gone away, and her vision had again improved from 660 to 624. In left eye also, we convinced her to take injection because the cataract was increasing in left eye. In future, she might require cataract surgery. So after Zeltrap injection in left eye, the big cyst had disappeared and very little edema was left. So this is the final in March, just recent pictures after 1 month post Zeltrap injection. So this is before Zeltrap injection in January, and this is in March post Zeltrap injection. So just to summarize, the patient had already received the right eye Bevacizumab injection in 2025 injection, following which she was counseled to take Ranibizumab injection. After 3, she had responded to Ranibizumab injection 3 injections, but after 4th injection, the edema increased. She stopped responding to Ranibizumab. That is when we counseled her about the tachyphylaxis and to change the molecule. Ozudex was an option, but since she was one-eyed and she had open angle glaucoma, we didn't want to put her on Ozudex. So we counseled her for Zeltrap injection, and she responded well to Zeltrap injection with visual acuity improving from 660 to 624. So this is just the studies which everyone has presented since morning. For vein occlusion, Ranibizumab was the first one to get approval in 2013, which was based on Bravo study, and then Shore study came up, in which they said that PRN injections were better compared to monthly injections for 12 months. Then came in Ipcv, which got approval based on the Vibrance study. Then there was Marvel study where Bevacizumab and Ranibizumab was compared for vein occlusions, and both were found to be equally effective. So the tachyphylaxis, since morning we have been hearing, is a known phenomenon where we need, after a few injections, the patient stops responding and we need to switch over. But tachyphylaxis has been studied in ARMDs and DMEs. There are very few data for vein occlusions in which tachyphylaxis have been studied. So there are various studies like that the pharmacodynamic tolerance means increased expression of VEGF due to increased macrophages, increased expression of VEGF receptors, change the signal transduction. So in order to reduce this, either you increase the dose of the intravitreal drugs which you are injecting, or shorten the interval, or pause the treatment, or combine different drugs. Anti-VEGF could have been combined with steroid in this case, but because of glaucoma, we did not combine it, because vein occlusions, we know that steroids work better because the pathogenesis could be inflammatory. So the rationale for just switching over the drug was different modality, because the different pharmacodynamics of Ipcv and Ranibizumab. These are just the few studies in which switching treatment from Ranibizumab to Ipcv in macular edema secondary to branch retinal vein occlusions have been studied. These are just 3-4 studies in which they have found Zeltrap or Ipcv or Eylea to be more effective when one develops resistance to Ranibizumab or Bevacizumab. Thank you for your patient hearing.
Thank you, Kamal.
Thank you, sir.
Paritosh, sir, your comments on these recurrent edemas in CRVO and BRVO.
Yeah, I think it's all related to systemic control and probably something in our genes and receptors. We seem to be having more this kind of dependence developing. So I'm very eagerly awaiting Faricimab, where the angiopoietin Ang2 part also, that part stabilizes the vascular instability, and this one, the other part attacks the VEGF-A. But I can only, re-emphasize the role of good. For RVOs, it's mainly hypertension and dyslipidemia, which are the main systemic things to be addressed. So some of these patients will do well to do, periodic 24-hour ambulatory BP. And the other thing which I've been noticing in some of my patients is sleep apnea. I mean, rather than, because they're already hassled with the trouble of going to different doctors and the costs involved, I use a very simple thing. I ask the next of kin whether this person snores in sleep or not. Usually the answer is that, yeah, very rarely. So I know that, yes, snoring is there. So I tell them to use a simple wedge pillow at night so that there's a gradient where they sleep. And then I tell them to sleep on the right or left side. And only patients who, despite using a wedge pillow and sleeping on the right or left side, they continue to snore, then those would require sleep apnea studies and the CPAP, BiPAP, whatever is indicated. But the correction of sleep apnea also helps a lot in all these vascular retinopathies.
Sir, like how our glaucoma consultants usually keep advising against night antihypertensives.
Yes.
Is there any role
yes.
in
nocturnal hypertension? Very good point, Swapnesh. So it's not only potent antihypertensives, but even the anti-prostate drugs which block the alpha-2 receptor. So they also cause hypotension. Naturally, also there is hypotension in sleep. These agents will cause a more profound hypotension, and which will affect the perfusion pressure and hence the perfusion and increase the ischemia. So thank you for bringing up that point. Very, very valid point.
Karaboi, madam.
The only thing I wanted to add was, like, see, in the use of anti-VEGFs, not only for RVOs, for any other indications, you have to be sure whether you're using the right anti-VEGF for the right condition, or it is a tachyphylaxis. So that is a difference which you have to establish, because if you are using the wrong anti-VEGF, suppose say there is a PCV patient and you're using Bevacizumab, we don't expect it to give that kind of improvement what an aflibercept or zivaflibercept or a brolucizumab would give. So you have to be sure of what you're using,
Kopika sir, when is the right time to start sector laser for BRVO or PRP for CRVO? When is the correct timing? How do you space out these sittings?
See, in this vein occlusions, generally I treat with laser only for any naive patients who are not injected and whom I have followed up and I have identified that they have now developed proliferative retinopathy. Otherwise, those who have been injected are always masked. I can never tell what is their level of, are they in a proliferative state or are they going to go or not? I can never predict it. So I'm very cautious in entering into these patients because I cannot say what will happen. But those who are my patients from beginning, I think that BRVOs, if you have to treat them, the problem, the pitfall which happens is where is the watershed zone you have to identify. And you will be surprised at the vast amount of watershed zone for even a superior temporal vein. So unless you treat all that area, which is at the watershed area, you will not get a good result with the laser. And you have to ablate completely. That sector has to be fully ablated. Otherwise, you won't get a good result. As far as macular edema is concerned with retinal vein occlusions, I always tell my patients is the first thing to come when the vein occlusion occurs and is the last thing to go. Whatever you do, whether you give injections or whatever, as long as that vein is blocked or whether there is a clot in the central vein or in the branch vein, till that block is relieved, the macular edema will keep coming or will persist. Those who are not having too much of macular edema and who have developed proliferation sectorally, they do excellently well with laser. And I treat them thoroughly and people have retained 6/6 vision also without any problems, with documented new vessels present and all of them regressing. So I am otherwise very cautious in doing laser for any macular edema also of vein occlusion. I tell them that it's not going to work well, and that I tell them if they wish they can go for injections, or if they don't wish to do anything, control all your medical problems, look after all the means rare things like sleep apnea or anything, check for all of them, control all that, and let the disease take its natural course. Because whatever Haire has studied of natural course, that also says that everything sometimes settles down with time. So that's their option. So that is what I practice.
So please, this is one of the situations where an FFA is absolutely necessary in the declining kind of indications of FFAs these days. This is where you know the exact watershed zone, and generally the clearance of the hemorrhage means you can wait up to about 3 months and then do the laser in that particular area, or if it has cleared earlier, you can treat it earlier also. But I just wanted to know from anyone, like, what do they feel about the use of Ozurdex for RVOs? And like, if somebody has used it extensively, what are their reactions to the use of Ozurdex for RVOs?
So it works very well, actually, Ozurdex, but you have to actually be very sure, especially in CRVOs. I use initially and I burnt my fingers. If it's a ischemic CRVO and you put a Ozurdex, the macular edema will go, but the VEGF is not getting neutralized at all, So that patient came back to me with neovascular glaucoma. So if you're using Ozurdex in patients with an ischemic CRVO, jolly well do a laser on him. That's what is the takeaway. But for BRVO, it works beautifully because there's no global ischemia. And that typically that drill lesion which you showed, if the patient did have glaucoma, I would have injected Ozurdex in that patient, rather than switching. It would have worked beautifully.
And you would prefer to inject it early in the course of the block, right?
Yeah, but actually what I do when there's extensive hemorrhage and if it's a ischemic type of a BRVO, I would first do anti-VEGF and then, to tide over the VEGF surge. And then in the later phase, after a couple of injections, if I feel that still the macular edema and the hemorrhage are not clearing, is when I'll switch to Ozurdex. I usually don't use it in the first case of ischemic vein occlusions, because there I feel the VEGF is the primary driver. And as per, I think just one point on Dr. what Kopikar said about laser, I feel that you'll be very careful when you're doing macular laser in these patients. It might not work as Sir said, but never, laser the other side, the normal side, because that is where the collaterals are coming. Normally, if you see, temporal to the macula, you have these vessels like the irmas, which are joining the ischemic and the normal area, So I always try to do a very little mild focal laser within the arcades, but in the side of the vein occlusion. Not on the other side at all by mistake also, because that's where the irmas are joining and providing collateral circulation.
Yeah, these are called the interhemispheric shunt vessels.
Yes, correct, sir. And they're very visible, if you see them clearly.
And even you will find them on the periphery and you will get a rope ladder-like appearance between two vessels. I have shown them in my lectures also. I have shown the pictures also.
Yes.
I have just one comment about some of these eyes, especially the eyes with central retinal vein occlusion. So before they go into the full-blown ischemic kind of a thing, they start off with few hemorrhages scattered all across. Now, those are the cases where I think just good medical management and management of risk factors can turn this eye around. I've had several such eyes where we didn't do laser, we didn't do any anti-VEGF injections into the eye. Just good medical management has been able to turn these eyes around. So we need to, always keep this at the back of the mind.
Yeah, exactly. That's what the first thing I send them to the physician and get, because it's a systemic disease. CRVO is a systemic disease. It's not a local disease.
Great. I think with the permission of the experts, can we declare this session close? And I would pass on the mic to Dr. Rajesh Joshi, sir, for
great job. But Swapnish, I must say that you've done a great job here to anchor. Like you're like, Sachin, this Sunil Gavaskar, you're like, first ball say last ball tak you're there.
Anyway, God bless you.
Because double
century हो गया तेरा तो
ये डबल सेंचुरी मार दिया है, कब से सुन रहा है नॉन स्टॉप दैट आल्सो
आई नो खाना वाने भी नहीं खाया मेरे को लगता है खाना खाया तू
हां नहीं यार
खाया
Swapnish, I would like to make one comment before Rajesh takes on.
Yes.
At this point of time, I would like to profusely thank Saili for being absent because it gave us 10 minutes of reprieve.
Anyway, just concluding remark from me before Rajesh takes over. Excellent webinar, very well organized, very well picked up topics covering the whole gamut of anti-VEGF, and the way he has carried on the discussion and the panel discussion, very informative even for the general ophthalmologists. So the way you have taken it, this thing, today's webinar is fantastic. Over to you, Rajesh. Thanks, Swapnesh, BOA, Dr. Preetham Samant, Dr. Ragini Parikh ma'am, and Dr. Lahane sir. A very nice webinar. Of course, the whole credit today goes to Swapnesh, I think, 100%.
Thank you.
That was really a wonderful webinar. In fact, I would say it was really wonderful for everyone, general ophthalmologist as well as retinal specialist and everyone, I suppose, because our residents were also attending. In fact, I was taking exam, MBBS exam. So I was in between the switching off from exam to CMA and all, something like that. So, but just we ended our exam. I thank BOA for this opportunity to MOS, of course, and all the experts, Dr. Natarajan sir, Dr. Atul Sekar sir, Dr. Vatsal Parikh, and all the presenters. I'm sure today's webinar will be helpful to everyone. And thanks to Swapnesh, Dr. Sumit, everyone, Dr. Preetham, and all the office bearers of BOA for this wonderful webinar. Thank you so much.
Thank you. Thank you, Kopikar sir, Karobi madam, and Paritosh sir for valuable inputs, and Dudani sir for being the man of the match. He is there since the start. Thank you so much.
Very nice.
Swapnesh,
Tomorrow,
very nice. And let me congratulate you on a wonderful innings for the last 2 years. You've done a fantastic job.
Yes.
Thank you, ma'am.
Yes.
Yeah, this is the last of the CME. I told in the morning only that it's going to be fantastic. The way he led it right from the front. Very good. Tomorrow we are leaving for Phuket and Krabi, the MOS trip.
Have fun.
So we'll be seeing, we'll be seeing you all on the 4th now.
So post some pictures.
Sorry?
Yeah, with bikini clad girls.
Yeah, we'll be posting it, absolutely.
With bikini clad girls, huh?
30th, we have a conference also at Krabi.
Jignesh, post pictures with bikini clad girls.
Chalo,
bye everybody.
Bye.